So procedures, no history of previous blood transfusion, no history of drug or food allergy.
Okay, you go back to your first slide. What are the salient features from the history
So
you have observed?
there's painless progressive jaundice, sir. Painless progressive.
Painless.
Yes, sir.
Painless.
Progressive jaundice.
Progressive jaundice. Duration? Short duration or?
Sir?
Duration.
For 3 months duration, sir.
3 months duration. Go to next slide. You have mentioned there is history of clay colored stool only. Is there any history of high colored urine?
So his main chief complaints was yellowish discoloration of urine and eyes.
Okay. So, why there is yellowish discoloration in urine?
So due to excretion of excessive conjugated bilirubin in urine.
Why there is the
Sir?
stool is clay colored?
Due to the absence of stercobilinogen, sir.
Bilinogen.
Why is it absent in stools?
So there's absence, there's obstruction to the bile flow, sir. So there's no bile, doesn't enter into the in the small bowel and intestine, sir. So there's no formation of stercobilin. The conjugated bile
stercobilin is formed
by bacterial action, sir.
So bacterial deconjugation occurs in the intestines. So yes, that is why stercobilinogen will not be formed and the stools will appear clay. Yes. Previous slide, please. See, you have clearly mentioned that the jaundice is painless and progressive in nature.
Yes, sir.
Then why do you want to ask for history of waxing and waning type of jaundice? You are contradicting your own history. See, when the jaundice is progressive in nature,
yes, sir,
it is clear that there is a message.
Yes, sir.
Then why do you want to ask for history of waxing and waning type of jaundice? And what are all the causes for waxing and waning type of jaundice?
Periampullary carcinoma will produce waxing and waning type of jaundice.
What?
Periampullary carcinoma, sir.
Periampullary carcinoma. What do you mean periampullary?
Any tumors present within 2 centimeter radius of the ampulla is considered to be periampullary carcinoma, sir.
It is tumor arising from the
within 2
periampullary, that is ampulla of Vater.
Yes.
That is adenocarcinoma arising from ampulla of Vater, adenocarcinoma arising from pancreas, duodenum, and distal
CBD.
Distal
CBD.
Common bile duct. So these compromises periampullary. In these, if there is malignancy, you can get waxing and waning. Why?
So the tumor will grow and there will be slough out of tumors, sir. Initially, when the tumor grows and causes obstruction, there will be jaundice, and then there will be slough out of the tumor occurs, necrosis and slough out of tumor occurs, and in that period there will be waning of jaundice, sir. And when again it proliferates, there will be obstruction and it causes jaundice, sir.
Whenever the growth is present at the ampulla, it is also one of the component of periampullary carcinoma.
Yes.
Carcinoma arising from the ampulla of Vater.
Yes, sir.
So these tumors may slough out and bile flow will be re-established. Yes. So in such conditions, you will get waxing and waning type of jaundice. Yes, any other cause?
Intermittent jaundice in case of choledocholithiasis.
Yes.
You can get intermittent jaundice.
Okay.
In the next slide, you have mentioned about fever. In which condition you can get fever?
So in case if choledocholithiasis and there's associated cholangitis, patient can have fever.
If the patient develops cholangitis, the patient
can
will
have fever.
Fever, okay. You have also altered sensorium. Why you ask history of altered sensorium?
So in cholangitis, in case if patient presents with shock and Raynaud's pentad, then patient might have altered sensorium, sir.
Okay. Why you ask history of hematemesis, melena and bleeding per rectum in this patient?
Sir, there might be upper GI bleeding also can occur in case of upper GI bleeding can occur in case of periampullary carcinoma, sir.
Upper GI bleeding. What are all the causes for upper GI bleeding?
In case if the tumor erodes into the duodenal mucosa, you can get an upper GI bleed.
It's a theory. So hematemesis, if it occurs, you have to rule out cirrhosis with
biliary cirrhosis
in a jaundiced patient. Otherwise, melena can occur.
Yes.
What is the cause for melena? Jaundice.
In periampullary, when the tumor sloughs out.
So the tumor slough out to produce melena. So upper GI bleeding never occurs in a case of obstructive jaundice with the tumors as well as choledocholithiasis. Yes. So if you get upper GI bleeding in a case of jaundice You think of cirrhosis with the portal hypertension and esophageal varices.
Yes, sir.
Can portal hypertension can occur in jaundice patient, obstetric jaundice patient?
Yes, sir.
How?
Secondary to biliary cirrhosis, it can occur, sir. Or if there's invasion of the tumor into the portal vein and causing extrahepatic obstruction.
So in pancreatic malignancy can cause splenic vein or portal vein thrombosis. So secondary portal hypertension, which may lead on to esophageal varices and bleed. Number one. Number two, sometimes carcinoma of stomach with node in the portal hepatis can also cause obstetric jaundice.
Yes.
Bleeding from malignancy, that is gastric malignancy, can also cause upper GI bleed.
Yes.
Yes.
Apart from the sclera, what are all the other areas you look for jaundice?
Undersurface of the tongue, skin, palms and soles, posterior hard palate, sir.
In the sclera, where will you look for this yellowish discoloration?
Upper sclera, sir.
By retracting the upper eyelid.
Yes.
So otherwise you can't be able to differentiate a muddy conjunctiva.
Okay, sir.
So why this jaundice is visualized in the sclera? Why there is yellow discoloration?
So the
In sclera.
conjugated bilirubin has high affinity towards the elastin present in sclera, sir.
Good.
Personal history: consumes mixed diet, chronic smoker for past 30 years, 2 packs per day, occasional alcoholic, normal bowel and bladder habits, disturbed sleep pattern due to the presence of itching. Family history: nil significant family history. To summarize, Mr. Lingam, 41-year-old male, chronic smoker with no known comorbid illness, presented with painless progressive jaundice associated with itching, passage of clay-colored stools, loss of weight and loss of appetite.
Coming to general examination, after obtaining consent, patient is examined in a well-lit room in both standing and supine position, exposed from nipple to mid-thigh. Patient is moderately built and nourished. ECOG status 1, conscious, oriented, afebrile, hydration moderate. Pallor couldn't be assessed due to severe jaundice. Jaundice present, clubbing present, no cyanosis or pedal edema, no generalized lymphadenopathy, scratch marks present, no signs of liver cell failure. BP 110/80 mm of mercury, measured in right upper arm in sitting posture, pulse rate 88 per minute.
Why there is scratch? You have mentioned about scratch marks.
Yes, sir.
Isn't it?
Yes, sir.
Where you have mentioned about itching in history of present illness.
Due to that, yes, sir. Itching present, sir.
Chronic itching, okay. So scratch marks, in which area it is common?
Chest and abdomen, sir. Chest and abdomen, sir.
Chest and abdomen, okay. Then you have mentioned there is no signs of liver cell failure.
Yes.
What are the signs of liver cell failure you have to look for?
Sir, from head to toe, alopecia,
Huh?
alopecia,
Hmm.
and bilateral parotid enlargement, and spider nevate,
Gynecomastia.
gynecomastia, Dupuytren's contracture, palmar erythema, testicular atrophy.
If the patient is deeply jaundiced, the patient may come with whether the patient may go for encephalopathy. Okay. So there is no signs of liver cell failure. Okay. Scratch marks present. Then
Jaundice present. Pallor couldn't be assessed due to severe jaundice.
Yes. Make it fast.
Suppose the pulse rate is low, there is bradycardia. What is the reason?
Due to the deposition of bile salts in the SA node causing bradycardia.
Suppose if there is tachycardia, what will be the reason? That is more than 100.
The bile salts get accumulated in the glomeruli and causing renal hypertension.
It may be associated cholangitis may be present.
Very good. So in cholangitis, the pulse rate will be elevated. So that is the reason. So you have to ask for history of fever also. So that is a method.
Systemic examination. After obtaining consent from the patient, patient is exposed from chest to mid-thigh. Inspection. Abdomen neither scaphoid nor distended. All quadrants moves equally with the respiration.
See, you have to, whether you have to mention abdomen distended or not distended. What do you mean by neither scaphoid nor distended? You have to
What do you want to say?
So normal.
Normal contour of the
Normal
abdomen.
contour.
Suppose if it is obese abdomen, you can mention it.
abdomen not distended, all quadrants moves equally with respiration, umbilicus in midline, inverted.
All
Fullness,
quadrants mean? What are the quadrants?
so 9 quadrants.
Okay.
Fullness noted in the right hypochondrial region, no visible gastric peristalsis or visible intestinal peristalsis, no scars, sinuses, dilated veins, bilateral anal angle free, bilateral hernial orifice free, external genitalia normal, left supraclavicular fossa free. Palpation, not warmth, not tender, no guarding rigidity, globular swelling of size 5 cross 4 cm, palpable in the right hypochondrium and umbilical region, below the right costal margin, medial to the right midclavicular line. It moves with the respiration, and upper border continuous with the liver, mobile in horizontal direction, smooth surface with well-defined margin and soft in consistency. Liver is palpable 5 cm below the right costal margin, sharp edge, smooth surface, firm in consistency, non-tender. No other mass palpable, no other organomegaly noted, no renal angle tenderness, bilateral flanks free, no supraclavicular lymphadenopathy, hernial orifices free. Percussion, dullness present over the mass, that is continuous with the liver dullness. Liver span is 20 cm and no presence of any free fluid. Auscultation, bowel sounds present. Digital rectal examination, normal sphincter tone, fecal staining pale color, no mass palpable. Systemic examination, CVS S1 S2 head, no murmur, RS no normal vesicular blood sounds head, and CNS no focal neurological deficit.
You have described a right hypochondrial mass, isn't it?
Yes. Yes, sir.
What is that mass?
Sir, gallbladder.
Huh?
Gallbladder, sir.
Gallbladder mass. How do you say it is gallbladder mass? Why do you say it is gallbladder mass?
Sir, globular shaped swelling, globular shaped,
Globular swelling, okay.
moves with the respiration,
Moves with respiration.
upper border continuous with the liver,
Upper border,
continuous with the liver,
liver.
Side to side
side to side
mobility
mobilities,
Huh?
side to side mobilities.
Side to side mobility.
Yes.
Does it? Can you able to? Can you able to catch this swelling?
Sir, borders are defined, sir, but not that much appreciable.
How we elicit side to side mobility?
So palpating the.
Okay, okay. One more thing.
Yields on pressure.
Huh?
Yields on pressure. Cystic in nature and yields on pressure.
Okay. Whether it is intraperitoneal mass, you have to mention a swelling in the right hypochondrial region, intra-abdominal mass that moves with the respiration, and you mean to say it is continuous with the liver? Okay.
Yes.
Why not it will be a secondary liver?
Sir,
How will you, in other words, how will you differentiate a nodule in the liver and gallbladder swelling?
step signs.
Huh? How will you differentiate?
Step down.
What is step down sign?
Palpating the.
You have to carefully palpate the lower part of the
Liver.
Liver.
liver
It is
that
continuous
merges
down,
with the.
coming down.
Okay,
Coming.
this is the swelling lies below the margin.
Margins.
If it is a nodule, it lies over. It is called step up sign. It is step down sign. Okay,
Yes.
okay. So this patient is little bit obese, so you may not able to see. Gallbladder mass is well seen
Then felt.
than palpation. Before palpation, you may be able to see the gallbladder mass. Okay, globular mass, cystic mass. Okay, and does the patient have any tenderness?
No, sir.
What is Murphy's sign?
In case of acute cholecystitis, the patient is having pain in the right hypochondrium over the fundus region.
How
By
will you
pal-
elicit Murphy's sign?
You have to keep the thumb over the
In sitting posture, we
Thumb
have
of
thumb
The
of
left
the
hand.
left hand.
left hand.
Yes.
Patient in?
Patient in
Sitting.
sitting.
Patient in sitting posture. Patient in sitting
Patient in
posture,
sitting
you have to use your left hand, left thumb.
Left thumb.
What is mine hand sign?
we do the same thing in
In lying down position.
What is mine hand sign?
Sir,
Patient in lying posture, sir.
The same sign elicited
Same
in
sign
lying
elicited in
posture. For this you have to use right hand. These are some of the clinical scenario. Okay. What is mine hand's hump?
So due to the tortuous course of the hepatic,
Right
right
hepatic
hepatic artery,
These are some of the questions to confuse the confuse the students. Don't bother. Okay. Few questions are asked to assess your clinical knowledge. That is, approach the patient. 1/3 of the questions will be like that. 1/3 of the questions will be asked to assess whether you worked in the ward, and 1/3 only your subject. Okay. This is the way of conducting postgraduate examination. 1/3 to assess the clinical exam, how your approach to the patient. 1/3 to test whether you have worked in the ward sincerely, and 1/3 to assess your knowledge. Okay. Yes, proceed.
What are all the points to say that it is obstructive jaundice? Number 2, what are all the points to say that it is malignancy?
Painless progressive jaundice. Why obstructive jaundice? Because it is painless progressive jaundice associated with generalized dizzying and passage of clay-colored stools. So it is
Points.
obstructive jaundice.
You say it in a nutshell. What are all the points to say that it is obstructive jaundice? That's all. What is obstructive jaundice?
Any obstruction to the flow of the bile.
Requiring surgical intervention.
So we talk of only extrahepatic biliary radicals plus intrahepatic biliary radical obstruction. So that is obstructive jaundice.
Yes.
So what are the points to say that it is a jaundice, obstructive jaundice?
So painless progressive jaundice, sir. With the history of itching is there.
See, jaundice விட்டுரு பெயின்லெஸ் ப்ரோக்ரஸிவ் ஜாண்டிஸ் அப்படிங்கிறதுக்கு அது ஒரு மெலிக்னன்ட் காசாக கூட சேர்த்துக்கலாம். அதர் கொஸ்டின் செகண்ட் பார்ட் ஆஃப் த கொஸ்டினுக்கு அதை ஆன்சராக வச்சுக்கலாம். ஸோ இதுக்கு ப்ரைமரியாக என்ன? வாட் ஆர் ஆல் த பாயிண்ட்ஸ் டு சே தட் இட் இஸ் obstructive jaundice?
Passage of clay colored stools.
Yes.
Associated with itching.
Yes, sir is asking. Courvoisier, what is Courvoisier's sign?
Palpable GB with
Painless
painless
progressive jaundice.
Painless.
Progressive
jaundice with
jaundice.
palpable gallbladder.
That is, the patient is having Courvoisier's sign, isn't it?
Yes, sir.
So it indicates it is a malignant obstruction. What is Courvoisier's law?
In case of obstructive jaundice, if the GB is palpable, it is not due to stones.
Not due to
Stones.
letter of Padiyod Nipattu. Maybe due to.
Maybe due to malignancy.
What are the exceptions?
Double impaction of the stones.
Where?
One in the CBD and another in the pantry.
Cystic.
One in the cystic duct and another in the ampulla.
Hey. One at the cystic duct and another at the common bile duct.
Common bile duct, not at the ampulla.
Double duct impaction. It's a double stone impaction. One at cystic duct and other stone at the common bile duct. Yes, then?
Next.
Mirici syndrome.
Huh?
Mirici syndrome.
Mirici syndrome.
Mirici syndrome, okay.
See, law மாதிரி சொல்லணும். What are all the exceptions for this law? Number 1 is accepted. Double impaction of stones. One in the cystic duct, another one in the common bile duct. Next one.
Hyalocholangiocarcinoma. Klatskin tumor.
Oriental cholangiohepatitis.
Oriental.
Pancreatic duct stone obstructing the ampulla mater. Mucosilla, the gallbladder. இதனால தான் இருக்கு புக்ஸ்ல. Why do you want to confuse all these things? Why the gallbladder is not palpable in stone disease?
Because of the chronic inflammation, it may go for fibrosis.
So due to previous inflammatory fibrosis, the gallbladder will not be palpable in a jaundice due to CBD stones. Okay.
Okay, this is Courvoisier's sign is present. Any other thing? The patient is something, looks like hale and healthy. That is, he is not of there is no malignant cachexia.
Yes.
Okay. Yes? Any other finding? These are the findings you have suspected is a malignant obstruction. Then how will you proceed in this patient? What's your approach to this patient?
Hello, I am Dr. Muhammad Mustafa. I am old MBBS student of the Government Rajaji Hospital, Madurai Medical College. I did my MS in Madras Medical College. I worked in here in Department of Surgery under Professor Sivalingam and my surgical guide, Dr. BKC Mohan Prasad. I worked in Oncology Department along with Dr. V.K. Rajendran, along with Dr. V.K.C. Mohan Prasad and other colleagues, Bala Murugan, yesterday another Ramesh. Then after that retired from the service, I went to SRM. I worked in 10 years. And then I switched over to Kerala, near my native place. And I'm working there. Now the presentation, everything is between and asking questions from this side. My colleagues, the Professor Dr. Damodaran, he has done so many things to this department of surgery during his professor and other. And I am very much thanks to my Said sir, given opportunity in this stage. I am sitting here in the old student. I am very much, thank you very much for that, Said sir. Okay, now what is your name, doctor?
Pravina, sir.
Vignesh.
Pravina.
Vignesh.
Vignesh. This the fight between the only here two and another two. What about the others are sitting there? They have to participate. There is two-way traffic. There should be, they have to ask question, we have to ask question. Asking question is not that, it's a clinical demonstration. The topic of given in here, clinical demonstration, not the theory part. Postgraduate clinical demonstration. What are the clinical finding in this gallbladder? What is the physical finding of the enlarged gallbladder? Come on, tell doctor. Anybody from the state, whether you are going to tell or I am going to ask? Sir, Dinesh Kumar. Dr. Dinesh Kumar is here. I have seen this patient or not. Before you are coming here, you want to see the patient. Otherwise, no use of sitting here. Now, what is the difference between CAB in other colleges and the great Rajaji Hospital? Here you can see, after seeing that the headlines given by your HUD, Said sir, I am very much happy. CA penis I have seen very, 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 very rare. Once I have seen a SRM, that day is a holiday. Only one student of final year MBBS student is attending. That also female. She is from Muslim from Norway. She got a first rank in this batch. Because even though we have to take class for even a single student. That is the status of the private medical college. While working in a government college, he has seen a lot of cases here, especially in Madurai. We can Madras, we cannot see such cases anywhere in the world. Here you can touch and examine, you can commit any mistake. Here you can see all the cases here. And whether you see the Dinesh, you have seen the case before coming here? While coming and entering into this auditorium, I asked the postgraduate, where is the case? The 7th unit they told. They won't bring the case. The difference between previously, that Damodaran said, they used to keep the case in front. Okay, COVID, okay, Alhamdulillah, very good. Now, okay, at least please, all postgraduate, see the case. It's a very good opportunity. Please come before coming here. We have not seen the case. Anybody seen this batch? Obstetric jaundice. What is the name of the patient?
Lingam.
Huh?
Lingam, sir.
Neelam.
Mr. Lingam.
Mr.
Lingam.
Neelam. Anybody? No one. No one he has not. Only 2 of them have seen. Where this patient is in the ward or not?
Yes.
As in the heaven.
And what, sir?
Huh?
Ward.
Is now in which ward? Which unit?
Surgical gastro.
Huh?
Surgical gastro.
Very good. Please, after the class, please go and examine. Surgical gastroenterologist. 301? Same.
Yes.
We had.
Okay, very good. Same there. You go and see, please, at least, okay. What is any finding in the clinic? What are the physical finding of an enlarged gallbladder in this case? Can you able to tell? Come on, doctor. 1, 2, 3. That is the clinical demonstration, doctor.
Yes. Globular swelling, arising from the right
Gallbladder swelling whether you are seen or inspection or palpation.
palpation, sir. Inspection fullness only noted, sir.
You are not seen.
Sir, seen fullness only noted, sir. Couldn't be able to
Okay,
find the
it is
borders
it is a better seen.
than felt.
It is better seen. Gallbladder always better seen and better felt in superficial palpation than deep palpation. That is very, very, very important point. This once you are lose one point in postgraduate, they won't. That's Damodaran sir told correctly. One part for clinical examination. If you miss a one point, clinical exam is same for MBBS or 3rd semester, 7th semester, 9th semester, and also MS or assistant or MCH. Same, whatever may be the finding. Then discussion you can start any day, night and day, any medical college, you have to alert. You see cases there. Please. And you see cases touched with the patient, we use the gloves. You can see as a patient. You're familiar with them in the examination, how many minutes allotted for the long case?
45.
You know or not? How many months are there? Yeah, he is answering. They don't know how many minutes allotted for the examination long case. You don't know. We are facing how many months more for examination? How many months?
2 months.
When are you facing the examination final year?
May, sir.
Huh?
May.
April, May.
Yes.
How many minutes they allotted for the long case?
40 minutes.
40 minutes. 40 or
45.
45 minutes. That what you have to write. Whether write the case sheet or not.
Yes.
Then investigation and treatment is there or not.
Yes.
Then short case, how many cases they used to keep?
2 short cases.
2 short case. How many minutes allotted for short case? These are all the fundamental.
15 minutes.
Each case 15 minutes. Whether you have to write the case sheet?
No. Only positive findings.
Only finding. Okay. Now this long case, you have written the case sheet. What is the clinical finding of the physical finding of the enlargement of the gallbladder? Is a better felt superficial palpation, deep palpation. Then appearance of the beneath the tip of the 9th rib on the right side. You to explain, ma.
Yes, sir.
That is the useful way of explaining. And what is the ovoid? You told something, eh? What is the shape?
Globulars.
Huh?
Globulars.
Globular shape, smooth. What is the surface?
Smooth.
Smooth and moves with respiration.
Respiration. Yes.
Dull on percussion and cannot be feel the space between the lump and the edge of the liver. That you told. Okay, I am appreciate. Then, what is your points in favor of obstetric jaundice for this case?
The history of painless progressive jaundice with itching.
Painless progressive jaundice. Doctor, whether everybody is having notes, everybody having note or not? Painless progressive jaundice, number 1. Then,
History of itching. The history of clay colored stools.
presence of itching and scratch marks. Number 2, write the notes, ma'am. You are coming. That's the difference between other CME in other college, in Rajaji Hospital here. While I am working in Al-Azhar also, the assistants are attend use. They told that we attended the CME of Madurai. I am very happy. The CME was first started by T.S. T. Subramanian, Sadivan sir. These are golden days. Now the Karnaran sir and Dharmodaran sir and Syed sir, never forget. You can't see such a CME anywhere in the world. This you can see it in the YouTube. Yesterday I see in the YouTube. What is they were sitting and studying in home, coming and attending without seeing the cases. That presence of itching and scratch mark, presence of palpable gallbladder and malignancy. What? Last one. Weight loss.
Weight loss.
Okay. What is the definition of jaundice, doctor? What is fundamental? What is the definition of jaundice? Any medical college, whether you are telling or how to tell, ask somebody else's name. I got a list of postgraduate. What is the definition of jaundice? This you see, ask, these are all the examiners, they will ask the question. What is the definition of goiter? What is the definition of jaundice? That's the usual question, simple question. Jaundice is a yellow staining of the body tissue produced by the excess of circulatory bilirubin. This definition cannot be changed by any word or single. Jaundice is a yellow staining of the body tissue produced by excessive circulating bilirubin. Normal circulating bilirubin, how much?
Total bilirubin 0.2 to 1.2 milligram.
0.2 to
1.2 milligram.
1.2 milligram per dilation. The rise above 40 millimoles or 2.4 millimoles per liter. Okay, these are all the values. They will ask suddenly. Then you know, he told that how they change into heme, bilirubin, plasma protein and transformation, okay, conjugated, and they will ask that conjugated, unconjugated bilirubin. These are fundamental. Even for a bile pigment metabolism, matured RBC, destruction of 85%, and then RBC 15%, bone marrow, liver, and conjugated bilirubin bound to albumin in plasma blood through the kidney urobilinogen, liver cell microsomes, conjugated bilirubin, reabsorption from colon, that is stercobilinogen, through the bile salt and the extrahepatic biliary system reaches the duodenum down to the colon, that is stercobilin, that is clay color. These are all the fundamental, they will ask, then you run away, okay? The clinically, what are the other differentiating features? What are the jaundice? Hemolytic jaundice, infected jaundice, gallstone, obstructive jaundice.
Here the clinical finding is gallbladder, isn't it? Isn't it?
Yes.
Yes or no?
Yes, sir.
Whether there is any upward enlargement of liver, have you looked for? What's the liver span in this patient?
20 centimeters, sir.
How will you assess the liver span?
By
Where will you percuss?
From the second intercostal space, you have to percuss below downwards.
Okay, whether there is upward enlargement or not. Okay, don't bother.
Down.
Differential diagnosis for gallbladder mass.
Mucocele of the gallbladder.
Mucocele of the gallbladder, good. Then
Any periampullary carcinoma.
empyema gallbladder, cholangiocarcinoma.
Cholangiocarcinoma.
Okay, these are the differential diagnosis for gallbladder swelling. Okay, so what investigation would you like to do in this patient?
Routine basic investigation.
How will you confirm whether it's obstructive jaundice or viral hepatitis? First,
Serum LFT, sir. Liver function
LFT.
test, sir.
what is the significant?
They'll be elevated direct.
Which fraction will be increased in obstructive
Direct.
jaundice?
Direct
Make it fast.
Direct bilirubin will
Direct
be elevated.
bilirubin. Okay. So direct fraction is increased. Okay. Then next
ALP, alkaline phosphatase will be elevated,
will
sir.
be elevated. Why?
Because it is secreted by the biliary tract epithelium.
So there will
Because
be
there's
gross
obstruction.
increase in alkaline phosphatase. Okay. Then
There'll be GGT and 5' nucleotidase will be elevated, sir.
what?
5'
Gamma glutamyl
nucleotidase.
transferase.
Okay. Then
Then we'll see prothrombin time.
5' nucleotidase will be elevated.
Yes, sir.
Because if serum alkaline phosphatase is elevated, it favors obstructive jaundice. And why do you want to do this 5' nucleotidase?
So it can be elevated in other conditions also, sir. Alkaline phosphatase.
So in order to rule out bony abnormality elevation, you have to combine this 5' nucleotidase. What are all the points to say that it is malignancy? You have not mentioned.
So painless, enlarged gallbladder.
Okay, you proceed. How will you investigate?
okay. What investigation? You have done liver function test. Next investigation.
Coagulation
Coagulation.
profile.
Huh?
Coagulation profiles.
Yes.
After that, you have finished all
Blood
lab
image.
investigation. Next investigation.
Ultrasound, sir.
Ultrasound abdomen.
Ultrasound
Abdomen.
abdomen. What you have to look for in ultrasonogram? Abdomen.
Ultrasound will look for any intrahepatic
Huh?
intrahepatic biliary radical dilatation, then presence of cirrhosis, presence of stones in the CBD, stones in the gallbladder, any nodes,
The main thing
Status of
is
gallbladder.
main thing is ultrasonogram abdomen is the gold standard investigation for gallstone disease. Number one. Number two, you can assess the level of obstruction. You can assess whether there is intrahepatic biliary radicals dilated or extrahepatic biliary radical dilatation. Okay. Number two. Number three, whether the gallbladder is diseased or not. Thickness of the gallbladder wall and the caliber of the common bile duct. What is the normal diameter of the common bile duct?
6 to 8 mm.
Huh?
6 to 8 millimeters.
6 to
8 millimeters.
millimeters. So, if there is more than 8 millimeters, it indicates dilatation. Then, mass lesion less than greater than 2 centimeters can be picked up by doing ultrasonogram. Any other thing? Node in the porta hepatis. Node in the pattern. And any metastatic deposit in the liver. These are the things you can do you can see in ultrasonogram. So, you come to a conclusion that it is a malignant obstruction. Next investigation to be done to fix the diagnosis.
CECT abdomen pelvis triple phase contrast CECT abdomen pelvis.
CECT abdomen. What is the difference between CT abdomen and CECT abdomen?
Non-contrast CT, plain CT. CECT you take it in.
Any specific name? Pancreatic protocol.
3D CT.
That you have to I have specifically ask any next investigation to fix the diagnosis. This should be your answer. Pancreatic protocol CT. What is the difference between normal CT and pancreatic protocol CT?
Here we are taking 3 mm cuts in the pancreatic parenchyma. That better lineation and
what is the advantage of doing pancreatic protocol CT?
Why do you want to do a CT in malignancy?
Better characterization of the lesion, denilation of the lesion, any vascular
involvement.
So it better delineates the pancreas from vascular structures, especially superior mesenteric vein and the portal vein.
Vascularity. No. That is, you should assess the fatty plane. You can assess the operability.
Yes.
Okay, you can moreover stage the disease also, sometime approximately. You can assess the operability. Mainly, you can assess the operability. You fix up the diagnosis. Whether it is mandatory to do biopsy to prove malignancy in pancreatic malignancy.
No need, sir.
No. In which other malignancy you need not prove malignancy?
Renal cell carcinoma.
Renal cell carcinoma.
Gallbladder carcinoma.
Very good work. You have done CECT.
Suppose if the patient is inoperable by your imaging studies.
Then we have to confirm do biopsy and confirm the diagnosis, sir.
For that, what will you do?
We'll do an endoscopy, ultrasound.
ERC.
So any treatment other than surgery, whether if you are going for a radiotherapy or a chemotherapy, you have to confirm your diagnosis by doing a FNAC. So in this case, since it is a retroperitoneal organ, it is very, very difficult. So you can do with the help of endoscopic ultrasound or a CT guided FNAC.
Here the bilirubin is grossly elevating, isn't it? Progressive jaundice. Progressive jaundice. What are when will you do ERCP?
To confirm the diagnosis for this case. Sorry, sir. Generally speaking.
ERCP is nowadays meant only for therapeutic, not for diagnostic. Not for diagnostic. Okay. So when the bilirubin is more than 13 with comorbidity condition, if you are planning for surgery or palliative procedure, you can do ERCP and what is ERCP?
Endoscopic retrograde cholangiopancreatography.
What equipment will you use?
Side
viewing endoscope, sir.
Endoscopy, ordinary endoscopy.
Side viewing endoscope.
Side viewing duodenoscope. Side viewing duodenoscope. How will you do?
Through routine endoscope, we are entering into the duodenum, second part of duodenum.
Straight up duodenum. So you have to pre-operate, you have to prepare, you have to, as a PG exam, you have to overnight starvation, you have to prepare the patient left lateral under local anesthesia. For ERCP, you have to you have to give anesthesia. Ideal will be general anesthesia. Yes. Okay. So you have to prepare the patient for ERCP. Then what? After entering to the duodenum, what you have to do? You have to visualize the
ampulla.
We have to visualize the ampulla fat and see if there is any malignancy.
You have to introduce the guide wire and you have to introduce water soluble dye. These are done under fluoroscopic control. Okay. So you have to take biopsy. Okay. So to assess the operability, there is one more investigation as sir is told.
Endoscopic ultrasound. Endoscopic ultrasound.
UUS. What is the advantage of ultrasound, endo-ultrasonogram? What are the advantages?
Lesions less than 2 centimeter can also be picked up in endoscopic ultrasound. It can vascular involvement can be assessed and nodal involvement can also be assessed.
Can take biopsy from that.
Not vascular involvement, you can assess the distal CBD very well with the help of endoscopic ultrasound. For vascular assessment, CT is the investigation of choice. What is endoscopic sphincterotomy? You are doing a ERCP.
Yes, sir.
What is endoscopic sphincterotomy?
So through the endoscopy, we will make a opening at the sphincter.
Opening?
At the
Already
level
it is opened.
of dilate.
Already it is opening then.
To retrieve the stone or to take
cut is
biopsy,
made
if
at,
we have to dilate it, we can make
See, making a cut
In
at
the
the 11 o'clock position
position.
in the intramural portion of the CBD.
CBD.
Our purpose is to cannulate the CBD, not the pancreatic duct. So that is called as sphincterotomy. So to enter into the CBD.
One more question. In endo-ultrasonogram, the advantage is you can assess the
nodal,
parenchymal,
infiltration,
ductal, vascular anomalies. Parenchymal, ductal, vascular. One more thing, mucosal. 4 anomalies you can do. Usually there may be anomaly in the biliary radicle. Moreover, gastroduodenal artery. How many percentage there is a anomaly in gastroduodenal artery? 30? 36 percentage. So GDA. These are the things you can assess while doing endo-ultrasonogram, which will be more informative while doing surgery. Endo-ultrasonogram. So parenchymal, ductal, mucosal and vascular anomaly can be assessed by doing endo-ultrasonogram.
What?
Enlargement of the pancreatic duct and the common bile
Bile
ducts due to obstruction at the periampullary region.
Okay, suppose if the ultrasound shows dilatation of CBD along with the gallstones, what is the next line of investigation you go for?
Yes.
You want to go for ERCP?
We'll do MRCP, then confirm the diagnosis, then we'll proceed with
Yes,
ERCP.
you do a MRCP and confirm the diagnosis. What are the advantages of MRCP over ERCP?
You can go up to the proximal biliary radicals.
So
visualize
intrahepatic
the
biliary
entire
radicals can be visualized, which will not be possible or less with the ERCP.
Yes.
Even less than 4 millimeter stones can be diagnosed with the help of this MRCP. Okay.
What are the complications of ERCP?
Pancreatitis.
Huh?
Pancreatitis. Pancreatitis.
ERCP induced pancreatitis. Number 1. Number 2, cholangitis, ascending cholangitis. Number 3,
bleeding.
Number
From the
4,
parenchyma.
number 4,
Perforation.
retroduodenal perforation. It's common in endoscopy, ERCP. So these are the 4 complications, expected complication in ERCP. Yes, you have done ERCP. You have make a biliary stenting. Then the jaundice regressed. What will you do next? In this patient, you have done ERCP, stenting done, jaundice regressed. What will you do next?
And you have to correct the nutritional status before proceeding for
Nutrition. You have to preoperative preparation.
Preparation
You have
of
to
the
prepare the patient for surgery. What is the preoperative preparation you have to do?
adequate
Hydration, anemia,
adequate hydration.
You have to rehydrate the patient. Yes, then.
anemia correction.
Anemia correction, then.
If prothrombin time is prolonged, you correct it.
What will you do if prothrombin time is prolonged?
Injection vitamin K.
Vitamin
10
K,
milligram,
route
10
of administration.
10 milligram IM for 3 to 5
Can we
days.
give IV?
IM.
IV? What is the IV preparation available?
Vitamin K once.
Vitamin K is IM. Vitamin K1 is IV preparation. Okay. Even after 3 days, if profile does not come to normal, what will you do next?
FFP transfusion can be. FFP
Frozen
transfusion.
plasma. Okay, you have done all these things. Then next.
To correct the electrolyte abnormalities.
Corrected. Next. One more thing.
To give antibiotics prophylactically.
One more thing. What will be the, if the patient is having in a deeply jaundiced patient, what will he expect? Urine output.
Reduced
You have
urine
to
output.
adequately, you have to monitor the urine output. If the urine output is low, what you have to give?
Monitor.
You have to start dopamine in renal dose for output. Okay. Your pre-operative preparation over. Then perioperative. You have posted the case for surgery. What will you do next?
Operable cases, we do staging laparoscopy. In case-
Staging?
Laparoscopy.
Why do you want to do staging laparoscopy?
To
To
see
ass-
the,
To assess the operability, intraoperatively we can see, so it can be
Okay, to avoid negative, that is unnecessary laparotomies. If the growth is inoperable, okay. You have done the staging laparoscopy. If the growth is seem to be operable, what will you do next?
proceed with the
Proceed with?
Whipple's procedures.
What is Whipple's procedure?
Pancreaticoduodenectomy.
What are the, tell me in short and what are the maneuvers you have to do? First one is
Coccus maneuvers, sir. Cattlebrax maneuvers.
before coccus. What? Huh?
Cattlebrax maneuvers,
Before
sir.
coccusation, huh?
Cattlebrax maneuver.
What is it?
Right medial visceral
You have to mobilize
rotation of
the-
right medial visceral
Hepatic-
rotation of the hepatic
Mobilize the-
flexure of
Hepatic
the
flexure.
colon is mobilized.
Huh?
Hepatic flexure of the
Colon. Next one is
Coccus maneuvers, sir.
extended coccusation.
Coccusation.
What do you mean extended coccusation?
Mobilization of the second and third part of the duodenum along with the head of the pancreas till the left lateral border of the aorta.
Okay. Then next.
Then-
Kadaran solliya.
Intraoperatively also we assess the operability and see whether the plane is preserved between the, whether there's any vascular involvement is there or
Okay.
not.
Next one is portal vein.
superior mesenteric.
Superior mesenteric, tunnel of love. Whether the fat plane is preserved between the pancreas and the portal veins, sir.
What is tunnel of love?
At the neck of the pancreas, below the neck of the pancreas, the tunnel which is present between the pancreas and the portal veins, sir.
You have to
Insunate
create
the
a
fingers
tunnel.
from
Okay.
both sides.
So what is point of no return?
Once the pancreas is transected means you have to proceed with Whipple's.
Another?
You should not return back.
When
Once-
you are able to create the tunnel, then okay, you can proceed further. If you are not able to proceed, you have to
Drain.
Palliative.
huh? You have to abandon the procedure and go for
Palliation.
palliative procedure. Okay. So you are able to create a tunnel and you have resected. What are the structures removed in Whipple's procedure?
Distal stomach.
Distal?
Distal
Colon,
stomach.
stomach.
Distal stomach, duodenum, and 10 to 15 centimeter of the jejunum with head of the pancreas, common bile duct, and
Distal
gallbladder.
common bile duct.
Distal common bile duct,
These are the
gallbladder.
structures
Along
removed in Whipple's procedure. Okay. Why you are removing unnecessarily distal stomach and proximal jejunum? Your lesion is only in pancreas, isn't it?
So the procedure is called pancreaticoduodenectomy. So we are additionally removing the pylorus and jejunum. Why?
The pancreaticoduodenal artery will supply the distal stomach.
Part of the stomach. Gastroduodenal artery will be ligated, sir, and that will supply the distal part of the stomach. So
Good.
we remove the distal part of the stomach.
Okay. Why you are removing gallbladder?
As we are removing the ampulla,
Okay.
there will be no space.
Okay. How will you maintain the continuity
We'll do
after resection of the
How will you reconstruct?
How will you reconstruct?
pancreaticojejunostomy or gastrostomy, hepaticojejunostomy,
Pancreatico?
gastrostomy or pancreaticojejunostomy,
Okay.
hepaticojejunostomy and gastrojejunostomy.
What is the Achilles heel of this surgery?
Why?
Pancreaticojejunostomy. More
Illa.
chances of leak is there, so that is considered as Achilles
Oh, 1
heel.
minute, doctor. He has told pancreatico gastrostomy and pancreatico bar jejunostomy. Which is better?
Pancreaticogastrostomy.
Why?
Because the stomach has rich blood supply and
Stomach has?
rich blood supply.
Stomach is a highly
Vascular,
vascular
highly
organ.
vascular.
Okay, agreed.
And
Then?
the alkaline secretion of the pancreas neutralizes with the acid secretion of the stomach.
The acidic
Acidic
medium
nature
of
of
the
the stomach
gastric juice will neutralize the
neutralizes the
alkaline
pancreatic
medium.
juice.
Okay. So the pancreatic juice also will not be activated. Will not be activated. So it prevents pancreatic necrosis. So
Yes.
the chance of leak is very minimum in pancreatic, this study, pancreatic gastrostomy rather than pancreatic jejunum. Moreover, pancreatic jejunostomy, the ideal will be duct mucosal anastomosis. Duct mucosal anastomosis. This technique has to be expertise.
What is the sequence? What will you do first in the reconstruction?
Pancreatic gastrostomy.
Followed by?
Hepaticojejunostomy.
Followed by?
Gastrojejunostomy.
Okay. At how many centimeters or how many distance will you do this hepaticojejunostomy and gastrojejunostomy? I mean, yes.
15 centimeters.
So first you have done either a pancreaticojejunostomy or a gastrostomy. Then how much distance will you do this hepaticojejunostomy? Because
20.
we are all anastomosing it to the jejunum.
So 15 to 20 centimeter distal to that we'll do.
So 15 centimeters hepaticojejunostomy, 45 centimeters gastrojejunostomy.
If the growth is inoperable, what will you do?
Triple bypass.
What is triple bypass?
Cholecystojejunostomy, gastrojejunostomy,
Jejunojejunostomy.
Jejunojejunostomy and jejunojejunostomy. Triple bypass. If the patient is in a cachectic stage, you are not able to do any open surgery, what will you do?
Palliative stenting can be done to relieve.
Palliative stenting.
Stenting can be done. You have to use double stent. You have to stent
Both
the pancreatic
pancreatic
duct
duct
as well as common
common
bile
bile
duct,
duct.
and you have to use metallic stents.
Stent.
This is for inoperable tumor. So while doing ultrasonogram, you find a stone in the common bile duct. Stone in the common bile duct with the dilatation of common bile duct more than 1.5 centimeters. What will you do now? What's your diagnosis in this patient? While doing ultrasonogram in this patient, you find a huge stone in the common bile duct. What will you do?
More than 1.5 centimeter, we can go for a CBD exploration, sir.
Huh?
CBD exploration, sir.
CBD
Exploration.
exploration. Straight away you go for CBD exploration, or
We'll confirm with the MRCP.
What are all the treatment strategies for
what a treatment?
choledocholithiasis?
What is called? What's your diagnosis in this patient?
Choledocholithiasis.
Choledocholithiasis. What is primary stone? What is secondary stone?
Primary stone that is formed in the common bile duct itself, and secondary
Primary stone is formed within the common
CBD.
bile duct. Secondary stone is
from the gallbladder.
from the gallbladder. It travels
Descends.
into the common bile duct. What is recurrent stone? What is retained stone?
Retained stones, it's present within 2 years of cholecystectomy. Within 2 years of cholecystectomy is retained stone.
Okay.
Recurrent means more than 2 years of cholecystectomy.
Okay, then recurrent, retained,
Within
retained or missed stone. What does it mean?
Retained stone is present within 2 years
2 years
of cholecystectomy.
So you have confirmed it is a diagnosis as a common choledocholithiasis. How will you proceed?
We'll assess the duct size. If it is less than 1.2 centimeter, we can proceed with the ERCP and assess and whether the stone, if it's a single stone, we can do ERCP and try removing it and do stenting, sir. If the duct size is more than 1.2 centimeter and if it's associated with multiple stones, impacted stones, then we can do CBD exploration.
That is, if the facilities are available, you can do ahead with the laparoscopic
CBD
CBD
exploration and lap cholecystectomy. If facilities and gadgets are not available, you can proceed with open cholecystectomy and CBD exploration. After CBD exploration, what will you do?
after CBD exploration, we will keep a T-tube and
T-tube. Okay, what is T-tube? How will you place it?
sir,
How will you place the T-tube?
we have
How will you
to
place the T-tube?
by making a opening in the CBD, and we can keep that the
Already choledocholithotomy will be placed, so we keep it in the one wall, one limb of the thing should be placed in the normal wall. And
T
the
limb
other-
is placed in the common hepatic and the common bile ducts.
The distal
limb.
should not cross the. Okay. How will you management of T-tube? Post-operative management of T-tube.
in the
When
immediate
will you do cholangiogram?
So T-tube cholangiogram will be done on 5th to 7th day post-operatively to look for any retained stones. It will be shown as a
How
filling.
will you manage T-tube post-operatively?
Post-op T-tube cholangiogram. Post-op T-tube cholangiogram.
No, no.
Management of T-tube பார்த்தமே நான் சொல்றது புரியலையா?
You introduce a
Post
T-tube.
operative ஆல T-tube ஓட ஒரு patient இருக்கு. How will you manage the T-tube? க்ளோஸ் பண்ணி கிளாம்ப் போட்டு வச்சிருவியா, க்ளோஸ் பண்ணி வச்சிருவியா, ட்ரெயின் பண்ணுவியா, எத்தனை நாள் விடுவா, எப்போ விடுவா?
It is kept open, sir.
How long?
3 to 6 weeks. 3 to 6 weeks.
This shows that you have not seen.
3 to 6 weeks.
Till the output decreases, we will.
Wait. Allow the T-tube to drain continuously for minimum of 5 to 7 days. After 5th day or 6th day, when you start oral feed, you have to clamp the T-tube after every meal for 1 hour. You have to look for any pain or features of cholangitis. You can increase the duration of clamping. That means there is no distal obstruction. If there is no obstruction, then you can go after 7 days to 10 days, you have to do T-tube cholangiogram. And you have to look for dye should enter into the duodenum. If there is no obstruction, you can remove the T-tube. While doing T-tube cholangiogram, if you find a radio-opaque shadow in the proximal, what will you do next?
Through the choledocoscope, we can remove the stone.
Huh?
Through the T-tube, we can put a scope and remove the stone.
ERCP and remove.
Through the T-tube. Baileyல இருக்கு இந்த டெக்னிக்.
Berhin's technique, sir.
What is Berhin's technique?
Ask the patient to go, and after 6 weeks, once the tract is completely formed, after 6 weeks, we remove the T-tube.
Allow the T-tube to drain continuously for 6 weeks so that tract may be formed. Then you can remove the tube and you can introduce the choledocoscope through the tract. And you can extract the stone. This is called Berhin's technique. If the T-tube is in situ, if you find a lesion, you can also inject heparinized saline dissolution therapy. This is called heparinized saline. This will dissolution therapy. Okay. So this is the management of T-tube. Okay. This question is specifically asked for your work in the ward. Okay.
Yes, sir.
Yes.
When will you do choledochoduodenostomy?
Indications for choledochoduodenostomy after CBD exploration and stone removal.
When the duct is dilated more than 1.2 centimeter, we can
1.3.
1.3 centimeter. Or if there's any distal stricture present distally to the stone, we can do
Presence of
What is funnel syndrome?
Sir?
What is funnel syndrome? Funnel syndrome.
The indications for CBD, that is choledochoduodenostomy, sir has asked, that is multiple
Close
stones.
to that. Funnel syndrome. You come closer. So there is distal
stricture.
stenosis at the level of ampulla vater and the presence of a stone. So if you find these findings, you can go for a choledochoduodenostomy or else multiple stones in the CBD or intrahepatic stones.
Intrahepatic stones.
What is the complication of this procedure?
sump syndrome, sir.
Sump
That
syndrome.
sump syndrome.
The distal part, the collections will be persistent in the distal part, leading to pain, sir.
Distal to the anastomosis, the distal CBD will be retained and it may get collected and the debris may produce infection, produces some syndromes.
Okay.
So for completion's sake, can stone, you have mentioned about, can stone in the gallbladder can cause obstruction of common bile duct?
Mirzi syndrome, sir.
Mirzi syndrome. How will you manage Mirzi syndrome? What is type 1, 2, 3, 4, 5?
Type 1 when there
Make
is
it fast. Last 3 minutes.
Type 1 Mirzi syndrome, there is a stone at the cystic duct causing
Cystic duct கிடையாது தம்பி.
Hartmann's pouch, sir. Hartmann's pouch and causing compression of the common hepatic duct or common bile duct.
Type 2.
When there is less than 1/3 of the duct is involved, it is type 2. When there is more
Type
than
2 is 1/3. Type
more than
3
2/3
is
more than
Two-third.
two-thirds is involved.
Two-third.
And
Type
when there's
4?
complete destruction of
Type
the
5
Five.
is
Fistula.
Fistula formation.
Fistula. For type 1 management,
partial cholecystectomy.
for type 2 and 3,
Cholecystectomy with T2 placement.
type 4,
With
type 4 and
hepatic
5, partial cholecystectomy with biliary enteric anastomosis. This is the treatment for Meresis syndrome. Okay. So if you find an ultrasonogram, a fusiform dilatation, a swelling, what you have palpated is cystic swelling in the common bile duct. What could be your diagnosis?
Choledochal cyst.
Choledochal cyst. How will you, what is Tatani's classification of choledochal cyst?
Five
Type-
types. 5 types. Type 1 is a fusiform dilatation of the CBD.
Type 2?
CBD diverticulum will be there. And type 3 there is a choledococele will be there in the
Duodenal
ampulla.
bulge. Okay.
Type
Type
4.
3. Type 4 and 5?
4 and 5 intrahepatic and extrahepatic.
Extrahepatic
4A
and
and
type
4B. 5 is
intrahepatic.
intrahepatic.
Oh. What's the treatment for type 1 and 2?
Type 1 and 2 we can
complete
do
excision of the cyst with
cyst.
Roux and
Excision of the
Cyst.
cyst.
Complete excision of cyst. If the diameter is less than 1 centimeter, we can do primary anastomosis. If it is more than
Okay.
that, we can go
For
for
type
hepatic.
3?
Transduodenal sphincteroplasty.
For type 3, mind it, this is a repeated asked question. Type 3, there is endoscopic management. Sphincterotomy is
sphincterotomy.
the treatment. Type 4 and 5, type 4 is
Intrahepatic, we can go for if only is extrahepatic means you can go for Roux and
Hepatectomy.
hepaticojejunostomy,
type 5, Caroli's disease, liver
liver
transplant.
transplantation.
Okay. For biliary stricture, what will you do?
Sir?
Biliary
Stricture.
stricture.
Stricture. You have to look for the stricture whether it is benign or malignant stricture, sir.
So as
If
a
it is a benign
conclusion, obstructive jaundice in postgraduate is like a mathematics, purely discussion. The physical one is only one physical one, jaundice and bulbal gallbladder. Most of things will be discussion part only. You should thoroughly know the in and out of each. 85% may be due to stone disease only, 15% only due to malignancy. Okay. In 15% malignancy, pancreatic, periampullary, other miscellaneous cause may be stricture, choledochal cyst, Meresis. Okay. So you should know how to discuss. You should read the mind of the examiner. Some of the examiner may go for in-depth laparoscopic procedure. You should also know the laparoscopic cholecystectomy thoroughly. What is callous triangle? What is cystohepatic triangle? Do you know the difference between callous triangle and cystohepatic triangle?
Sir, in
What
Calix
are the
triangle,
boundaries?
in Calix triangle, the superior boundary is found by the cystic artery, whereas the cholecystohepatic triangle is
What is the content present in the callous triangle? What is the content present in the cystohepatic triangle?
cholecystohepatic triangle, cystic artery and cystic node of Lund, sir. In Calix triangle, only cystic node of Lund will be, sir.
Okay. What is Strasberg's critical view of safety?
While doing cholecystectomy,
If the discussion was go to strictures, benign strictures, they ask in and out about the anatomy. You should know all these things.
So to sum up in obstructive jaundice, the method of evaluation is the first line investigation or imaging study of choice is ultrasound. So ultrasound can differentiate a malignant cause from a benign cause like stones. So if you have got stone disease, you straight away proceed with the MRCP. So if the ultrasound says that it is a malignant disease, you proceed with the CECT. So that is a thing. For stone diseases, you do a laparoscopic cholecystectomy. Suppose if CBD stones are present, you can combine ERCP either pre or post operatively. And what is biliary pancreatitis? Please, only one question. What is biliary pancreatitis?
because of the stones in the gallbladder may descend and gets obstructed at the ampulla, producing inflammation of the pancreas. This is biliary pancreatitis.
Biliary pancreatitis. What is the treatment for biliary pancreatitis?
You have to go to settle the pancreatitis and you have to do cholecystectomy, either lap or open in the same sittings.
When will you do cholecystectomy? Suppose if the patient presents with biliary pancreatitis.
You can do at the same sittings.
Same admission. You can do the surgery in the same admission. Okay. Suppose if it is a malignancy, you do CECT. And diagnostic laparoscopy as such is not indicated in the protocol as that of CA stomach. But if you want, you can do. Suppose if your diagnostic laparoscopy says that it is inoperable, what are all the non-surgical palliation will you do?
Palliative stenting.
Palliative stenting where?
The distal CBD, sir.
So you have to palliate for
Jaundice,
jaundice.
pain and
jaundice, pain and
gastroduodenal obstruction.
GOO. So another important commonest cause for GOO is pancreatic malignancies. So you do a upper GI stenting, ERCP and stenting followed by celiac plexus block in order to relieve the jaundice. So you have a roadmap and do well. Very good presentation. Congratulate both of you. Thank you.
Thank you.
The next presenter is Dr. Vijay Raghavan.
Good morning, sir. I am going to present a case of 64 years old male from Simmakkal, auto driver by occupation, belonging to lower socio-economic class, came with complaint of ulcer over the penis for 3 months. History of presenting illness. The patient was apparently normal 3 months back, after which he developed ulcer over the penis, initially small in size, about 1 centimeter, involving the tip of the penis, gradually progressing towards the base to attain the present size. Not associated with pain, no history of discharge or no history of difficulty in passing urine, no history of swelling around the groin region, no history suggestive of distal metastasis.
That small in size, about 1 centimeter, involving the tip of the penis.
Yes, sir.
What is the tip of the penis? Did you mean prepuce or you mean glans?
Glans the penis.
Okay.
No history suggestive of distal metastasis, no histories of trauma. The past history of circumcision done at 30 years for phimosis, no history suggestive of diabetic mellitus, hypertension, sexually transmitted disease, cardiovascular disease and chronic skin disease. No history suggestive of multiple sexual partners, not a smoker, an alcoholic 3 times per week. Summary: a 64 years old male non-smoker came for complaint of progressive non-healing ulcer over the penis for 3 months, not associated with the discharge, with the past history of circumcision done for phimosis, no history suggestive of metastasis.
Okay. So it is a good thing you have asked for history of circumcision done at 30 years of
Yes, sir.
for phimosis.
Yes.
What is the significance?
Phimosis is a risk factor for the CA penis, sir.
Okay.
Due to the poor hygiene, the patient may end up in a CA penis, sir.
Can circumcision prevent the development of carcinoma penis?
Neonatal circumcision only provide protection against the
Very
CA
good.
penis, sir.
So only circumcision immediately after birth will prevent the future development of carcinoma.
Yes, sir.
But circumcision done in later life, during puberty,
Yes, sir.
will not have protection, same protective effect over the development of carcinoma.
Yes, sir. General examination: patient is conscious, oriented, well built and nourished, no pallor, icterus, cyanosis, clubbing, pedal edema, generally stabilized with the ECOG score is 1. After getting consent and explaining the procedure to the patient was exposed from abdomen to mid-thigh and examined in well-light room. Inspection: and single ulcerative lesion, predominantly ulcerative, of size approximately 6 x 4 cm over the gland species and a part of the shaft extending up to 2.5 cm from root of the penis. Appears to be irregular in shape with a irregular margin, everted edges and floor covered by slough. External urethral meatus seen. Rest of the penis and scrotum appears normal and no discharge present. Palpation: no local rise of temperature, no tenderness. Inspectory finding confirmed. Does not bleed on touch. Irregular shape and irregular margin with everted edges. Base interrelated extending up to 1 cm beyond the lesion. The length of the remaining pinnings from base, excluding lesion along with induration, is about 1.5 cm. The palpation of rest of penis and perineum normal. External urethra meatus is in midline. Scrotum, bilateral testis and cord structure palpable. Palpation of regional lymph nodes. The multiple enlarged horizontal group of superficial right inguinal lymph nodes, largest measuring 2 x 1.5 cm, well defined smooth surface, mobile, film in consistency, skin over the swelling normal. The multiple enlarged horizontal group of superficial left inguinal nodes present, the largest being 2 x 1 cm, well defined smooth surface, mobile, film in consistency and the skin over the swelling normal. The other examination, the Oz normal vesicular bits here, CVS S1 S2 here, CNS no focal neurological deficit, abdomen soft, no organomegaly, iliac lymph nodes could not be assessed, spine and cranium normal, Digital rectal examination.
Why the
normal-
iliac lymph nodes could not be assessed? Why do you say that?
Patient is obese, so I can't assess.
So you are not able to do a
Assess.
proper examination. Okay.
Go to inspection.
Yes, sir.
You mentioned a single ulceroproliferative lesion. Okay. Seen in the glans penis, isn't it?
Yes, sir.
Isn't
Yes,
it?
yes, sir.
Ulcer.
Yes, sir. Yes, sir.
Ulcer or ulceroproliferative lesion.
Ulceroproliferative lesions are predominantly ulcer in nature.
Okay. Go to the palpation. Up to which area of the penis you are able to palpate the induration?
1 centimeter.
Whether the ulcer confined only to the
The induration can be palpable 1 centimeter beyond the lesion, sir. 1 centimeter beyond the lesion, sir.
1 centimeter. Oh, well, okay.
Yes.
1 centimeter beyond the.
Ulceroproliferative lesion, sir.
What about the urethral?
Meatus
External urethral meatus.
could be palpable and is in
Huh?
is in midline, sir.
Able to see.
Yes, sir. Able to see, sir.
What about the urine or flow?
It's a normal flow.
It is a single stream or multiple streams?
The patient.
I asked.
Sir, I asked that there is no complaint of difficulty in passing urine.
I want to ask whether the urethra is involved or not.
Yes, sir. No difficulty in passing urine, sir, but the single stream of urine is present.
Single stream of urine. Why there is a ulceroproliferative destroying the glans penis, isn't it?
Yes, sir.
Why urethra is not involved?
It's a late presentation in CA penis, sir.
Huh?
It's a late presentation in the CA penis. Buck's fascia, it acts as a natural barrier for the
Acts as a temporary
against the CA
barrier
penis. Yes, sir.
for the spread of
Okay.
cancer cells.
So your diagnosis? What's your diagnosis?
Yeah, ulceroproliferative lesion.
Picture picture.
The
Okay.
ulceroproliferative growth involving the glans penis on the shaft of the penis, sir. Probably CA
Probably.
carcinoma penis.
Okay. What is the morphology of the ulcer in this patient? Morphology of the ulcer. Describe the ulcer.
Ulcer is irregular in shape.
Appearance. Morphology means external
Morphology.
appearance. Whether it is ulcerative lesion or ulceroproliferative lesion
It's
or a
ulcer.
verrucous type of lesion.
It's a ulcerative lesion, sir. Ulceroproliferative, predominantly ulcerative lesions.
Define ulcer.
Ulcer is a break in the continuation of the epithelium of the mucous membrane of the skin.
What are the parts of an ulcer?
It's maybe it's maybe neoplastic or
Huh?
or infective or
Huh?
infective or neoplastic or
Parts. You are telling the classification.
yes.
Parts of
Morphology of the ulcer என்னன்னா ஒரு அல்சர்ல என்னென்ன பார்ட் இருக்கும்?
The shape of the ulcer.
edge, margin அதெல்லாம் சொல்லு.
Yes, sir. Edge, margin.
Mind it. If you make mistake in the basic, it is very difficult for the internal to help you. Mind it. Yes. So, morphology in geta you have to tell.
The shape, margin, edge,
Margin, edge,
floor of
floor,
the base of the ulcer.
ஆமா. Whether you can distinguish all these things in this lesion?
Yes, sir. The ulcer involves the whole of the penis and the shaft. The edge is everted. The floor is punched out. The floor is covered with slough, minimal slough, sir. Margin could not be. Base indurated, sir.
Okay.
Irregular margin is present.
Their question is, what are the edges of ulcer? How many edges are there in
What are all
ulcer?
the types of
Examination of
generally?
ulcer.
The 5 types are
Very good.
undermined ulcer,
Undermined in example,
TB ulcer,
very good. Tuberculosis.
yes. The punched out ulcer, sir.
Punched out example,
The neurotropic ulcers,
trophic ulcer and
and
anybody?
neuropathic ulcer.
Huh?
Neurotrophic ulcers.
Arterial ulcer.
Arterial ulcer.
Next.
Healing ulcer or sloping edge ulcer.
Sloping edge.
Another example for
Romantic.
sloping edge.
Sloping edge.
You said clinic healing ulcer.
Diabetic ulcer.
Another example. Venous ulcers. Very good. From
Venous
the
ulcer.
Everted edge ulcers.
This is an example.
Rolled out edges or everted edges.
Everted edges example.
Squamous cell carcinoma.
Carcinoma or ulcerated adenocarcinoma.
Yes.
Then raised and beaded.
Beaded ulcers are present in basal cell carcinoma.
Very good. 5 edges of, that's why they are asked. If you don't know presentation of ulcer, no need to go to the exam hall.
How will you confirm the diagnosis? Your diagnosis, what is your diagnosis in this patient? Carcinoma?
Carcinoma stomach.
Penis with?
Penis. With bilateral.
Bilateral or unilateral?
Bilateral inguinal.
Bilateral?
Inguinal lymphadenopathy.
Inguinal. Iliac node not palpable.
Yes, sir.
Not palpable, or you are not able to make it?
He's
Yes,
not
could
able
not
to-
be assessed. Sir,
Okay, okay. How will you confirm the diagnosis?
by edge wedge biopsy of
Huh?
the edge wedge biopsy of the
Edge wedge biopsy.
Okay.
What do you mean by edge wedge biopsy? Where will you take?
the edge wedge biopsy is done in the edge of the lesion along with the normal skin.
Why
surrounding.
you have opted for edge wedge biopsy?
It's the most representative area of the ulcer, sir. The proliferative cells are more in the
Know the level of invasion. Why not in the middle of the ulcer?
necrosis and the are
Necrosis occur. Okay. So you have taken edge wedge biopsy. What could be the histopathological report?
present. The histological report depth of the invasion can be
Huh?
depth and the perineural and the vascular invasion can be assessed.
இதில் பெத்தலாஜிக்கல் செல்ஸ் என்னையா இருக்கும் இந்த லீஷன்
Squamous cell carcinoma.
ஸ்குவாமஸ் செல் கார்சினோமா என்ன இருக்கும்
என்ன
cell
future இருக்கும் histology?
Keratin pearls.
Huh?
Keratin pearls.
What
will
is
be-
keratin pearls? Epithelial pearls or keratin pearls?
It's the desquamous epithelium which forms a hole-like lesion in the slides. It's a signs of well differentiation, sir.
Can you get epithelial pearls in all squamous cell carcinoma?
Yes, sir. It's not it's absent in the differentiated cells.
Huh?
Not different, poorly differentiated cell, squamous cell epithelium we can't get.
In which type of squamous cell carcinoma you will not get epithelial pearls?
Sarcomatoid,
Huh?
sarcomatoid type of spinal cancers.
The lower end of esophagus. Transitional cell. In which benign lesion you can get epithelial pearls? Benign lesion.
In situ lesions.
Can you tell me in the afternoon? Okay, don't bother. You confirm the diagnosis. The report is missing. What will you do for the lymph node? Will you do any FNAC?
Yes, sir.
If the lymph node size is more than 2 centimeters,
Yes, sir. FNAC can be done in the both.
FNAC can be done. Okay, you have
Before
done FNAC.
proceeding to FNAC, what will you do?
CT abdomen,
CT.
abdomen pelvis.
All the inguinal lymph nodes are infective, more than 50%. For that, what you are going to do?
We can give antibiotics and
For how many days?
for 4 weeks, sir.
4 weeks.
3 to 4 weeks.
Okay,
4
any other
to 6
imaging study
weeks.
will you do?
Sir.
Any other imaging study you want to do?
Sir, we can do CT abdomen pelvis can be done, sir, to assess the pelvic lymph nodes. Sir.
Okay. So you want to rule out involvement of the urethra. What will you do?
We can do MRI penis.
MRI of the penis.
Yes,
So CT abdomen and pelvis to rule out any iliac nodal metastasis
Yes,
as well as lung metastasis. You have to go for a CT chest.
CT just.
Okay. What treatment will you choose for this patient?
Before proceeding to treatment, whether you examine the abdomen for something,
Yes, sir. I examined the abdomen for iliac nodes and liver metastasis.
any other. In a carcinoma penis, examination of abdomen for what?
And iliac nodes and para-aortic nodes.
Pelvic lymph node and para-aortic lymph nodes.
Yes.
What is pelvic lymph node?
It's a external iliac and internal iliac and obturator nodes together form the pelvic
Internal
lymph node.
iliac, external iliac, operator lymph node combined to form pelvic lymph node. Here, here whether it's involved or not.
Yes, sir, it's not, could not be assessed, sir, due to the obese.
How will you examine the pelvic lymph node in a patient? Sir, that's the clinical demonstration.
Ask the patient to, in a supine patient, after getting the consent, the leg is, ask the patient to abduct the limb and externally rotate, and you have to palpate the limb nodes
Whether
again.
patient has to flex the hip or not.
Yes, sir, you have to flex the hip
That
and
is the
abduct.
important point. To relaxation of the lower abdomen, to look for the pelvic lymph node, internal iliac, external iliac, operator lymph node.
Yes, sir.
Ask the patient to flex the lymph node and look for the
Iliac.
pelvic lymph node. Okay?
Yes.
That is very important. What is the importance of looking for the lymph node? Your explanation you are not given for the lymph node, whether it's mobile or not. What is the consistency, you are not told. Whether attached to the skin or deeper structure, you are not told. That is very important. You have
What
to
is the
proceed.
lymphatic drainage of penis? How the lymphatics?
Superficial inguinal nodes, sir.
Huh?
Horizontal group of superficial inguinal nodes and deep inguinal nodes.
What is Gabanos?
Horizontal group of
Huh?
horizontal group of superficial inguinal nodes, sir.
Okay.
What
Superomedial.
are dashless nodes?
Dashless is classifies the horizontal, the superficial ink nodes into the 5 types: central, supromedial, and suprolateral, and infromedial and infrolateral, sir, depending upon the arterial.
You have confirmed the diagnosis. You have workup.
Yes.
What we do for this patient?
For this patient, we can go for total penectomy, sir.
Total.
Amputation of penis, sir.
But the lesion has crossed the corona glandis.
Is the remaining stump of the penis is not adequate, sir. It's
What
less
should be
than-
ideal stump?
Ideal stem should be 2 centimeter or greater.
2 centimeters, minimum of 2 centimeters.
Yes.
And the clearance you have to give how much centimeters?
2 centimeters, sir.
2 centimeters.
Yes.
What is
So
a serviceable penis?
Uh,
You heard of the term serviceable penis? Have you heard?
preserving.
Anyone?
No.
What is a serviceable penis? So you have beautifully presented in your palpation. You have measured the length of the shaft after induration. Yeah. So after a partial penectomy, there should be a sufficient length of penis to micturate
Yes, sir.
in the proper way, in the upstream
Upstream.
urination. Patient has to urinate in a upstream fashion. So that is very important. And number 2, patient's sexual activity will not be compromised. So if you meet these 2 factors, you can go for a partial penectomy for a lesion. Okay.
You have done, your answer is incomplete. Total penectomy with
Bilateral ilioinguinal dissection depending on the biopsy.
perineal.
Perineal, sorry, sir. Perineal urethrostomy,
You have to
but
mention,
bilateral
you have to
orchidectomy.
perineal, total penectomy with perineal urethrostomy.
Yes, sir.
What we do with the testis and scrotum?
We can do bilateral orchidectomy.
We can do will you do or will you not do?
We do bilateral orchidectomies.
Orchidectomy and scrotectomy.
Yes.
Huh?
Yes.
Is it mandatory?
It's
What is the name of the procedure? That is total penectomy. What is the name of the procedure for total penectomy with orchidectomy with scrotectomy? There is specific name for these 2 procedures, isn't it?
Yes, sir. The Percy-Gold operation for
First one is
for total amputation of the penis with bilateral orchidectomy with the perineal urethrostomy, sir. Young's operation for the partial penectomies.
What are all the penile preserving surgeries you know?
The
Don't
laser
worry about this case and diagnosis. What are all the non-surgical methods for the treatment of carcinoma penis?
The laser.
What are all the indications?
The indication for the organ preserving is less than 4 centimeter, involving the glands, and it should not go into the shaft.
TAS, TA, verrucous carcinoma, carcinoma in situ,
Yes,
and T1 lesions with well differentiated tumors without lymphoadenoma. You leave that. What are all the methods of treatment?
The laser ablation techniques.
So it is 5-FU cream, imiquimod cream. So
Yes,
it
sir.
is a immunomodulator,
Modulators.
which has activity against NK cells.
5-FU
ND-YAG laser as well as carbon dioxide laser. Then what is most micrographic surgery?
We have to dissect the ulcer.
One word, I want one word regarding most micrographic surgery. Have you
Re-examine.
heard of the abbreviation CCDPMA? Complete circumferential, peripheral and deep margin assessment. So you can go for a glancectomy also if the lesion is confined to the glans. And you can do a wide local excision. Suppose if the patient is not willing for surgery, what will you do?
Give RT for the patient.
What
For
type
this
of RT will you give?
external beam RT or the brachytherapy, sir.
What precaution will you take before giving external beam radiation?
The testes should be covered before.
Circumcision should be done.
Yes, yes, circumcision.
And alternatively, you can go for interstitial radiotherapy,
Yes.
especially in penile carcinomas.
Yes.
Okay.
What will you do for the lymph node?
If the lymph node, the bilateral FNAC appears to be positive, we can go for
If
bilateral.
lymph node is negative, what will you do? If lymph node is positive, what will you do?
If the both
If
lymph
lymph node is negative for malignant cells, what will you do?
if the lymph node is negative, we can go for a deep and superficial inguinal lymphadenectomy, sir. And after which we can
Deep and superficial inguinal. So if the
superficial
lymph nodes are negative, what will you do?
superficial inguinal lymphadenectomy.
What is the name of the procedure called?
Gabbana's modified inguinal lymphadenectomy.
Modified inguinal lymphadenectomy or Catalona's procedure.
Yes, sir.
Okay, if lymph node is positive, what will you do?
If the lymph node is positive bilaterally, the ilioinguinal
Ilio?
inguinal dissections,
Ilio-inguinal block dissection. What incision will you put for ilio-inguinal block dissection?
boundaries, sir.
Huh? Incision.
Lacius incision for the ilioinguinal dissection.
What incision will you put? You have to go up to the
ASI 4 centimeter lateral to the ASI, sir. 4 centimeter lateral to ASI up to, and we have to.
that is lacy incision, inverted S incision,
Yes, sir.
starting from above the inguinal
Inguinal ligament up to the
So,
ASI, sir.
what are the structures will you remove in the
In the ilioinguinal
inguinal
dissection,
region?
inguinal region with the superficial and the deep inguinal lymph nodes,
Anugundu.
GSV
Okay,
can be pressed. Superficial and deep inguinal lymph nodes, and GSV can be preserved.
What will you do with the saphenous vein? Will you ligate or don't ligate? Saphenous vein.
In the classical, we should ligate the, in a classical inguinal dissection, we should ligate the GSV, sir.
You have to ligate, you have to excise a segment of.
GSV, sir.
Okay, what are the complications anticipated?
Flap necrosis.
Huh?
il-
Complications after ilio-inguinal block dissection.
The post-operatively, the patient may go for the flap
Block
necrosis.
Flap necrosis.
Yes.
Okay, agreed. So, in a case of, if the case of advanced malignancy, with a fixed node,
Yes, sir.
fixed inguinal node,
We can
what will you do?
we can give neoadjuvant chemotherapy.
Chemo?
Chemotherapy or radiotherapy.
Okay. What are the complications expected in this patient? In an inoperable case with the fixed inguinal node.
The femoral artery.
Huh?
Femoral artery hemorrhage may be present.
The patient may die of,
Erosions.
that is the end stage.
Only one question. What Kroon's algorithm? KRN. What is Kroon's algorithm? Anybody? So in clinically impalpable nodes, N0 nodes, you can follow this Kroon's procedure. This is nothing but a ultrasound or a MRI of the inguinal region. You do a FNAC. So if the FNAC is positive, you proceed with the lymphadenectomy. If the FNAC is negative for N0 nodes, you can observe the patient or put the patient on antibiotic management as sir has already mentioned. So in 25% of the individuals, mostly these nodes will be reactive nodes. So you always go for a FNAC when in doubt. Okay.
If involved lymph node is fixed, how will it want to give chemotherapy or radiotherapy?
Chemotherapy, sir.
If fixed lymph nodes are inoperable, course of palliative radiotherapy
Can be given.
and the lymph nodes are becomes mobile, then you can go for palliative immunopelvic lymph node dissection. Maybe consider. Okay, these are all done. Then last is this, you have to discuss about the pre-malignant lesions of the penis.
Yes, sir. It can be HPV related or non-HPV related, sir. The HPV related are condyloma accumulatum, the Buschke-Lowenstein tumor, the bonoid papillosis. The non-HPV related are balanitis xerotica obliterans, or the cutaneous horns, or the pseudoepitheliomatous micaceous keratosis.
What is this balanitis xerotica obliterans?
It's a localized condition of the lineate sclerosis at atrophic, sir, in which
So
there
it
is
is lichen sclerosis of the penis, which will be associated with the
scarring
stenosis of the external meatus as well as strictures.
and yes.
So very good presentation. I congratulate you. Thank you. Who is the next presenter? You can come up. Introduce yourself.
Good afternoon, sir. I'm Dr. Naveen Kumar from Theni Medical College, postgraduate from Theni Medical College, finally postgraduate. Today my topic for presentation is solitary nodular goiter. 38 years old female from Vandipatti, who is a homemaker, came with complaints of swelling in front of the neck for past which was insidious onset, initially smaller in size and gradually progressed to attain difficulty in breathing or swallowing, no history of any other swelling in the neck, no history suggestive of hyper or hypothyroidism, no history of loss of weight or loss of appetite, no history of bone pain, chest pain or breathlessness. Past history, no known comorbidities, no history of previous neck surgeries, no history of childhood irradiation in the past, no history of drug intake. Personal history, consume mixed diet, sleep pattern is normal, no bowel and bladder abnormalities, no history of tobacco, smoking or alcohol consumption. Menstrual history, regular menstrual cycle with 5 days of normal flow for about 28 to 30 days cycle. Family history, no family history suggestive of thyroid swelling or thyroid cancer. Summary, a 38 years old female with gradual progressive swelling in front of the neck without pressure symptom, with no history suggestive of hypo or hyperthyroidism and without any significant family history. Examine in a well-lit room in sitting position with adequate exposure till the level of nipples. Patient's conscious oriented afebrile, no pallor, icterus, sinuses, clubbing, generalized lymphadenopathy, edema, no eye signs, no tremor.
What are all the eye signs you look for?
Sir, exophthalmos, lid lag, lid retractions, inability to convergence of eyeballs, chemosis.
What are all the names of various signs?
So, Van Graaff sign, Darlimple signs, Van Graaff sign, lid lag, sir. Darlimple sign, inability to avert upper eyelids, sir. Stellwag sign, infrequent blinking.
Is papillary carcinoma.
If the size of the swelling is less than 1 centimeter, then we can observe the patient, sir.
So
If it is
you can categorize as low risk,
low risk and high risk.
Low risk and high risk. Okay.
If there is low risk, less than 1 centimeter, we can observe the patient, sir. Further follow-up. If it is more than 1 centimeter high risk patient, go for completion thyroidectomy, sir.
Okay. If you fix up the pre-operative diagnosis is known, if while doing FNAC, if the report comes as malignancy, that is PAP-CA, what will you do?
Total thyroidectomy with central and ecto dissection. Lateral dissection, if any clinically or radiologically palpable, no.
Okay. So, if the report you have done, if the pre-operative report itself comes as medullary CA, what will you do? Medullary carcinoma.
Total thyroidectomy with bilateral, total thyroidectomy with central inguinal and lymph node dissections.
Huh?
Total
thyroidectomy with the
central compartment inguinal and lymph node dissections.
Okay. If lymph nodes are involved?
If lymph nodes palpable or clinically involved lateral nodes, then go for functional neck node dissections.
Okay. What will you do if the FNAC report comes as lymphoma?
Lymphoma is most radio-sensitive tumor, sir. Radioablation can be.
Will you proceed with radiotherapy with FNAC report, or will you do any other investigation?
Immunohistochemistry.
Huh?
Go for immunohistochemistry.
Huh?
Immunohistochemistry, sir.
For immunohistochemistry, what do you want?
Tissue biopsy. If I go for true cut biopsy, sir.
You have to do
True
cut biopsy. What are the indications for true cut biopsy in thyroid swelling?
So
Usually it is contraindicated only in two conditions can do true cut biopsy.
Lymphoma and anaplastic carcinoma.
Huh?
Lymphoma, anaplastic carcinoma.
Anaplastic carcinoma. Okay.
What will you do for anaplastic carcinoma?
Sir, true cut biopsy, if
What is the treatment?
Treatment, external baby, palliative radiotherapy.
If the patient complains of stridor,
Hystomectomy can be done, sir, to relieve the obstructions.
So you have done completion thyroidectomy. How will you follow up the patient?
I'll follow up the patient after 6 weeks. I'll go for radioiodine uptake study, sir, and look for any.
What's the tumor marker you have to look for in follow-up study?
Thyroglobulin, sir.
Thyroglobulin. Okay. Any other thing? Any other investigation?
Ultrasound neck also can be done.
Any other?
Whole body scanning.
Whole body scan. Okay.
so after total thyroidectomy for differentiated thyroid carcinoma, when will you do this radioisotope iodine scan?
After.
So in the follow-up study you have to do estimate the tumor marker as well as sir is indicating, that is radioactive iodine study. Okay. To locate what are things you can look for? What are the indications for radioactive iodine study?
Any remnant tissues left behind or recurrences.
Remnant, recurrent, and then metastasis. Okay. So if you find a metastasis, what will you do?
Radioablation can be given.
Ablation, radioactive ablation therapy. Dose.
What is the radioisotope used for that? Radio ablation therapy?
So iodine 132.
Iodine 131. So iodine 123 is for scanning purpose.
Diagnostic purpose.
Dosage?
So for metastasis, more than 100 to 300 millicurie can be given, sir.
Mechanism of action? So it emits beta rays as well as
beta rays and causes
so it
destruction of
destroys
tissues.
the tissue without affecting the normal tissue.
Any contraindication for this radioactive iodine therapy?
Pregnancy, lactation.
Pregnancy. Is there any prerequisite for doing this study? Radioiodine scan?
Sir, for TSS should be 30 milliunits per liter.
It should be more than 30 micro international units per ml. So what will you do for that?
If TSH suppression, or you can give recombinant T3 to increase the TSH.
Okay.
What is the nature of metastasis in follicular carcinoma?
So, Pulsatile secondaries over the
Pulsatile?
bony metastasis.
Bony metastasis. In which other condition you can get pulsatile bony metastasis?
Renal cell carcinoma.
Huh?
Renal cell carcinoma.
Renal cell carcinoma. While doing FNAC, you are aspirating clear fluid. The lesion disappears. What will you do?
I will observe the patient, sir.
Okay. Again, if the swelling reappears, what will you do?
Again, I can aspirate, sir. After 3 aspirate, if it is again recurring, I go for thyroidectomy, sir. Hemithyroidectomy.
If it is a multiple cystic lesion, what will you suspect? It is a unilateral cyst, agreed.
Can be a malignancy.
Huh? If it is a multilateral cyst, you have to suspect malignancy.
Malignancy.
You have to suspect malignancy. So, if it is a colloid nodule, what will you do?
If the nodule produce any obstructive symptoms, go for thyroidectomy, sir.
So, for cosmetic surgery, or if the patient develops the symptoms, go for
Thyroid
surgery. Okay.
Suppose if the patient is having toxic symptoms, your diagnosis is a toxic nodular goiter,
So,
solitary
while
nodule.
doing radioactive study, hot nodule and the pulse rate is 100, what will you do?
Ablation.
Huh?
Ablation can be given, sir, over the toxic area.
Okay. Any other option available?
Antithyroid drugs. I will start the patient on antithyroid drugs, sir.
Do you want
If
to be a
the-
physician? Do you want to be a physician?
So I make the patient euthyroid state and go for a thyroidectomy.
How will you bring the patient to euthyroid state?
By giving antithyroid drugs.
What drug will you give?
Thionamides like
What drug routinely you are giving in the ward?
carbimazoles.
Huh?
Carbimazoles.
What is the dose of carbimazole?
5 to 10 milligram.
What is the side effect of it?
Agranulocytosis.
What will you do if the patient develops agranulocytosis?
Stop the drugs.
Then?
Give other drug.
What drug will you use in pregnancy?
Propyl thiouracil, sir.
Okay, you bring the patient to euthyroid state. What will you do next?
If radio ablation is contraindicated, I go for surgery, sir. Total thyroidectomy, sir.
Huh?
Thyroidectomy, sir.
Thyroid? Whether you go for hemi or total?
Subtotal thyroidectomy, sir.
Okay. What are the complications will you expect in toxic thyroid surgery after finishing talk? You have done surgery in a toxic patient. What post-operative?
Thyroid crisis.
Huh?
Thyroid
What is thyroid crisis?
Thyroid from excessive secretion of thyroid hormones in inadequately prepared.
What are the clinical manifestation, man?
Hyperexcitability,
Huh?
hypertension,
Hyperpyrexia.
hyperpyrexia,
Okay, then
hyperpyrexia, hyperexcitability, sweating, palpitation, atrial fibrillation.
okay, what will you do for the patient?
First, antipyretics,
Huh?
antipyretics, IV fluids,
Antibiotic.
pyretics, sir.
You have to
Tepid
bring,
sponge.
for hyperpyrexia, you have to treat the patient. You have to give tepid sponging.
Tepid sponge.
You have to give acetaminophen drug, and you have to give steroids. Okay, you should not use paracetamol. So what could be the cause for the thyroid storm?
Inadequate preparation of the patient.
One is inadequate preparation. That is before bringing the patient to euthyroid state. Then number 2,
Stress and distress.
force handling of surgery during surgery of thyroid gland. How will you prevent? How will you prevent thyroid storm?
So, adequate preparation, giving Lugol's iodine.
Okay, you have to prepare the patient adequately. Then during surgery, which vessel to be ligated first?
Middle thyroid vein first.
Huh?
Middle thyroid vein.
Good. In case of toxic thyroid, you have to ligate middle thyroid vein first. In regular surgery, which pedicle you have to ligate first? In regular thyroidectomy, which pedicle you have to ligate first?
Middle thyroid. Superior pedicles.
This question is asked that you are exposing yourself, you are not exposed to thyroid surgery. So you have to ligate superior pedicle, because 60% of the blood supply is from the superior pedicle. In toxic thyroid, you have to ligate middle thyroid vein to prevent postoperative thyroid storm. So thyroid, how will you manage? Apart from that, you have to rehydrate the patient. You have to bring temperature should be brought normal, and pulse rate. The patient may go for atrial fibrillation and failure. What will you do for that?
Rejection, give rejection for atrial fibrillation.
Short-acting beta blocker.
Yes.
Short-acting beta blocker.
Propranolol and
Esmolol. Esmolol. Pre-operative you can give propranolol. Post-operative short-acting beta blocker. Okay. So what are the other complications of thyroid surgery?
Injury to the nerves, sir, recurrent laryngeal nerve.
Okay. Then next.
Hemorrhages, sir.
Huh?
Bleeding, sir.
Okay. Then.
Thyroid, then hematoma
You
post-operative.
mentioned subtotal thyroid. If you take all 4 parathyroid gland, what happens?
Hypocalcemia also.
What happens? What will you do? How will you manage?
I give oral calcium.
The post-operative period, man.
If the calcium level is below 8, then I will give for IV calcium.
How will you give?
IV calcium, 10 ml of 20 ml of 10% calcium gluconate in 5% dextrose.
You have to give slowly. Otherwise, the patient may go for cardiac arrest.
What is the earliest postoperative symptom of this hypocalcemia?
Perioral numbness.
What are all the other signs will you look for?
Chostek signs, drowsy signs, sir.
Okay. So very good presentation. So Dr. Naveen from Theni, congratulations.
The presenter and the moderators, everybody has done a nice job in a limited time. It's a thyroid, CA penis, and obstetric and endocrinologist. Now everything solved by a general surgeon. That's why we are choosing general surgery. Next is our surgical gastroenterologist, Dr. Padmanabhan. The great Dr. Padmanabhan is on the way. You are really lucky enough. You got all the faculties here. You never expect this type of faculties anywhere in Tamil Nadu. It's really, I'm telling, you are able to see, only in YouTube and all you can see, but here you are seeing, they are coming in time, you make use of, before coming here, please see the case. Definitely he will scold like anything. Before seeing, I got a beat from his artery forceps in this, because we are in oncology, in this side, one side, another is gastroenterology. He used to come and help usefully. And if any mistake, he will beat with artery forceps. Even though he is my student, you have to accept. Whatever learning, you have to accept. That is the process of our learning. Okay? That is our dictum. He is a very good surgeon. Make use of him. Subject is very great. You have to make use of him. Thank you very much for all.
Thank you, sir. Now, Professor Damodaran, sir, will distribute the Professor Damodaran Endowment Prize for gold medal in MS University exam to Dr. Anthony Rennington. I request Professor Damodaran, Professor Mohammad Mustafa and Professor Lakshmi Narayanan to distribute the certificates to the presenters. Dr. Praveena. Dr. Vignesh. Dr. Vijay Raghavan. Dr. Naveen Kumar. I request Professor Syed Ibrahim to honor the Dr. Damodaran sir and Dr. Mohammad Mustafa sir. Now we'll move on to the next session, which will be chaired by Professor Padmanabhan, Head of Department of Surgical Gastroenterology, Madurai Medical College, Professor Selvaraj, Professor of Surgery, Madurai Medical College, Professor K. Saravanan, Professor of Surgery, Madurai Medical College, and Professor Geeta, Professor of Surgery, Madurai Medical College. The first case to be presented by Manoj Murugan.
Only one candidate.
A 30-year-old female whose coolie occupation with low socioeconomic status presented with the complaints of vomiting for the past 1 year. History of presenting illness: patient was apparently normal before 1 year. After that, patient developed vomiting, which was insidious in onset, gradually progressive, gradually increase in frequency, non-projectile, non-bilious vomiting, not bloodstained, contains undigested food particles, usually 30 minutes after food intake. There was a history of abdominal distension for the past 3 months after each meal, which relieves by vomiting. History of abdomen pain present, history of ball rolling movement present, no history of melena, no history of hematemesis, no history of backache, no history of any altered bowel habits, history of loss of weight was there, no history of loss of appetite, no history of jaundice, no history of cough with hemoptysis, no history of pedal edema. Past history: patient had a history of recurrent abdominal pain for the past 5 years, for which she took medication from local pharmacy. No comorbid illness, no history of previous surgeries, no history of chronic NSAIDs intake. Personal histories: history of irregular diet habits was there, no spicy food intake, not a known smoker, alcoholic or tobacco chewer, normal bladder bowel habits. Menstrual history: age at menarche 14 years, LMP 31/1/2022, normal cycle 4/30 and moderate flow. Obstetric history: age at marriage at 21 years, P0L0A1. Family history: no relevant family history. Summary: a 30-year-old female with low socioeconomic status with no comorbid illness presented with vomiting, ball rolling movements, upper abdominal distension and loss of weight, and history of abdominal pain, loss of weight and history of recurrent abdominal pain, is possibly suffering from upper GI pathology. General examination: after getting consent from the patient, abdomen exposed from nipple to mid-thigh in bright light, patient conscious oriented, thin built and poorly nourished, afebrile, hydration fair, pallor present, no pedal edema, cyanosis, clubbing and icterus, no generalized lymphadenopathy. Vitals: patient sitting position, BP 100/70 mmHg, pulse rate 80 per minute, temperature normal, saturation 98% in room air. Examination of the abdomen.
Before going to the examination of the abdomen, summarize the history so that which system or which part of the body you are going to examine.
Patient is a 30-year-old
First slide,
female.
go from first slide. Yes, what's the positive histories you elicited?
Patient has a history of vomiting for the past 1 year and a history of abdominal distension for the past 3 months after food intake, which relieves after food vomiting. History of ball rolling movements was there. History of loss of weight was there.
So main complaint is vomiting.
Oh.
On elaboration of the vomiting, can you able to pick up anything? Which type of pathology or things happen to the upper GI system?
At an obstruction.
So what are the types of vomiting? Why vomiting occurs? Can you elaborate?
Vomitings can be projectile or non-projectile.
Yes,
Bilious
projectile occurs in which condition?
Any pyloric stenosis, there will be
Not only pyloric stenosis, any gastric
Any
outlet
gastric
obstruction.
obstructions.
Okay.
And medical causes like intracranial tension.
Tension, yes. Yes, projectile vomiting. Then what else? You'll elaborate with vomiting.
Bilious and non-bilious vomiting.
Why bilious and non-bilious?
If it's non-bilious vomiting, the obstruction is above the second part of the duodenum. If it's a bilious vomiting, the obstruction is distal to the second part of the duodenum.
So all gastric outlet obstructions will be non-bilious only. Okay. Then what else will elaborate in vomiting?
And blood stain, not blood stain. There is no recent hemorrhage bleeding inside the upper
What are the
GI.
conditions? What are the conditions?
Gastric ulcers, duodenal ulcers,
Bleeding gastric
peptic,
ulcers.
bleeding peptic ulcers,
Erosion of the gastric.
peptic ulcers,
Gastric
esophageal varices,
varices, yes.
uh,
Barrett's esophagus.
Barrett's
Malarious
esophagus,
syndrome. Malarious syndrome. Then
Malarious
malignance.
syndrome, Boro
You should
syndrome,
not miss the malignancy.
malignancy,
And drug-induced.
drug-induced NSAIDs.
Okay. How will you differentiate between hemoptysis and hematemesis by history?
Hemoptysis, there is coughing out of sputum with streaks of blood over within the cough.
Only streaks of blood, coughing.
Frank,
The streak where? It will be frothy.
frothy
Frothy.
streak of bloods will be there.
It will not be altered color.
And altered color, and in case hematemesis, there will be frank blood or there is any
Altered
stasis,
blood mixed with the
coffee ground color will be there,
mixed with the food particles.
food particles.
Okay. Then what else in the vomiting? Projectile, non-projectile,
Bilious, non-bilious,
bilious, non-bilious,
Blood stain.
mixed with the blood or not. Then what else? Aggravating
color of-
factor, relieving factor.
aggravating factor.
Yes. What is aggravating factor, relieving factor?
In case of gastric ulcers, food intake will aggravate the pain, gastric ulcers. In duodenal ulcers, and vomiting will reduce the pain in the gastric
Yes.
ulcers.
What is the type of vomiting you call this?
Sir?
What is the type of vomiting? Vomiting produced by the patient to relieve the pain. Induced vomiting. The patient put the finger and induces vomiting so that he relieved of the symptom. That is especially in gastric outlet
Gastric outlet
obstruction. Complicated gastric outlet obstruction or duodenal ulcer complicated. Okay, what else? What else vomiting occurs? Where else? Only we are concentrating on the gastric outlet. Anything proximal which causes vomiting? Proximal issue.
Upper
Yes, what
esophageal
about
junction.
OG junction?
OG junction.
OG junction problems. What are the things that occurs in OG junction that causes vomiting? Or induced vomiting even?
Stricture esophagus, esophagitis,
Stricture
GRT,
esophagus is an uncommon condition, right? It is
GRT,
followed by any yes.
gastroesophageal reflux disease,
No, not gastroesophageal reflexes. Obstruction.
That should not be called as vomiting, it's actually regurgitation.
Dysphagia, yes.
Anything
That
coming
is-
above OG junction, that's only regurgitation.
Dysphagia, that's also patient produces left out the vomit. Okay. Yes. Yes, Professor.
Have you mentioned about the frequency of vomiting? You told that the vomiting is there for 1 year.
yes sir.
You have not mentioned about frequency. You know, is
That's
he
a
vomiting
gradual-
daily or
Daily
weekly
after-
once or once in a month?
that's
And
a-
what's the frequency per day? Because vomiting once a day is different from 10 times a day for this much duration. Okay.
was a gradual increase in frequency of vomiting, sir.
Frequency also increased with the duration.
With the duration, increase
In
in
which condition you get such an increase in frequency with duration?
case of full-blown obstruction, patient will have frequency in
Frequency of vomiting will increase. So for completion, you should mention about frequency. Okay. Because few of the conditions, patient will vomit once in a week or once in a month, like that. No?
When you have feculent vomiting,
in case of intestinal distal to second part of duodenum, that is distal obstruction, intestinal obstruction, fecal have fecal vomiting.
not feculent vomiting or gastrojejunocolonic
Fistula.
fistula, it's a major complication of gastrojejunostomy.
Ulcers. No history of melena, no history of hematemesis, no history of backache.
Is the weight loss significant or
Here the weight loss is maybe due to repeated.
in this patient you described about the loss of weight is there?
Sir.
Is it significant weight loss or
Significant weight loss, sir.
why do you say it as significant weight loss?
Patient had a chronic history of vomiting of 1 year, and patient had poor nutritional intake because of vomiting, and there's a fear of vomiting after every food intake.
Patient has lost weight.
Yes, weight.
When will you call it as a significant weight loss?
More than 10% of total body weight within 6 months. Within 6 months.
6 months or less.
6 months or less.
Loss of weight at
6 months or less.
10% or more over a period of 6 months or less. Okay.
Yes.
So this patient has got significant weight loss.
Yes, sir.
So what does it signify in this patient? Patient has got vomiting and significant weight loss. Is it giving any clue to you for the diagnosis?
Significant weight loss will leads to any malignancies, but
Weight
patient
loss will lead on to malignancy.
What's the inference? Weight loss, vomiting, inference.
Here the weight loss may be due to poor food intake.
poor
Poor
nutritional intake.
nutrition. Okay. What is cachexia? Cachexia especially occurs in malignancy.
Malignancy due to malignancies.
How will you explain the cachexia, malignant cachexia?
In malignancies, because of
What is the difference between starvation cachexia and malignant cachexia?
in malignant cachexia, there will be increased basal metabolic rate, increased of tumor necrosis factors and interleukins that will cause us
In malignant cachexia there will be muscle loss, will be more, whereas in starvation
fat
loss will be there. That is irreversible. Malignant cachexia is irreversible. This can be reversible. In this case, what do you consider this weight loss? Whether it is due to malignant condition or not, with history?
It's because of poor nutritional intake, sir.
Okay.
Past history of recurrent abdominal pain for the past 5 years, for which he took medication from nearby pharmacies. No comorbid illness, no history of previous surgeries, no history of chronic NSAIDs intake. Personal history, patient had a history of irregular
What
diet
is the
habits.
importance of previous surgery? Vomiting of one year duration. What is important? What previous surgery is important?
Patient had any vagotomies, truncal vagotomy. Previous history of truncal vagotomy, patient was bile reflex vomiting will be there, and bile reflex gastritis will be there.
What are the complications of these surgeries? Vagotomy and gastrojejunostomy complications.
In vagotomies, patient will had post vagotomy diarrhea and bile reflex gastritis. In case of truncal vagotomy, the hepatic branches will also severe, so there will be stasis of bile in the gallbladder, so gallstones will be there, and dumping syndrome will be present.
Early dumping and late dumping syndrome. Okay.
Early dumping and late dumping syndrome. Early dumping syndromes occurs within 30 minutes after the meal intake, and late dumping syndrome occurs 2 hours after the meal intake.
What is the main problem with early dumping syndrome?
It's because of
Hyperglycemia.
rapid gastric emptying that causes increased spanchling circulation, so the extravascular collection fluid will be lost. Patient will go for hypotension. And in case of a late dumping syndrome, patient that because of rapid gastric emptying, all the food particles get into the small bowel will leads to increased high glucose level, that in turn causes increased insulin level, which leads to reactive hypoglycemia. Then in early dumping syndromes, these dumping syndromes can be reduced by low carbohydrate diets, and will take high proteins and fat diets. And
Okay. Apart from dumping syndrome, what are other complications of vagotomy and gastrogenesis? Stomal ulcers.
Stomal ulcers will be there, and if we do
Then gastrogenocolonic fistula
will be there.
Then what else? Reflux gastritis. There is no JJ or Roux-en-Y done reflux gastritis. Then
Afferent loop syndrome and efferent loop syndrome will be there.
Yes.
Gastric atony will be there.
Then any hernias? Hernia behind
Stammer's hernia.
Peterson hernia. Okay. So these are the complications you have to expect. On malignancy, how long it takes for malignant change for gastrogenesis site go for malignancy?
15 to 20 years.
Yes, minimum 15 years.
The duration is, it should be more than 5 years actually. Usually it takes 15 to 20 years, but any malignancy arising within 5 years of previous gastric surgery should be considered as de novo malignancy. It should not be attributed to GJ. So there is a definition of actually stump gastric cancer. Stump gastric cancer by definition is any malignancy arising in gastric stump 5 years after gastric surgery. If anything occurs, if malignancy occurs within 5 years, you should not attribute this surgery to the development of malignancy. So it is otherwise de novo malignancy. 5 years.
So is there any pain abdomen in this patient?
Pain.
No, the explanation of the pain. Pain was there or not? This patient. Patient had pain or not?
History of abdomen pain was there.
How long it was there?
5 years.
So is any periodicity of pain is there?
Yes, periodicity was there, sir.
Okay. How it was relieved and aggravated? Any aggravating factor, relieving factor?
Patients, after every food intake, patient had pain, sir. It relieves by vomiting only.
So what are the nature of pains you get in upper GE?
Upper G.
What are various types of pains and abdominal pains?
Colicky pain, which is a gripping type of pain, and followed by throbbing pain seen in cholecystitis and hepatitis. Burning type of pain in case of diffuse peritonitis. Colic pain you see in ureteric colic and biliary colic.
Different colic. How will you explain the colic pain? How it occurs? It occurs all of a sudden. It goes
sudden sharp gripping pain will be.
Then it goes off. Examples of colic pain?
Biliary colic, ureteric colic.
Ureteric colic, yes. Worm colic. Okay.
Any intestinal obstruction also, colic pain.
Here, what type of pain the patient experienced?
Patient dull aching pain.
Dull aching pain where?
Mid epigastrium and right hypochondrium.
Any radiation of pain?
No, sir.
What are the pain that radiates in the epigastrium to the back?
In case of in my cases, pain radiating back is because of any ulcer that posteriorly penetrates to the pancreas.
Yes, penetrating
to the pancreas, it causes pain. And
infiltration.
Infiltration.
CS stomach infiltrated the pancreas or perforated, posterior perforated peptic ulcers or stomal ulcers. Stomal ulcers radiate to the back. What is migratory pain? What is shifting pain? Migratory pain especially occurs in the perforated, any gas contents of the intestinal abdominal cavity, there is a leak. Wherever there is bone collection, it causes pain. That is migratory pain. Suppose posterior cell perforate, gravitates to the right paracolic gutter to the right iliac fossa. What is the condition called?
Valentino syndrome.
Yes, Valentino syndrome. It mimics appendicitis. Simply that is migratory pain. What is shifting pain?
Change in position.
With the change in position of the viscera, the pain shifts,
Shifted
that is
from
shifting
one
pain.
region to another region.
What is the difference between radiating pain and referred pain?
Sir?
Referred pain and radiating pain.
Referred pain is same dermatological supply.
Where the pathology area don't experience pain,
pain.
the other area
Some other
experience
areas
pain. That is referred pain. Radiating pain
pertaining to
from
around
the
and around the
primary region to the experienced region, there is a continuity.
continuity.
Pancreatitis.
Pancreatitis.
Acute pancreatitis. Epigastrium to the back, there is a continuity. That is
Radiating
radiating
back.
pain. So these are types of pain.
Pain.
Okay. What is the aggravating factor, leading factor with relation to food? How will you diagnose the acid peptic disorders? Food aggravates the pain, food relieves the pain.
Food aggravates the pain in gastric ulcer and food relieves the pain in duodenal ulcer, sir.
Yes, what happens in duodenal ulcer? Food relieves the pain, patient takes on food, they
Patient
put
keep
on
on taking on food. Patient will become, there will
Weight
be no
gain.
weight loss. Patient gains weight actually.
gains. Okay. Summary.
A 30-year-old female with low socioeconomic status with no comorbid illness presented with vomiting, ball rolling movements, upper abdominal distension, loss of weight, and history of recurrent abdominal pain is possibly suffering from upper GI pathology.
There's a non-projectile vomiting and ball rolling movement. How will you correlate? Ball rolling movement occurs in which condition?
Any outlet obstruction,
Outlet
there will
obstruction.
be delayed emptying, so keep on peristalsis of the muscles, so ball rolling movement will be there, sir.
Whether it is an
Ball rolling
exaggerated,
movement occurs in gastric outlet obstruction, that's all.
Sir?
exaggerated
Answer should be
perception.
only like this, no? Ball rolling movement. Sir asked what's the cause of ball rolling movement?
Any
It is due to the gastric outlet obstruction. That's
gastric outlet obstruction.
I think it is an exaggerated peristalsis against a resistant. Huh?
So this upper GI symptom pathology. What are the other upper GI symptoms you know of? As sir said, lower esophageal obstruction causes dysphagia. What are types of dysphagia you know? Dysphagia, how will you quantify the dysphagia? To liquids and solids, how will you arrive at the diagnosis? Dysphagia to both liquids and solids, what is the condition? Dysphagia to solid alone followed by liquids, what is the condition? Any motility disorders, there will be
Achalasia cardium.
there will be dysphagia to both solids
Both
and
solids and
liquids.
liquids.
Whereas mechanical obstruction produces first initially
patient
to
with
solids
solid,
followed by
then with liquids.
liquids. What is the minimum luminal diameter that is required for the passage of food in the esophagus? It is 14 millimeter. Minimum 1 centimeter must be there. Okay. So dysphagia. What are the other causes of dysphagia? Apart from Boji junction problem, achalasia cardia. Then, what are the conditions you know of dysphagia? Motility disorders. What else? Strictures esophagus.
Satsky ring, stricture esophagus.
Yes. What is the investigation of choice for this dysphagia?
Barium
Esophagus, esophagus
Barium
imaging.
barium
Barium
swallow.
swallow in which view?
Lateral
Oblique view. Right, lateral oblique view. Okay, apart from dysphagia, what are other upper GI symptoms you know? Regurgitation, what about regurgitation?
reflex esophagitis, there will be regurgitation.
What is the difference between regurgitation and vomiting? Regurgitation is antiperistaltic movement of the stomach to empty the contents into the esophagus. Which condition it occurs commonly?
GRD, gastroesophageal reflux disease.
Reflux disease. What else you can get? regurgitation, dysphagia. What else we can get? Belching, bloating.
Bloating.
Yes, belching occurs which
dyspepsia.
condition? Due to the diet or anxiety. Psychological, the patient go and swallow the food to produce, swallow the air to produce belching. Now, what are other psychological conditions you know of? In upper GI. Globus hystericus. What is globus hystericus? The patient feels something in the throat. That is globus. Then anorexia nervosa. What is anorexia nervosa? The patient will not take
Get fear of
taking
fear of
food and
eating.
lost the weight. That's one of the causes of loss of weight. Okay, go ahead. The examination.
What's the diagnosis? Finished, na? Please describe knowledge.
Examination, sir. Examination of the abdomen. After getting consent from the patients with the abdomen exposed from nipple to mid-thigh in bright light, inspection, a fullness noted around the umbilicus, hypogastrium and right lumbar region. All quadrants of the abdomen moves equally with respirations. Umbilicus in midline, umbilicus everted and not flushed with surface. Visible gastric peristalsis present. No sinus, scars or dilated veins. No visible epigastric mass or organomegaly. Left supraclavicular fossa free. Bilateral hernial fossa free. Bilateral renal angle free. Umbilical orifice free. External genitalia normal. Palpations, not warmth, not tender. No palpable mass is present. No palpable organomegaly. Succussion splash is present. Percussion, osculus scrapings done. Borders are marked and found to be below the umbilical level. Impaired resonance present over the umbilicus region, right hypochondrium and hypogastrium. No shifting lens or thrill. Bowel sounds present. Left supraclavicular fossa, no free, no nodes palpable. Perectal examination, sphincter to normal, no pile mass, no nodes palpable. Perivaginal examination, cervical os closed, anterior and posterior pharynx, no nodes palpable. External genitalia normal. Other systems, CVS, S1, S2 head, RS, NVBS, CNS, no focal neurological deficit. A diagnosis, case of gastric outlet obstruction due to cicatrized duodenal ulcer.
You described visible gastric peristalsis seen.
Yes,
no?
yes.
Why do you say it as a visible gastric peristalsis?
There is a movement of visible peristalsis present in the epigastrium from left to right.
So any peristalsis from left
side
to
to
right,
right.
you will describe as visible gastric peristalsis. Intestinal peristalsis also can be seen from right to left or left to right. So peristaltic wave seen in the upper abdomen from left to right constantly. What is the frequency of visible gastric peristalsis? What is the normal frequency of gastric peristalsis? What's the normal peristaltic gastric peristalsis frequency? 3 per minute.
3 per minute.
Right? Okay. You described in palpation that there is no organomegaly. You should specifically tell that there is no hepatosplenomegaly. Right?
Yes.
Then no other organs, no other mass or organ felt. You should rule out hepatomegaly and splenomegaly. You should mention it.
So impaired resonance over the umbilicus region, right hypochondrium, what do you infer from the impaired resonance?
Distended stomach with fluid-filled distended stomach present with impaired resonance. And in case of any mass within a hollow viscous organ, impaired resonance will be seen, sir.
Yes.
In my case, it's because of distended stomach, fluid-filled distended stomach.
So you said auscultopulmonary scraping, borders marked.
Yes.
Just marking enough, or you want to say it's a dilated stomach or not?
Yes, sir. Borders marks and there's a dilated stomach.
So in this picture you clearly mentioned whether it's a dilated stomach or not.
Yes, sir.
Yeah, that's why there is a impaired resonance. You have to say like this. Succussion splash, how long the patient take food before you are doing the test?
Patient should stop taking food for past 3 hours, solid foods for 3 hours and liquid diets for 2 hours, sir.
No shifting dullness you have mentioned. Shifting dullness should be looked for in which condition?
Malignant.
Flanks full. This is flank full.
No, sir.
Flanks full or free?
Free, sir.
Free. Then how will you elicit shifting dullness? When the flanks are full only, you
Only
have to
we
look for
mention
shifting
yes.
dullness. When the abdomen is grossly distended with the fluid, look for thrill. Fluid thrill. Shifting dullness, flanks full.
What is flank? Very basic question.
Flanks is a region bounded by costal margin above, below, iliac crest, anterior axillary line above, posterior axillary line below.
Not above, below, anterior axillary, posterior.
Posterior.
Per rectal examination, you have simply said it is normal. What are things?
Sphincter.
Per rectal examination, normal you have mentioned.
Sphincter tone. If any bile mass is there or any nodes, malignant nodes.
Malignant nodes.
What about fecal signal?
Per rectal examination. Per rectal examination, what are things you look for? PR examination, digital examination. Otherwise, you have to put a word.
DRE.
Digital
Rectal
examination. What are things you have to note? The patient is suffered for 5 years duration, acid peptic disease symptoms, right? With vomiting. So,
I'll see the
what
color
are things?
of the I'll see the color of the stool.
Yes.
And
especially look for melena.
Melena.
What is melena?
Malodorous, black, tarry stool that sticks on pans.
Pan. How much blood is essential to produce
50
melena?
to 60 ml of.
Where should be the bleeding?
It should be up to the level of ligament of Treitz.
Yes.
Up UJ bleed.
Yes, those things you have to look for. Is a digital examination. Okay. Umbilicus.
Umbilicus in midline.
You have to specifically say any nodules present in the
Sister
umbilicus.
Mary Joseph nodule, Sister malignant nodule, sir.
Nodule present or not, you have to specifically mention. If there is any nodule in the umbilicus, what it signifies? Your plan of management. By simply looking at the nodule in the umbilicus, how will you?
It's maybe a malignant nodule. It's a sign of inoperability.
It's a sign of inoperability. Okay.
Why do you say it as benign chronic duodenal ulcer? Your diagnosis is chronic duodenal ulcer. Gastric outlet obstruction due to chronic duodenal ulcer. Why do you say it as a duodenal ulcer? Why not malignancy? Tell the points in favor of duodenal ulcer and point against malignancy.
Age of the patient, 30-year-old patient, from low socioeconomic status, duration for a period of 1 year.
Low socioeconomic status, is it in favor of malignancy or benign? I don't think that's one factor. Okay. Young age?
Vomiting for a period of 1 year.
1 year, so prolonged duration.
1 year. And then history of recurrent abdominal pain for the past 5 years is there.
Okay. Past history of pain suggestive of peptic ulcer disease.
Peptic ulcer disease. And there is obstructive features.
You should enumerate points
Loss of weight.
from history and findings. Right? And the varsayila sollunga apdi.
Age.
Young age, prolonged duration 1 year.
Age, duration of symptoms, and then other associated symptoms, obstructive symptoms due to gastric outlet abdominal distension, ball rolling movements, followed by the past history of peptic ulcer
Presence of
disease.
VGP, is it in favor of benign or malignancy?
Benign.
Why?
VGP. It can occur in malignancy also.
Yes, sir.
Then
Malignancy, but in which condition it is more common and more prominent? It is in favor of benign condition.
Benign condition.
Because obstruction is a prolonged one. So stomach becomes grossly dilated with prolonged obstruction only. So you can get VGP in malignancy also, but common is benign condition. and more prominent also.
Also the dilated stomach, because malignancy produces contracted, somewhat contracted stomach. If there is a gross dilatation of stomach with VGP, you have to think in terms of benign conditions.
What else? Tak tak nu solunga.
Examination same patient, this H. pylori will cause
H. pylori.
Don't stick on to H. pylori. Increased acid production, decreased barrier protection. Okay.
Loss of there will be normal barrier
That's
protection
a
will be
basic
there.
thing. Other things you have to contribute. Which are H. pylori, neonatal drugs.
Disturbance in the defense mechanism.
Defense mechanism, low bicarbonate secretion, low mucus secretions, low epithelial proliferations will be there, and low blood flow will be there. Loss of
What are the conditions that produce increased acid production? What are the conditions that produce defective barrier protection? Increased acid production, what are the conditions? Stress, anxiety, then any
stress,
syndromes?
anxiety, any Zollinger-Ellison syndromes,
syndromes.
lymphoma and sarcoidosis. All these cases will cause increased
Young age, increased vagal tone. This patient also 30 years.
30
But
years.
usually male will have more vagal tone, right? Defective mucosal barrier occurs in which condition?
This H. pylori will cause defective.
Why you are seeking out
acid,
H. pylori?
any acid,
Pernicious anemia, right? Pernicious anemia.
pernicious anemias. There's autoantibodies against these parietal cells and chief cells.
Apart from the blood investigation, what else will you do?
Upper GI endoscopy will do. Upper GI endoscopy to look for any ulcers, to look for any malignant lesions, to look the site of obstructions.
So in this case, what do you expect?
It will be obstruction at the duodenal level, first part of duodenum.
Duodenal? Where is ulcer common?
Lesser curvatures.
The duodenal ulcer. In this case, where do you expect the ulcer
D1
sited? Duodenal bulb. This is called
duodenal bulb.
Duodenal first part is of 2 inches length. Okay. The first inch is called a duodenal bulb, and the second inch is called a post bulbar area. It is called bulb because there is no mucosal fold like antrum. See, if you see the stomach, the antrum is devoid of mucosal fold. It is flat. Body and fundus will have longitudinally coursing rugae. This is called mucosal fold. Mucosal fold stops short at the antrum. So similar to antrum, the duodenal bulb is devoid of mucosal fold. Duodenal ulcer is common in duodenal bulb. So you expect an ulceration in the duodenal bulb with the cicatrization and obstruction. Okay.
By doing endoscopy, can you
Will
diagnose?
you take biopsy or not? Okay. Will you take biopsy from the duodenal ulcer or not to confirm that it's a benign non-malignancy?
Most of the duodenal ulcer is non-malignant.
You say yes or no, then you describe. Will you take biopsy?
No, sir.
No, why don't you take biopsy?
Because duodenal ulcers, most of the duodenal ulcers are non-malignant, sir. Only gastric ulcers are malignancy.
So duodenal ulcer does not warrant biopsy confirmation. You need not take biopsy from the duodenal unless you strongly suspect malignancy. If you find everted edge, nodularity, like that, you take biopsy. Any from any. Otherwise, it is not necessary.
There is lack of mucosa, right? Fear of complications of taking biopsy. What are the complications? Perforation, bleeding. If you take anteriorly biopsy, perforates. Posteriorly, gastroduodenal artery bleeds. And rare malignant site. 90% of duodenal ulcers are benign only.
Yes.
By doing endoscopy, can you rule out Zollinger-Ellison syndrome?
We can find only ulcers. In Zollinger-Ellison syndrome, there will be ulcers on the stomach, duodenum, and all small bowels. Only by gastrin level, we can fasting gastrin level only we can identify Zollinger-Ellison syndrome. That will be more than greater than 200 picogram per ml, and the maximum of 1000, greater than 1000 picogram per ml indicates strongly diagnostic of Zollinger-Ellison syndrome, sir.
Sometimes a distal duodenal ulcer also you can come to an inference.
You mean post-bulbar area. So I told that the ulcer is common in duodenal bulb, first inch of the first part of duodenum. So any ulcer located distal to the bulb, it's called in post-bulbar ulcer, duodenal ulcer. So you should strongly suspect Zollinger-Ellison syndrome. That's what he describes. What is pre-pyloric ulcer?
Pre-pyloric ulcer, the type 3 gastric ulcer, sir.
What is that? Is it a duodenal ulcer or gastric ulcer?
Gastric ulcers.
Gastric ulcer. So what is the importance of what is the definition of pre-pyloric ulcer? In what way it is different from other gastric ulcers? Anybody else other than presenter? So pre-pyloric ulcer is an ulcer situated within 2 centimeters of pyloroduodenal orifice. So if you do endoscopy, you will see a round pyloroduodenal orifice. So any ulcer situated within 2 centimeters is called a pre-pyloric ulcer. It is important because it can go in for gastric outlet obstruction. The recurrent ulceration will lead on to cicatrization. So that pre-pyloric ulcer can lead on to gastric outlet obstruction. This behaves as a duodenal ulcer, right?
Yes.
So generally the gastric ulcer is, the management of gastric ulcer is entirely different from duodenal ulcer, because duodenal ulcer is due to hyperacidity, whereas this is due to lack of mucosal defense, gastric ulcer, right? Gastric ulcer is common in
Old age.
insusura,
Lesser curvature.
insuraangularis. Pre-pyloric gastric ulcer is very close to the pyloric ulcer. Pyloric orifice. That should be treated as duodenal ulcer. That's important. Complications are more with pre-pyloric ulcer, obstruction, bleeding, perforation, everything is common with that should be treated as a duodenal ulcer. Right.
How will you prepare the patient for OGD? Overnight starvation and gastric lavage is
for 48
ideal.
hours.
Then, when you look at the inside the stomach, what are the characteristics of benign ulcer?
In benign ulcers, I look for the site of the ulcers.
Yes.
Site of the
What are
ulcer.
the common site? What are the classification?
Modified Johnson's classification there.
Okay.
Type 1 ulcer is present on the lesser curvature at the incisura. Type 2 is duodenal ulcer with gastric body ulcer. Type 3 is pre-pyloric ulcer. Type 4 is lesser curvature in at the proximal region.
Which ulcer bleeds commonly?
Sir?
Which ulcer bleeds profusely to produce hematemesis? Type 4 ulcer, incisura, why? Involvement of left gastric artery, whereas in duodenal ulcer, gastroduodenal artery.
Type 4 is called what?
Sir?
Type 4 ulcer is called?
Type 4 ulcers.
These are ulcers situated where?
Proximal lesser curvature.
High, that's called a juxtacardiac ulcer. Juxtacardiac ulcer. Okay, what type 5?
Anywhere in ulcer, due to anywhere in the body, anywhere in the stomach.
Multiple ulcers along the greater curvature of stomach is called type 5. What is it due to?
NSAIDs.
NSAIDs, most important. NSAID intake is very common nowadays.
What are the characteristics of ulcer? Site you are looking for, then?
Lesser curvature and size of the ulcer, it should be less than 2 centimeter. If it's more than 2 centimeter, we suspect of malignancy.
Yes.
And the convergence of mucosal folds towards the ulcer.
Yes.
Regular margins will be there.
Yes.
And,
what about edge?
the edge will be punched out due to
punched out or sloping edge. What about the floor?
Floor will be the granulation
tissues. No necrotic tissue.
No necrotic tissues.
Okay. Will take biopsy or not from gastric ulcers?
Definite biopsy should be taken from all quadrants of the ulcers. Minimum of 6 to 8 should be taken. Maximum 10 biopsies will be taken for a 100% diagnosis.
What are the other special enhanced things we can observe with endoscopes? Suppose apart from the ulcerative, benign ulcerative area, any area of suspicion of malignancy, how will you manage? What are the enhanced methods?
What are the other advanced endoscopy?
Chromoendoscopy.
Chromoendoscopy.
We'll do inject dye such as indigo garmin.
You will inject a dye.
Spray the dye.
You should spray the dye. Okay. Chromoendoscopy, one.
Confocal imaging, endoscopy. It enlarges, visualizes the cellular, to the cellular architecture level, it enlarges. So that we can change this.
So up to 1,000 times you can get magnification. Currently what is being used in our it's commonly available is NBA, non-NBA, narrow band imaging.
Narrow band imaging.
Narrow banding is inbuilt facility available in recent endoscopes. We have got in our department. So it's called a narrow band. Conventional endoscopy will not have NBA, the narrow band imaging technology. With the NBA technologies, there's a special mode in the handle. If you press that, the narrow band imaging features will be seen. You can differentiate benign from malignancy, you can differentiate the metadysplasia, differentiate adenoma from malignancy. Each and every pathology will have special features. You will have features in terms of modified vasculature and pits. It's called VS. VS means VS classification. And confocal endoscopy is a very advanced one. It is available only in research laboratories. So you will have 1,000 times magnification, right?
Still you suspect malignancy, you can do brush biopsies. Brush it, aspirate the contents, send it for cytological examination.
What will you do? So if it is a duodenal ulcer with obstruction?
With treatment of the ulcer followed by bypass surgeries will be done. And for treatment of ulcers, we will do truncal vagotomy with posterior gastrojejunostomy followed by H. pylori treatment.
So you prefer only truncal vagotomy and GJ?
GJ, or we can go for truncal vagotomy and pyloroplasty.
Pyloroplasty. What are the accepted procedures for the duodenal ulcer? What are various procedures other than this truncal vagotomy and GJ or pyloroplasty? Is there any other accepted procedure? Highly selective vagotomy is one. Another thing is truncal vagotomy plus antrectomy. The three are accepted procedures, among which we follow only this one. Because it is technically easy, failure rate is less common, and morbidity is less compared to vagotomy and antrectomy. Vagotomy and antrectomy will have more ablative effect that will decrease acidity, that will decrease acid secretion more than the vagotomy and drainage procedure. But since there is anastomosis, there is a little bit increase in the risk of leak and morbidity. So least morbid, technically easy, with less failure rates. That is why we prefer bilateral truncal vagotomy and draining procedures.
Suppose we do antrectomy, what is the anastomosis we will do? Usually we can do.
Billroth 1.
One we can do.
Billroth 1 anastomosis.
Billroth 2 is practically ideal, but Billroth 1 we can do because benign conditions.
Benign condition.
Okay, what is the loop? How will you select the loop for PGJ, posterior anastomosis? What is the loop, name of the loop called?
PV ring.
Mayo's loop.
Mayo's GJ, that is posterior, vertical, retrocolic, isoperistalsis, no loop or short loop gastrojejunostomy.
So that is a classical loop, but for practicality, there will be some conditions where mesocolon will be very short. We cannot introduce the loop. Another thing is the distance between lesser curvature and greater curvature will be short to have vertical loop. In these conditions, you have to modify on the table. You have to judge. You can do ideally anterior gastrojejunostomy, because if you do in this condition with a short distance from the lesser curvature to greater curvature, if you do vertical anastomosis, definitely you will end up in afferent loop or afferent loop syndromes, obstruction. You have to decide on the table. You can go for oblique anastomosis, or you can prefer anterior gastrojejunostomy. That is for practical purpose, but in exam purpose, you have to say only Mayo's typical Mayo's loop.
In laparoscopy, we do only anterior GJ. We do only anterior GJ. So the question of anterior, posterior, isoperistaltic, antiperistaltic, retrocolic or anticolic does not matter. Will you add JJ in addition to the GJ? Will you add jejunostomy distal to the GJ?
Yes, sir.
You do in your unit regularly?
Only if we suspect any afferent loop syndrome, we can go for JJ.
Afferent loop syndrome. See, for this case, you will be doing vagotomy and GJ. Will you add JJ bronze anastomosis called side to side.
Yes, sir.
Will you do that bronze anastomosis?
No, sir.
If so, why? Why do you want that? JJ is done, need not be done for this case, because adding jejunojejunectomy, otherwise called bronze anastomosis, does not decrease the incidence or severity of alkaline gastritis. So the complication that can happen with GJ is alkaline gastritis, otherwise called reflex gastritis. So neither the incidence nor the severity decreases with the adding JJ. So you need not add JJ. JJ should be done in after gastrectomy. That is not to prevent alkaline reflux. That is to
Bypass.
avoid stump blowout, duodenal stump blowout. If you add JJ, that will decrease the pressure on the duodenal stump. Say if there is a kink in the GJ stoma, bile gets pent up in the duodenal stump. You don't do JJ, the duodenal stump will blow out by 5th or 7th day, post-op day. So to prevent duodenal stump blowout in Billroth gastrectomy, you should
JJ.
always add
JJ.
What is the commonest cause of recurrence of peptic ulcer after surgery?
Sir?
Commonest cause of recurrence of peptic ulcer,
Failure of
otherwise called stomal ulcer. Failure of
treatment of H. pylori.
Failure
Failure of eradication of Helicobacter pylori.
Okay.
And then reflex gastritis after post-surgery.
Commonest cause is the non-identification of the vagal nerves and improper incomplete vagotomy is the cause of recurrence after peptic ulcer surgery, right?
What test you will do to find out the incomplete vagotomy?
I will do gastric function test, the whole under insulin test.
On table, how will you?
Whole under insulin test. Whole under insulin test I will do, sir. After administration of insulin, we'll check whether there is an acid secretion within the gastric insulin.
So it's dangerous. That is dangerous test. Okay, you have to bring hypoglycemia to 30 milligrams. It's a dangerous. Pentagastrin test available. Augmented pentagastrin or histamine injection test. What is criminal nerve crazy?
Criminal nerve crazy is the proximal branch of the posterior vagus nerve, sir. Which is usually, in case of truncal vagotomy, we tend to miss the criminal nerve crazy. For that, we have to go 5 cm above gastroesophageal junction, dissect the gastroesophageal junction, and find out the criminal nerve crazy, and we have to.
That supply which part of the stomach? Criminal nerve crazy. Fundus.
Cardiac and fundus region, sir.
Okay.
Fundus. That supplies fundus.
What is nerve or letter jet?
After giving that, both vagus nerve, after giving that hepatic and ciliary branches, it runs along the lesser omentum, gives
the curvature. Okay.
lesser curvature, and gives the branches and forms gives gastric branches over the.
What is the appearance called?
Crow's foot.
Crow's foot appearance. Okay. Either you can do one vagotomy, you can do one side, or another vagus you can do seromyotomy. It is highly selective. Posterior vagotomy you can do. Anteriorly seromyotomy, highly selective vagotomy, to prevent this motor, to preserve the motor function of the stomach. Antral pump. Okay.
So what's the H. pylori eradication regime?
In H. pylori regimens, we either give for a triple therapy or quadruple therapy, madam. Both at recent guidelines, we have to assess whether the patient is allergic to penicillin, and patient had any macrolide resistance or greater than 15% of clarithromycin resistance. If so, we have to give it according to this. We can triple therapy. We can give PPI, proton pump inhibitor, with clarithromycin, amoxicillin, or metronidazole. We can give. In case of quadruple therapy, we can go. In addition, we will give bismuth.
What are other sites where this acid peptic disorders can occur apart from stomach? Ectopic sites of gastric mucosa.
Meckel's diverticulum.
Yes. What are the imaging? Suppose if you are doing endoscopy, you are doing, okay. Without endoscopy, any imaging help for diagnosing the benign ulcers
Barium meal.
or complications of benign ulcers. What is barium meal?
Barium will give 300 ml of barium sulfate.
Okay, we are giving taking picture. Okay, what are the findings you observe?
In gastric ulcers, you will find niche over the lesser curvature and corresponding notch over the greater curvature. And the ulcer crater will be above the lumen of the ulcers. There will be loss of rugosities will be there.
Loss of rugosity. Rugosal convergent will be there towards the ulcer. Okay, then
and then hourglass contracture and teapot deformity.
Complications. Okay. In case of duodenal ulcer, complication.
Trifoliate deformity, loss of duodenal cap will be there.
Duodenal bulb is lost.
Will you do double contrast or single contrast barium meal series?
Yes. Single contrast.
Is it called a double contrast or single contrast?
Double contrast.
What is the second contrast used?
Air.
Air. How will you introduce air?
We'll put effervescence initially solution, followed by effervescence solution, and followed by barium sulfate. When it reacts, it creates an.
First, you will give effervescent solution in a tumbler, then you will dissolve barium sulfate separately. That means you have not seen, you have not accompanied patient while doing barium meal series. Double contrast means, so it is what is commercially available barium sulfate is a carbonated barium sulfate solution. So if you dissolve the barium sulfate carbonated solution, that will emit air. So need not separately inject air or give carbonated things, right? So it is a carbonated barium sulfate solution. Whether it is a barium swallow or barium meal series or edema, the second contrast is only this.
The patient going out taking, you said, taking antacids for so many years. What are the complications of antacids? Solution.
The antacids combines with the hydrochloric acids and.
No, antacid solution, the patient is self-medication.
Achlorhydria.
What are the complications you can expect? Milk alkali syndrome, hypophosphatemia, sometimes hypermagnesemia, and calcium also, hypercalcemia, milk alkali syndrome. Okay. So this has to be given in patients of cardiac failure, renal failure with caution. Also, what are the complications of H2 blockers, cimetidine, ranitidine? What is the complication? Cimetidine complication, rashes, flushes, gynecomastia.
Duodenal ulcer.
Duodenal ulcers either go for bleeding, obstruction. Also go for bleeding and perforation, sir.
Perforation. So the patient goes into obstruction, you do vagotomy GJ. The patient bleeds.
Patient bleeds, I will start with, I will resuscitate the patient initially, and they will go for endoscopic mode of management. And endoscopy, I will go for electrocauterization with India glazes or sclerotherapy with ethylamine oleate, and hemoclips can be applied. If it fails, we can go for gastroduodenal artery embolization.
Embolization. Embolization for benign ulcer bleed.
Or you can go for operative surgeries.
No. That's not a treatment for this one. Embolization is not a treatment for duodenal ulcer bleed. So mainly conservative management with injectable PPIs, relative aspiration and all that, blood transfusion, do endoscopy. If feasible by endoscopy, if the ulcer bleeds actively, you can inject adrenal saline or any of the sclerosants. Or if you see a visible vessel pulsating and bleeding, you can apply hemoclips. Disposable clips are there, right? So if the patient bleeds profusely, then is there any role for surgery?
Sir, we'll take longitudinal incision over the duodenum. I'll open the duodenum and we'll put U-stitch.
Suture ligation of the bleeding vessel.
U-stitch ligation
That's
of
called
the
U-stitch.
U-stitch.
U-stitch. So you should ligate the gastroduodenal as well as the
transverse pancreatic
artery. So if the ulcer perforates,
we'll check whether the patient is stable or hemodynamic unstable. If patient is hemodynamic unstable, we go for if the size of the ulcer is less than 1 centimeter, we can go for primary closure. If it's greater than 3 centimeter, we can go for a serosal patch closure or with pelvic exclusion procedure. In unstable patient or in between 1 to 3, we can go for a patch closure with Graham's patch closure. If the patient is stable, you can go for.
Will you do definitive procedure or not? Vagotomy and the pyloroplasty
The
or
patient,
DJ?
if the patient is clinically hemodynamically stably, I can go for vagotomy and.
Provided it is a chronic ulcer.
gastric.
Chronic ulcer with the cicatrization.
Go for
in early stage, you can add the or else acute ulcer. There is no need for definitive surgery. That means no need to add vagotomy and draining procedure. Right? What is giant gastric ulcer? What is giant duodenal ulcer?
Giant gastric ulcer is greater than 2 centimeter.
3
centimeter.
Duodenum is 2.
2 centimeter.
Yeah, these giant ulcer means that will definitely go in for complication. So there is no role for conservative management, both for giant duodenal ulcer as well as giant gastric. That's why it is described separately as a giant ulcers.
Yes.
Thank you very nice presentation.
The next presenter is Dr. Saulos.
Good morning, everyone. I am going to present the case of neck swelling. 59 years old gentleman, Mr. Muniyaswamy, coming from Ramanathapuram, farmer by occupation with low socio-economic status, with chief complaints of swelling in the left side of the neck for past 2 months. History of presenting illness. Patient was apparently normal before 2 months. Then he noticed a swelling in the left side of the neck, which was insidious in onset. Initially, it was small in size in the upper half of neck of almost marble shape, which progressed to attain the current size.
No, marble has no definite shape.
Sir?
Is there any shape for marble?
Spherical.
Don't say like this in the examination. Right?
Yes. There is also history of hoarseness of voice present, history of cough with expectoration present on and off. And there is no history of pain over the swelling, and no history of difficulty in swallowing, no history of increased salivation, difficulty in chewing, difficulty in opening mouth. There is no history of oral ulcers, no history of deviation of angle of mouth or difficulty in closing eyes, no history of dyspnea, and no history of ear discharge, deafness, no history of nasal bleed, no history of fever, evening rise of temperature, night sweats, no history of altered bowel habits, no history of jaundice, hematemesis, melena, no history of trauma, no history of loss of weight or loss of appetite, and no history of any other swelling in the body. Past history, no history of similar illness in the past. Patient not known diabetic, hypertensive, epileptic, asthma, tuberculosis, thyroid disorder, or no previous history of radiation exposure, and history of excision biopsy done on the left side of the neck 1 week back. Personal history, he consumes mixed diet and there is normal bowel and bladder habits. History of smoking for 40 years, 2 packets per day. Alcohol for 30 years, one quarter twice a week. History of occasional tobacco chewer for 1 year. Family history, no history of similar illness in the family member, and no history of contact with open case of tuberculosis.
So before going first slide. So only complaint is swelling in the lateral swelling. Lateral neck swelling, right? What are the causes of lateral neck swelling? Quickly say.
Tubercular adenitis. Lymphadenopathy, tubercular adenitis.
Then?
Lymphoma.
Lymph node, anatomical, I am asking anatomical.
That are lymph nodes.
Swellings, lymph nodes, then lateral swelling. Submandibular gland, carotid body tumor, cystic hygroma, brachial cyst, sternum-mastoid tumor, cervical rib. Okay, you must able to tell 4 or 5 things. Also the midline neck swelling.
Thyroid swelling, thyroglobulin cyst, sebaceous bursitis, and nodal swelling.
Ludwig's angina, ranula.
Plunging ranula.
Okay. This patient has lateral neck swelling. Is it confined to the neck or it extends to the face also?
Slightly inferior to ear, it is extending, sir.
Okay. 2 months duration. Next slide. Upper neck. How will you account for hoarseness of voice in this patient?
There is a recent change in voice.
Either due to the node or primary elsewhere that cause hoarseness in this patient.
Both can be elicited, sir. Hoarseness.
Suppose it is both. How the swelling causes hoarseness of the voice?
Infiltration of malignant swelling into the recurrent laryngeal nerve can cause.
Where is recurrent laryngeal? Here. It could not be.
Deep.
So primary might have caused the
laryngeal
hoarseness of voice. Primary pathology in the
larynx, glottic region.
Okay. History of cough with expectoration. How will you account for cough with expectoration?
Any tubercular etiology and chronic smoker can present with COPD.
Okay. Next slide. No history of pain, then no positive history, right? We asked all these things. History of difficulty in swallowing.
To find anything related to primary.
Primary.
Yes.
Okay. Increased salivation.
Any oral tongue cancer can result in increased salivation, sir.
Okay. Difficulty in opening the mouth.
If any buccal mucosal tumor infiltrating into the masseter pit and temporomandibular joint can result in trismus.
Deviation of angle of the mouth.
If any parotid swelling involving the facial nerve.
It's not a parotid swelling, as per your.
Any occult primary parotid.
No. Where is the location of the tumor? In the angle. Okay.
Below the angle.
So what is the structure that passes in that area? Yes, it's related to the parotid only, but the swelling is not parotid as per your presentation.
Yes.
But it causes no history, you said, no history of deviation of the angle of mouth. We asked for that. Which nerve involvement
facial.
will cause? Which branch of facial nerve?
Branch.
Which branch of facial nerve that causes deviation in the angle of the mouth? Or drooling of saliva?
Marginal mandible.
Marginal mandibular nerve, no, because the location is typical for this patient. Okay. No history of dyspnea. Why you ask dyspnea? Yes, again, comparison to the upper airways. Yes, next slide. Next slide. This history is, why you asked, ear discharge, nasal bleed, altered bowel habits. Is relevant in this patient, altered bowel habits? Oral cavity, head and neck region, you asked all the histories,
yes, sir.
relevant histories. You are added altered bowel habits. Is it relevant in this patient or not?
Initially the
is it
swelling
upper neck swelling or lower neck swelling?
Initially it started in upper neck, sir. It also extended to the lower part of the neck also. So
which part of the neck swelling is relevant for altered bowel habits or abdominal complaints?
Level 5, 4 and 5.
4 and 5. Okay.
Supraclavicular nodes.
Yes. Okay, next slide. Okay, next slide. The past history relevant, personal history.
Smoker and
Smoker. Significant smoking. What is smoking index?
number of
Like
cigarettes.
this patient, what is smoking index?
Sir,
2 packets per BD. Okay. Next family
Packets
history.
is 80,
Examination.
sir.
Come to the examination.
more than general examination, patient conscious oriented, moderately built and nourished, afebrile, no pallor, icterus, cyanosis, pedal edema, no significant generalized lymphadenopathy.
When you
Vital-
call it as generalized lymphadenopathy, when you call it as?
If more than one group of lymph nodes are
Not more
involved,
than one group, 2 groups.
two
2 groups of nodes, non-contiguous.
non-continuous.
Okay.
Vitals, pulse rate 76 beats per minute, respiratory rate 16 per minute, abdominothoracic, blood pressure 120 per 70 mm Hg in left upper limb. Local examination of the neck, left inspection, swelling in lateral aspect of upper part of neck on left side occupying upper 2/3 of the sternocleidomastoid, inferior and posterior to left ear of size 10 x 6 cm and oval in shape, nodular surface, skin over the swelling stretch, well defined margin, and there is an incision scar present in left posterior triangle region, and no sinuses, dilated veins, visible pulsation over swelling, platysmal fold seen below the swelling, retromandibular groove not obliterated, restriction movement on turning the neck to the left side, trachea appears to be shifted to the right side. Palpation, and there is no warmth or tenderness in the swelling, and size is 11 x 7 cm, shape ovoid in shape, and there is multiple hard discrete swellings, largest measuring 4.5 x 3 cm, and the extent of swelling is upper border at the level of tragus, lower border 2 cm above clavicle, anteriorly up to 5.5 cm from angle of mouth, posteriorly along posterior border of the left sternocleidomastoid. Surface nodular, hard in consistency, well defined margin, mobility restricted, fixed to the underlying structure, skin not pinchable, trachea shifted to right side, the plane of swelling is deep to deep fascia, carotid pulsation felt on both sides, slightly pushed inwards on the left side, there is no fluctuations or pulsation over the swelling. And other examination of oral cavity, oral hygiene poor, halitosis present, lips normal, labial sulcus normal, gingival buccal sulcus normal, gums normal, buccal mucosa nicotine stains present, dental caries present, floor of mouth normal, anterior 2/3 of tongue normal, mobility normal, no deviation, hard palate normal, antitonsillar pillar normal, posterior pharyngeal wall normal, retromolar trigone free, opening of mouth normal, admits 3 fingers, bidigital palpation, no stricture or stone felt, no discharge from Stenson's duct, ear no discharge or perforation or polyp, nose no discharge, a polyp or a nasal deviation, scalp no ulcer or swelling, thyroid not palpable, examination of other lymph nodes, cervical node on opposite side not palpable, right supraclavicular fossa free, axillary area not palpable, inguinal region not palpable, other system examination were normal. Summary. A 65-year-old gentleman presents with chief complaints of swelling in left side of neck for past 20 days with history of 2 months with history of hoarseness of voice. On examination, multiple hard lymph nodes were enlarged and fixed at the level 2 to 5 on left side. Probably metastatic secondary neck with unknown primaries.
Why do you say it is a lymph node?
The situation of the node swelling is present at level 2 to 5.
I'm asking why not other structures? Why not fibroma? Why not neuro?
It is a lymph node.
Lymph node. Why do you say it is a lymph node? Anatomically, you are thinking in terms of lymph nodal swelling. Pathologically, metastasis. Why do you say it as a lymph node?
Any swelling in the neck, commonest swelling in the neck is lymph node. That is confined to the anatomical area of lymph nodes. That should be the answer.
So it is any neck node, any neck nodal swellings, if this question is asked, the answer should be It is a known site of lymph node, and lymph nodal swellings are common in that region, sir. So that should be the answer. Right? Right.
So what is the clinical finding you observed? Inspection, anything positive? It's a single swelling or multiple swelling?
Multiple swelling, nodular surface.
So anatomically, it occupies the lymph node. You said anatomically lymph node.
Lymph node.
Occupied which are the levels you said? 2 to 5. 5 with skin involvement.
Yes, sir.
Skin involvement, platysma sign. Also, there is a history of biopsy.
Yes,
also
sir.
on palpation, firm to hard consistency with posterior fixity. Fixity present.
Restricted movement.
Also restricted movement involving the which muscle? You said
Sternum
turning that head difficulty. Sternomastoid muscle involvement. So what do you infer from these findings? And no primary.
Could be detected.
Primary lesion clinically detected. Only thing we can able to examine clinically are the what are things you have to examine. Suppose if you consider as a secondary swelling, what are the primary areas you go for survey clinically?
In this case, since the upper part of the neck is involved, exam in the entire head neck region.
Entire head and neck, not only for upper part, lower part of swelling.
Okay.
Any neck swelling, if you are in doubt, you are not confident with your regional, the thyroid or parotid regions, and primary is unknown, you have to examine the whole head and neck region for any swelling. Okay, so head and neck examination, what are things you examine in the head and neck region?
Scalp, see, sir, any swelling or a lesion, ulcer.
Ulcer, lesion, swelling, yes. Then?
Oral cavity, see.
Ear cavity.
Ear.
You have mentioned polyp and all that.
Yes,
will there be any polyp in the ear? No need of mention all those things. No need of, no polyp, should not mention. Ear examination, that too external ear only you can examine. Middle ear you cannot go and examine. Tympanic member, up to tympanic member only external ear. Any changes seen in the external ear we can see. Any discharges, any growth. Then what else? Anterior nasal cavity only we can examine. You cannot go for nasopharynx examination.
Yes.
Then any infections of the eye. Parotid gland region. Any palpable mass in the parotid region you can examine. Then oral cavity proper. What is the extent of oral cavity proper? It starts from the Vermilion border
to the
anterior pillar, tonsil pillar, and anterior surface of the soft palate. What are contents of oral cavity?
Lips.
Buccal mucosa.
Alveolar process.
Sulcus. Gingival sulcus, gingival sulcus. Alveolar ridges, upper and lower. Alveolar ridges, hard palate. Flora of the mouth. Then tongue. Which part of tongue?
Anterior tooth.
Anterior tooth. Mobile part only you can see in the oral cavity. Beyond that, everything is oropharynx. Oropharynx contains what are structures? Tonsils, posterior pillar, posterior surface of the
tongue.
Tonsil, lateral wall of the pharynx, and posterior wall of the pharynx. That we can visualize some extent, oropharynx. But oral cavity examination, we can nicely see what are the findings, positive findings in the oral cavity in this patient.
This oral nicotine stains were present.
Nicotine stains. What are tooth formula? Any loosening of tooth?
Yes, sir.
Any absence of tooth? No. Okay.
The incisor, right incisor and central incisor, lateral incisor are absent, sir.
Melanosis, you said it is present, right?
Sir?
Lot of pigmentations.
Pigmentations.
Because of smoking. Okay, then what else we can examine? Oral cavity, anything finding? No finding. Positive finding you can observe, okay. Then what else we can examine? Thyroid, neck region, thyroid gland, salivary glands region. You have to examine, and tracheal position, whether the tumor pushes the tracheal position, have you mentioned?
Yes, sir. Pushes to right side.
Pushes to right side.
Shifted to right.
How a lateral swelling will push to involve the trachea? Only thyroid gland. It's a large extent. So this swelling occupies mostly in the angle of the mandible, but that groove is not also obliterated. Retromandibular sulcus is not obliterated. It's not a parotid swelling.
Not a parotid.
Parotid swelling. So clinical examination, primary surveying the primary area, you cannot able to find out any
primary tumor.
primary lesions. Okay, then how will you proceed this patient?
We can search for a primary tumor under anesthesia, sir. Examination under anesthesia. If any primary tumor is visible, and pan endoscopy should be done.
Have you done palpation of tongue? Have you put your glove hand to look for posterior one-third tongue? Clinical examination.
Yes,
Have you done it or not?
Yes, sir. No swelling palpable, sir.
Why you are
No
not
lesion.
told? Because that is important, very important. What is the level 2 node drains? Tonsillar fossa. Jugulo-digastric. Jugulo-omohyoid drains mainly which area? Tongue. These are specific nodes. Jugulo-digastric nodes. Tonsillar area, jugulo-omohyoid, tongue, posterior triangle node, nasopharynx. Nasopharynx. Okay. So accordingly, you have to look for, especially in this patient, jugulo-omohyoid node also involved.
Yes.
But clinically, you have to specifically tell. On clinical examination, you should not miss the examination of posterior one-third of tongue by putting your gloved hand. Patient will have gag reflex. You have to convince the patient, at least look for, you should not omit the any major lesion in the tongue.
Yes.
Then you have to go for what a pan endoscopy, right? In spite of what you told is, I will examine that general anesthesia. That is not routinely done, right? What you have to say is pan endoscopy, examination and surveillance biopsies. What are pan endoscopy?
Nasopharyngoscopy, laryngoscopy, bronchoscopy, upper GI endoscopy.
Endoscopy, okay. Surveillance biopsy, where are the sites you take biopsy?
Fossa of Rosenmuller, tonsillar fossa, posterior one-third of vallicula, posterior pharyngeal wall, lateral pharyngeal wall, and pyriform sinus.
Sinus. Can you do tonsillectomy?
If after surveillance biopsy, tonsillectomy is the next step.
It's also indicated on that same side. So swelling is on left side, you can do left side.
Left side tonsillectomy.
Tonsillectomy also. Okay, what imaging will you prefer in this patient?
MRI head, if any primary lesion is suspected in any area, we can CT on that area can be taken, sir.
Ultrasound, what about ultrasound in this patient? Is there any role? Ultrasound. Ultrasound examination in this patient.
To look for the nodal.
Any necrosis in the swelling? Necrotic area you can see, vascularity you can see. This is a very obvious, very enlarged swelling, which is small node. You can characterize the node whether it is benign or malignant. Subcentric nodes are 1 to 2 centimeter nodes, up to 3 centimeter. You have to look for changes of malignancy. Here it is clinically evident node of malignancy because posterior fixity, size, multiple nodes, skin involvement, etc. So no need for ultrasonogram in this patient, but for survey purpose by imaging you have to go for which image you will choose, CT or MRI?
MRI.
CT, multi-slice, multi-detector CT, MDCT. Spiral CT is the ideal one where it can make 2 mm of slices. So no area will be left over.
Yes.
Other side of the neck, not only neck, head and neck area, you have to screen from base of the skull to the clavicle for neck evaluation.
Yes.
Not only that, CT chest, CT abdomen, you have to make survey. X-ray, plain X-ray chest, you have to take. What is the role of MRI? When you take MRI?
If MRI, the primary lesion and extension can be detected, sir.
Yes, neurovascular involvement. Suppose mandibular nerve involved, alveolar nerve involved, whether perineural infiltration is there or not, we can go for MRI. Another advantage of CT is there is oral lesions, bony involvement.
Yes, bony infiltration.
Yes, bony. And while taking CT, suppose cheek lesions. Cheek lesions, cheek abuts the gingiva area. We cannot say there is a lesion in the cheek that abuts the normal gingiva. How to differentiate whether it involves or not by taking CT? Which image we will take? Puffed image, puffed cheek. You have to make the cheek puffing. If you take the image, you can differentiate whether there is a actual involvement or the lesion abuts the gingival mucosa, right? Suppose there is a trismus, difficulty in opening the mouth. This patient has trismus.
No trismus.
No trismus. Then what is the investigation? How will you evaluate? We can do Hopkins 90-degree endoscope. That is 5 mm endoscope. We can put inside the oral cavity and look thoroughly the oral cavity, oropharynx also. You can take biopsy. So, how will you histopathology confirm your diagnosis? What investigation will take?
FNAC from the no, sir.
Okay, FNAC, and if it not inconclusive, if it not coming out with the proper report, then what will you do?
True cut biopsy
True
can
cut
be
biopsy,
taken,
yes. Why not open biopsy?
Open biopsy should be planned only when we plan for a neck dissection.
Immediate dissection
Immediate
or
neck
frozen section is available. You have to plan, go for open
neck
biopsy.
open.
Otherwise, only true cut biopsy you have to do. What are types of things we can expect in the true cut
Mainly
biopsy?
squamous cell carcinoma can be seen, sir.
Squamous cell carcinoma.
Most
Then
common, sir. Adenocarcinoma is seen. Undifferentiated carcinoma will be seen.
Then what are other things that cause secondary deposits in the node? Melanomas.
Melanoma.
Okay, melanomas also. Why it is not primary malignant tumor of the lymph node? What are the primary malignant tumors?
Lymphomas.
There is no characteristics of lymphoma, rubbery consistency.
Rubbery consistency.
So
No
it's a
history of
typical
fever,
secondary node. Okay. So after proving, how will you manage? How will you treat the patient? If it is coming as squamous cell, what is the treatment? What is coming as adenocarcinoma, what is the management? This is a fixed node with the skin involvement, multiple nodal levels. How will you manage? Squamous cell carcinoma.
If adenocarcinoma means we can rule out the primary in parotid, salivary glands or thyroid, sir. After ruling out for treatment of neck nodes, if it
Not
is
only confined to the neck, you have to confine to the other, you look for other areas also, breast, then kidney, prostate, colon, pancreas.
Yes, sir.
Yes, these areas also has to be considered by making whole body CT
Yes.
for adenocarcinoma. Okay, primary has to be dealt, and for secondaries, is it operable or inoperable? Secondaries.
Already it is fixed to the underlying structure nearby.
Any fixed node, inoperable. Okay.
Inoperable.
So for inoperable things, what will you do?
RT should be given, sir.
Radiotherapy. Suppose it is squamous cell carcinoma. Again, inoperable.
Again, RT should be
only
given.
RT. What RT will choose? Only radiotherapy will choose or combined with chemotherapy?
Both the chemo radiation can be
Yes.
given in adenocarcinoma.
Because it chemosensitization will be there for radiotherapy. It will enhance the radiotherapy effect. How will you reduce the effect, complications of radiotherapy? What is the dosage for? Suppose screening, there is no chest and abdominal involvement. Other thing you have to look for is bronchogenic carcinoma also, right? The chest, it produces occult. What are three types? With non-primary, that is one type. Secondary node with unidentified primary, and third one is occult primary. So occult primary bronchogenic carcinoma is common. Okay. So what is the dosage of radiotherapy? 60 to 70 centigrade given in how many fractions? 30 to 35 fractions per day. 1 to 2 gray you have to give. How will you reduce the complications of radiotherapy?
Can apply shield over the thyroid.
Image guided radiotherapy, then intensity modulated radiotherapy, conformal radiotherapy. These are things. Then accelerated. What is accelerated radiotherapy? Then you can accelerate the dosage, or you can divide the dosage into multiple segments so that the complications are reduced. What are the complications of radiotherapy? Head and neck region?
Mucosal cirrhosis,
xerostomia, mandible necrosis, cataract formation, optic neuritis,
secondary malignancy, thyroid malignancy.
Okay. What is field cancerization? You have to look for field cancerization, right? What do you mean by that?
What's that?
Field cancerization. In case of genetically predominant patients going for malignancy chances, you have to survey the whole area, but there will be multiple areas of malignancies in the upper area digestive tract. Suppose if it is operable, what type of dissection you prefer? Squamous cell carcinoma, high grade.
Radical
neck dissection is done for high grade tumors, squamous cell carcinoma. Others are, we can plan for modified radical neck dissection. What are the types of neck dissections you know?
Radical, modified radical, functional neck dissection.
Modified radical, what are the three types?
Modified radical, we preserve three structures: sternocleidomastoid, internal jugular vein, and spinous nerve. Type 1, spinous nerve preserved. Type 2, spinous nerve, internal jugular vein preserved. Type 3, all the three are preserved.
Okay. What are the other selective neck dissections?
How will you decide which structure to be preserved?
Sir?
How will you decide which modification you will have to adopt? You described three types of modification.
Yes, sir.
Mainly
it depends on the on-table.
How will you decide what modification to be adopted for this patient?
Mainly decided on the on-table, sir.
How will you decide? Depending on the structure infiltrated by the node. That's all.
What are the selected types? Selective neck dissection. Supraomoid neck dissection is done for N0 neck nodes for oral malignancy. Then lateral neck dissection.
Thyroid.
For oropharynx, laryngopharynx, nasopharynx. Then posterolateral neck dissection for then occipital lesions. Preauricular nodes and occipital nodes also taken along with the lateral nodes. That is posterolateral neck dissection. Complications of neck dissection. What are the complications of neck dissection?
Flap necrosis, hemorrhage, yes. And carotid blowout, carotid artery injury.
Carotid artery injury should not say. You have to take care of the carotid artery while operating. Okay. Carotid artery blowout. Otherwise, carotid artery blowout after some days because of the dryness of the adventitia. What are nerves you preserved in take care of during dissection? What are various nerves? Marginal mandibular nerve, spinal accessory nerve, hypoglossal nerve, lingual nerve, then recurrent laryngeal nerve, then vagus nerve and phrenic nerve. Vagus nerve, which goes the carotid sheath, and phrenic nerve is protected by prevertebral fascia. That is, prevertebral fascia is the posterior limit. You should not go beyond that. What is the cause of phrenic nerve? What is the cause of brachial plexus? Identification. Brachial plexus come from medial to lateral, whereas phrenic nerve lateral to comes from lateral to medial. So preserve all this now. You have to preserve all this now. What is the difference between neck dissection of the right side and left side? Complication.
Left side we can injure the thoracic duct and cause a chylous leakage.
Why it is injured, thoracic duct on the left side? Why not on the right side? Because it goes and drains to the left side. How will you manage the thoracic duct injury? How will you identify what is the, how will you evaluate?
Ligation. You should ligate the thoracic.
Where, which level we can ligate? There are various methods: intrathoracic ligation, neck exploration and ligation, embolization, or putting flaps. Pectoralis major myocutaneous flaps.
Easy ways to clip by thoracoscopy.
Thoracoscopic approach also you can able to clip. Okay. Then chemotherapy. What is the chemotherapy?
Platin based therapy can be given. Cisplatin, sir.
What are the AJCC modification, the 8th edition regarding classification, staging of node, cervical node?
They include in tumor category, they include the depth of invasion as independent prognostic factor and extranodal extension in a nodal category, sir. It considered as 3B, sir.
3B, extranodal, any extranodal, clinically or imaging?
Clinically or radiologically.
Radiologically it is N3,
N3B.
3B. Pathologically, N1 nodes if there is extracapsular spread from N1 to N2A. From other nodes of any size, contralateral, bilateral, if it is there is extracapsular extension, P3B. That is a thing. If it is HPV related, is a good prognosis or bad prognosis? HPV, human papilloma virus for oropharyngeal carcinoma, and for nasopharyngeal carcinoma, what is the virus taken? Epstein-Barr virus, EB virus.
Yes,
Okay.
Epstein-Barr.
They consider as good prognosis.
prognosis.
Why they done this modification? Because there is a outbreak of this viral infection in the Western countries.
Yes, sir.
That produces lot of enlargement of the gland to produce this modification of this thing. Okay. Thank you for the presentation.
Thank you. Thank you. Thank you, sir. Thank you. Thank you, sir. I request Professor Padmanabhan to distribute the certificates to the presenters. Dr. Manoj Murugan. Dr. Saulos. I request Professor Selvaraj to honor Professor Padmanabhan. The next session will be chaired by Professor Saravanan Robinson, Head of Department of Vascular Surgery, Madurai Medical College. Professor Ganga Lakshmi, Head of Department of General Surgery, Sivagangai Medical College. And Professor Geeta, Professor of Surgery, Madurai Medical College. And the presenter is Dr. Gokul.
Good afternoon, sir. Sir. Good afternoon, sir. Good afternoon, ma'am. 36 years old male, painter by occupation, came with complaints of dilated veins in the left leg for past 1 month. History of presenting illness. Patient was apparently normal for 1 month, after which he noticed dilated tortuous veins in the left lower limb. Insidious onset, gradually progressive, more prominent on standing and less prominent on lying down. History of pain present for the past 1 month around the dilated veins, dull aching type, aggravated by standing and walking and relieved by lying down, more at the end of the day. No history of ulcer in the left lower limb, no history of fever, no history of left leg swelling. This is the clinical picture showing dilated veins over the left lower limb. No history of pruritus, no history of prolonged immobilization, no history of trauma, no history of previous ulceration, no history of bleeding from varicose vein, no history of abdominal distension, and no history of rest pain. Past history, not a known case of diabetes mellitus, hypertension, tuberculosis, bronchial asthma, epilepsy, ischemic heart disease. No previous history suggestive of DVT, no previous history of surgery, no previous treatment history for the varicose vein. Personal history, patient is a chronic smoker for the past 15 years, 1 packet per day, chronic alcoholic for the past 15 years, occasional, normal bowel and bladder habits, normal sleep and appetite, family history nil relevant. Summary, a 36-year-old male, painter by occupation, having no comorbid illness, complaints of dilated veins in the left lower limb for the past 1 month. Associated with the pain more over the end of the day, no history suggestive of DVT.
So with this history, your diagnosis?
Varicose vein present along the medial side of the leg and below the knee. It indicates varicose vein of the involving the great saphenous vein and perforator.
With this history, can you able to say whether it is perforator involvement or?
No, ma'am.
So refine your diagnosis.
Varicose vein involving the great saphenous vein.
Any other? Site. So
the dilated veins involve the medial side of the leg, ma'am. So involves the GSV territory.
So be simple. Varicose vein involving
GSV.
left lower limb, involving the long saphenous system.
Okay, ma'am.
Okay, proceed.
General examination, patient is conscious, oriented, afebrile, moderately built and moderately nourished, no anemia, pedal edema, generalized lymphadenopathy, icterus or clubbing. The BMI of the patient is 26.3. Local examination of left lower limb, inspection, dilated tortuous elongated veins in the medial aspect of the thigh in the GSV territory and below knee area. Not edematous, no active ulceration, no scar or sinus, no telangiectasia, no reticular veins, no pigmentation, eczema or atrophic blanche, no loss of hair or brittleness of nails, gait normal, attitude of the limb is normal. Palpation, no warmth or tenderness, no pedal edema, no lipodermatosclerosis. And specific clinical test to detect the varicose vein, Breuer-Trendelenburg test 1, which is positive, and test 2 is also positive, which implies saphenofemoral junction incompetence and perforator incompetence. Multiple tourniquet test, adductor canal below knee, lower leg perforator incompetence seen, which is 5, 10, 50 cm from the medial malleolus. Pratt's test, blowout seen in the adductor canal 3 cm below knee and 5, 10, 50 cm from medial malleolus. Fagan's test, perforator localized in the above said location. Schwartz test, impulse felt in the thumb at the saphenous opening. Morrissey-Coffey impulse test, expansal impulse felt. Modified by this test, patient no cramping pain or no dilatation of the supraspinous system. Systemic examination, cardiovascular system S1 S2 present, respiratory system normal vesicular breath sound, per abdomen soft, no palpable mass or organomegaly, no dilated veins seen over the lower abdomen. Central nervous system, no focal neurological deficit, pericardial examination is normal, the locomotor system examination normal. No regional lymph nodes palpable, all arterial pulses on both lower limb felt equally, no dilated veins seen in the right lower limb. Diagnosis, varicose vein involving great saphenous system with saphenofemoral and perforator incompetence without any complication, probably primary etiology. And the SEEP classification, clinical 2 staging when the patient is symptomatic, etiological it is primary, and anatomical both the superficial and the perforator system are involved, and in pathological reflex.
Why primary?
Because of the age of the patient, ma'am, in the middle age group, and it is present for the past 1 month. It rules out congenital etiology, ma'am, and no history suggestive of deep venous thrombosis, ma'am, in the examination and in the history. No previous history of DVT in the past. It rules out secondary, ma'am.
This veins, dilated veins are present for only 1 month. I don't think so. These are chronic conditions, will be present for a longer period. The patient might be noticed for the short duration.
Okay.
So your words should be properly mentioned as this patient noticed this will. Because by the history, I thought you are doing something related to deep venous occlusion with dilated veins. As per your acute history, with pain along the distribution. I had different things in my mind. As per your presentation, presenting with acute symptoms, probably superficial venous thrombosis. That's where it present with pain along the veins. And how will you do Brody Tendelberg's test? Just describe 1 and 2.
Sir?
Brody Tendelberg's test 1 and 2. How will you do?
So the patient is made to lie in supine in lying down position. Then the limb is elevated to empty the veins, and it can be augmented by the milking the veins. After that, the tourniquet is applied at the below the saphenofemoral junction, and the patient is asked to stand up. After releasing the tourniquet, if there is sudden fill from above downwards, indicates test 1 positive. It indicates saphenofemoral junction incompetence. And Brody-Tendelberg test 2, the patient is made in lying down position, and the veins are emptied, and the tourniquet is right below the saphenofemoral junction, and the patient is asked to stand up. If there is sudden filling from below upwards without releasing the tourniquet, indicates test 2 is positive.
The next test you describe?
Multiple tourniquet tests.
Where are the tourniquets being applied?
4 tourniquet will be applied, sir.
Where are they?
So first tourniquet will be applied above the ankle, and second one below the knee, and third one above the knee, and fourth one below the saphenofemoral junction.
What's the concept behind this applying tourniquets?
Sir, it indicates that segment of to identify the segmental perforator incompetence.
Each segment is being separated by each tourniquet, thereby filling indicates there is incompetence on that segment of that vein.
Okay, sir.
What is Schwartz?
Sir, Schwartz test, thumb is placed at the saphenofemoral junction. Then
where is the saphenofemoral junction surface marking?
4 centimeter below and lateral to the pubic tubercles. Then the dilated veins in the below knee region, tapping is done, and the moving column, that thrill will be felt at the thumb kept at the saphenofemoral junction, sir. It indicates single column of blood and valvular incompetence along that segment.
What is Fegans?
Sir?
Fegans.
Sir, Fegans test, it is used to see the perforator incompetence, which are all the sites it is present, it is used to see. The patient is made to lie in lying down position. After that, grip bandage is applied from below to the upward fashion. Then tourniquet is applied at the saphenofemoral junction. After that, the perforators are seen, sir.
How will you test for the deep venous competency?
Sir?
Deep venous flow pattern. How will you test?
Sir, the patency of the deep system can be made out by the modified Perthes test, sir. The patient, the prerequisite for the modified Perthes test, there should not be any perforator incompetence. The patient is made without emptying the veins. The tourniquet is applied at the saphenofemoral junction. After that, the patient is asked to walk. If the patient develops bursting type of pain associated with the dilatation of the superficial venous system, it indicates occlusion of the deep venous system, in turn causing dilatation of the superficial venous system and causing pain.
What is your final diagnosis as per your C?
Sir, varicose vein involved in the great saphenous vein territory with the saphenofemoral and perforator incompetence without any complication, probably primary.
Just give in SEEP system.
Sir, clinical 2S and etiological primary, anatomical both superficial and perforator are involved, and pathological reflex.
Is that pathological system been classified clinically?
No, sir.
How do you classify pathological system? What are the classes in that?
In pathological, it is divided into reflex, obstruction, both reflex and obstruction, and could not be identified N, sir. PN.
How do you do that?
Sir?
How do you classify your P?
Sir.
Based on
duplex ultrasound.
And, to my surprise, you never mentioned about the side in your diagnosis. You never mentioned about your side, which side the patient had. I suppose in your diagnosis,
Left side.
nowhere else you have mentioned about that.
So left side.
Now what do you want to do? Is your examination complete?
Sir, examination of the peripheral arterial system and locomotor system done, sir. Then varicosity over the lower abdomen also examined.
Varicose vein? You have to mention about any dilated veins over the abdomen is present or not.
Okay, sir.
And now how will you move about?
Apart from the routine investigation, non-invasive investigation will be preceded by the invasive investigation. Duplex ultrasound can be done. Then plethysmography.
What will you look for in duplex ultrasound?
I mean, duplex ultrasound, the perforator, superficial and deep venous system has to be examined, along with IVC has to be examined, ma'am. In the superficial venous system, saphenofemoral incompetence, saphenopopliteal incompetence has to be seen, along with perforator incompetence, and patency of the deep venous system has to be seen to rule out DVT, ma'am. Then,
so you
in case
define
of
the anatomy, physiology as well as the functional defect of the valves.
okay, ma'am.
Plethysmography is in still research stage. I don't think it's been used routinely. So I don't think you need to mention about unless it's been asked. So duplex ultrasonography is the gold standard as of now. There's no investigation like as MRI, CT or PET doesn't use. All those are static images. But you need a dynamic image to make a diagnosis in these cases. Now you have criterias for making a thing positive.
Sir,
Criterias for SF junction.
Sir, for the deep venous system incompetence.
I'm asking about SF junction ultrasonographic finding to call it as incompetence.
Sir, the reflex has to be present for more than 500 milliseconds, sir, for it to call incompetent.
Reflex more than 5 seconds to competence, competent or incompetent?
Incompetence.
Incompetent. That's 300 milliseconds. Anything below 300 milliseconds is normal. What about the perforators?
Perforator more than 350 mm will be coined as incompetent, and the reflex more than 300 milliseconds.
What is 350 mm? What do you mean by that?
Size of the diameter, sir.
Do you imagine 350 mm how much it will be? It's 3.5 mm rather than 350 mm.
3.5 mm.
3.5 mm. What are the perforators are for now? The concepts of perforator.
Sir, adductor canal perforator.
What is the perforators are now? Because previously when we were students,
Femoral canal perforator.
Huh?
Femoral canal perforator.
No, the perforator concept has been changed from years together. Previously when we were students, we were told it's the only thing which communicates from deep venous system, superficial system to the deep system. Now it's called as the buffering agents, which communicates whenever the deep venous pressure picks up, it communicates pressure to the superficial system. Whenever the superficial system pressure goes up, it communicates to the other system. That's why now the size of the perforators have been taken into account rather than the bidirectional flows and other things. Now, what do you want to do for this patient?
Sir, after establishing the diagnosis and after ruling out DVT, the patient is having saphenofemoral incompetence along with the perforator incompetence. Sir. So, as the patient is symptomatic, a trial of conservative management will be done, sir. The patient.
What are the symptoms the patient had?
So, patient is having pain, sir. Only pain.
What other symptoms you expect in this patient?
Patient can have edema, sir, lower limb edema. Then skin changes like pigmentation, eczema, lipodermatous sclerosis.
Your classification, it falls into C2.
Yes, sir.
In that case, which are the symptoms you expect in that?
Sir, patient can have pain because of superficial thrombophlebitis. Patient can develop, sir. Then bleeding from the varicose veins can occur, sir.
Night cramps is the one of the most commonest symptoms this patient seeks advice for varicose vein treatment.
Cosmos.
Night cramps.
Okay.
One of the reason for this patient seeking intervention is night cramps, which is usually unexplained or not treated with properly by some other person. If you take care of this varicose vein, this night cramps, usually the night cramps and the pains falls in C2 lesion. All others are visible lesions. These two are the patient's symptoms. Now, what do you want to do?
So conservative trial will be.
What are the conservative managements you know?
Sir,
for this patient as well as other patients where it falls into different categories.
Elevation, leg elevation, then elastic grip bandage, then education. Elastic grip bandage can be applied, sir. And pharmacological drugs.
The first thing is he is a painter by occupation, you said, I suppose. Change of occupation is the one you have to be suggesting first.
Okay, sir.
Because by his occupation he has to stand for long hours to do his painting work. So first thing is occasional job which can be modified, job modification the top priority. Then comes your other management protocol by means of them. If the patient is C6, we assume this patient present with a huge active ulcer. What is your management? Is there any role for conservative management?
Sir, patient can be treated with compression dressing, sir. Like the treatment of the ulcer can be done, sir.
What do you mean by treatment of the ulcer?
Sir, by compression dressing, 4-layer dressing can be applied.
Multi-layer dressing,
Multi-layer
there are 2-layer dressings available and 4-layer dressing. No? So, when will you intervene in patients? Otherwise, what are the criteria you will intervene?
Patient is having symptoms, sir. Symptoms of varicose vein. Then patient developed complications because of cosmesis. In these cases, patient can be intervened, sir. And failure of the conservative therapy.
Failure of conservation. Is there any role for stockings, compression stockings?
Compression stocking, in view of conservative therapy, patient can be applied compressive stocking, sir.
What is the pressure you advise for this patient?
So, as the patient is symptomatic, grade 3 compression stocking.
Grade 3.
35 to 40 millimeter mercury compression stocking can be applied, sir.
Is that pressure needed for this patient? He doesn't have any other skin changes?
Grade 2, sir.
If you want to intervene, what are the options for you?
Sir, surgical and then endovenous methods.
It can be classified into 2 classes, intervention methods and open surgery. What surgery by open method?
Trendelenburg, along with the stripping of the GSV and perforator surgery can be done.
Before placing the patient on table, what are the things you will do?
Sir, before, after that, the site of the perforator will be marked, sir. And patency of the deep venous system has to be ruled out.
It's all been done. Now the patient is on the table. You want to mark the perforators.
And then any anomalous venous tributaries has to be venous tributaries has to be ruled out, sir.
What do you mean anomalous venous?
Sir, accessory saphenous system has to be ruled out, sir.
Is that you only bothered about? Accessory saphenous system, duplicate saphenous system, even anterior vein of thigh has to be considered into your ultrasonography.
Okay.
Sometimes the reflex will be predominantly conducted in the anterior thigh veins, which comes in joints at the level of your knee. The LSV at the segment of thigh will be normal. These things can be made out. In accessory saphenous vein as well as duplication system is also possible. After that, how do you proceed this?
So in Trendelenburg surgery, after palpation of the femoral pulse, the incision is made lateral to it.
You are going to cut the femoral now.
Sir?
You are going to cut the femoral now, placing incision lateral to your femoral artery. What's the anatomy there?
Sir, there will be vein, nerve and artery and nerve, sir.
Vein, artery and nerve. If you place your incision next to your femoral artery pulsation, where will you reach your femoral, saphenofemoral junction?
Medial to the, it has to be the lateral boundary, sir.
Huh?
The femoral artery pulsation has to be the...
Medial to your femoral artery pulsation. Be simple.
Yes, ma'am.
Where will you be starting your incision? Medially.
So the inguinal crease, sir.
Inguinal crease.
The incision should
How do you identify this SF junction?
So it will be dipping. It will be superficial to the deep fascia, sir. Saphenous GSV will be superficial to the superficial fascia.
Sir is asking, how will you identify SF junction?
Ma'am, there will be dipping.
Okay, then how will you proceed? Junction has been identified.
So then tributaries has to be ligated, sir.
What other tributaries will be like?
Superficial external potential, superficial circumflex iliac, superficial inferior epigastric has to be ligated, and then proximally the GSV has to be ligated with minimum 3 mm at the SF junction. After that, the stripper is passed, and then GSV is stripped not beyond the mid-calf level to reduce the risk of saphenous nerve injury.
Why do you prefer to choose? I don't think it's a mid-calf level, it's the upper, just below the knee level. Why do you choose to do that?
So to reduce the incidence of saphenous nerve injuries.
Is that the only reason? Usually LSV is stripped up to the first perforators below the knee. And what happened to the perforators after that?
So it can be addressed by perforator surgeries.
Where does this perforators joins? Is this joins LSV or some other vein?
Superficial system where the perforators join.
Posterior arch vein, usually it will join.
It always joins with the other perforators doesn't joins at the LSV. In the posterior communicating vein, it goes and joins. So stripping below the knee doesn't contribute any of this ambulatory venous pressure. So stripping is stopped above the first perforators, and it specifically this saphenous nerve comes and joins the LSV at the level of the first perforators. So it's easy, you can stop before your first perforator, so that you do a step in perforator surgery which was you marked as in a different plane. So it doesn't contribute. So you start stripping just below the knee. And how do you handle this perforators?
Perforator can be ligated by the subfacial ligation.
Subfacial ligation? Do you have any names for that?
Lintons.
Lintons or modified lintons? Where will you place your incision or the modified lintons?
Sir, parallel to the medial border of the tibia, the incision will be made, sir.
You are bothered about only the medial perforators. You are not bothered about the lateral perforators. Lintons is to take care of perforators on both sides, or medial and lateral perforators. What are the lateral perforators? Is there anything?
Paratibial perforators and posterior tibial perforator, and above the ankle perforators.
Like Todd and Cock, there are Sherman's perforators available in the lateral position. You have to place your incision in between this so that you can approach both perforators.
Okay.
So now the incision has to be where?
Over the lateral side.
Lateral side? Then how will you handle this medial curve? It's over the mid calf, man. In between both medial and lateral, you made an incision. Go medially and laterally and take care of that. What are the problems with lintons?
Sir?
What are the problems with lintons? Modified lintons procedure.
So morbid incision, sir.
I don't think you will be getting this kind of patient without any skin changes. In that case, it runs to the deceased, this incision runs to the deceased part. And other thing is taking care of the ankle perforators is very difficult. So recurrence due to ankle perforators is very common with lintons. Is there any other way you can handle this perforators?
Stab avulsion can be done, sir.
Stab avulsion, is there anything other than stab avulsion? Any word about sepsis?
Sir?
Sepsis.
Sir, 1 to 3 mm incision is made over the...
What is sepsis, man? Yes.
Sir?
Sepsis.
Subfacial endoscopic perforator surgery, sir.
If the patient has a saphenopoptal junction incompetence, how will you handle this?
Sir, saphenopoptal can be treated by ligation and stripping of the veins. It should not
How
cross.
often you strip short saphenous?
Sir?
You said stripping of saphenopoptal junction ligation, stripping of the vein. How often you have done that? You are more bothered about your saphenous now. You don't bother about your sural now.
Beyond the mid-calf level can cause injury to the sural.
Sural nerve comes close in contact with short saphenous at various levels. There is no definite mark. So stripping of SSV is not been recommended usually.
Okay, sir.
It's only a personal choices. Because sural nerve comes at various levels, there are no definite relationship at all patients. So stripping is not recommended. What is the other problem is, it doesn't have mulch perforators or tributaries joining at the close to the junction. So SP junction can be done not as flush at the SF junction. It can be done away from it. Just ligation of SP is cephalopopliteal junction is, that's all. No need to do. If you are doing intervention, how do you classify the intervention methods?
Sir, endovascular.
Intervention is endovascular. It can be classified into two classes: thermal tumescent methods, non-thermal, non-tumescent methods. Thermal tumescent methods you have laser and radio frequency. Non-thermal, non-tumescent method
Mechanochemical ablation.
and glue.
Okay. Cyanoacrylate.
There are glue guns available where you place that and inject your glue all the way down. What are the advantages of this endovenous methods?
So the complications of surgical stripping can be reduced, sir. Like the incidence of neovascularization is much less.
Why the incidence is less in endovascular? The surgical concept is totally different from endovascular. The endovascular concept, the concept of incompetence changed from the terminal wall to pre-terminal wall. Whereas previously flush ligation was advised because of the thought the culprit is the terminal wall. Now terminal wall is never thought to be a culprit, it's the pre-terminal wall which is the culprit. So leaving 3 to 5 centimeters and leaving one of the branches which drains from the abdomen or anywhere else is found to reduce the chances of neovascularization. That's how this endovenous has been taking off. And what are the requisites for doing endovenous procedures?
Patient has to be evaluated via duplex ultrasound, sir. Duplex ultrasound has to be done.
Doing an ultrasonogram, none of the procedure has been complete in varicose vein. So one of the venous associations says that if you are not doing a duplex, don't do varicose vein. It's okay. So it has to be mandatorily followed with everything with your Doppler ultrasonographically. And what are the advantages of the endovenous procedures?
So the patient hospital admission will be reduced, sir. Anesthesia, local anesthesia, tumescent anesthesia, endovenous procedures can be done.
Shifted varicose vein management from a OT procedure to a daycare procedure. So the patient using non-thermal, non-tumescent methods can walk back from the OT straight away back to his office. This becomes an office procedure. So the pain complications of open surgeries has been reduced to a larger extent, but still it's a surgery. And which one is the gold standard?
Sir, endovenous.
The new gold standard, I still feel surgery is the gold standard. All the surgeries, tumescent, non-tumescent, invasive, non-invasive methods, everything has been compared with that of a gold standard 120 years old Trendelenburg's procedure. And the now modifications are there, leaving the tributaries in the proximal part and ligating distal LSV has found to reduce the neovascularization. Is there any other procedure you know other than this what we discussed?
Mechanochemical ablation can be done, sir.
Other than this what we had discussed?
Chivas.
Chivas, what is Chivas?
Actually, extensive duplex ultrasound evaluation has to be done to find out the entry and the re-entry point, and the varicose segments along with the incompetent perforators has to be ligated. Only the re-entry point has to be preserved, sir, to facilitate the normal superficial to deep venous flow.
This is to preserve the LSV where the proximal reflexing point is ligated and distal re-entry points are allowed to flow. Thereby the flow in the proximal segment goes to the distal tree. And if there is no distal re-entry points have been created. This is how the Chivas works. Is there anything called Avas? Just try to read that also. It's nothing but as a under local anesthesia, you avulse the segment of the dilated veins.
What is the role of sclerotherapy in varicose veins?
Sclerotherapy can be injected in case of recurrence, and in case of cosmesis, and in case of reticular veins, sclerotherapy can be used to.
What is reticular veins and what is thread veins?
Reticular veins having diameter 1 mm to 2.9 mm.
Thread veins?
Reticular vein also known as thread vein.
Reticular veins also veins. Veins are still smaller.
Telangiectasial 1 mm.
So that is the thread veins.
Okay.
And for that sclerotherapy, what are the types of sclerotherapy?
Detergent and osmotic agents. The osmotic agents, it is 10% hypertonic saline and alcohol, and in the detergent agent 3% sodium tetradecyl sulfate, ethanolamine oleate and pyridocanol and sodium morphate can be used to.
Foam sclerotherapy.
In the Tessera's method, sodium tetracyl sulfate is used to, ma'am. Then 1:3 ratio of sodium tetracyl sulfate and air is taken using a 3-way syringe. To and fro motion is made and foam is created, and using
Complications of this foam sclerotherapy.
Ma'am?
A
patient can have thrombophlebitis, DVT, then allergy,
Sometimes,
air embolism can also occur.
What's the difference between liquid sclero and foam sclero?
Ultrasound guided.
What's the advantage of foam? With the smaller volume, you sclerose a larger. This foam displaces the blood from the system, as well as it causes intense spasm of the veins. So it acts on the larger surface than this liquid sclero. So at least you will be using 10 mm as the maximum. Otherwise, you will found to have DVTs. Air embolism, if it is properly created foam, there is 100% there is no chances, because these foam particles are 90 nanometers if you are creating it, and it's found in echographically in the cardiac immediately after your foam. So air embolism is not that much predominant. Paradoxical, if the patient has ASD, VSD, there is something called as scotomas, transient vision loss, which thus occurs in patients with occult septal defects, where this escapes into the optic nerve, and it's only a transient. Scotomas is transient blindness. Other than that, if you have created a good foam, the possibility of air embolism is very, very less. Now there is available with foams, over the shelf foams are being available, where you take 110 ml and inject that. And these foams are now being created not with air, with carbon dioxide also. Thereby it reduces causes lesser complications.
So, in your diagnosis, kindly specify the site of the lesion. That is very important. And this is more anatomical discussion only if you are the last candidate in your exams. So formation of saphenous vein, tributaries, short saphenous system, anatomical location, perforators, all these things. So thank you for your kind presentation.
I request Professor Sarunan Robinson and Professor Ganga Lakshmi to award the certificate to the presenter. I request Professor Amudan sir to honor Professor Sarunan Robinson. And I request Professor Geeta to honor Professor Ganga Lakshmi. We will now break for lunch. Please reassemble in half an hour.
also cardiac. So you, in the history itself, you rule out any symptoms related to the coronary, carotid, as well as visceral arteries.
Yes, sir.
So what are the things you look for? You ask about syncope and everything. What are the things you ask in the history in the cerebral artery disease to rule out cerebral artery disease?
Transient ischemic attacks, sir. Blood division, syncope, patient may faint.
So TIA, RLND, or progressive stroke, or previous stroke and recovery, then you have to rule out. Then, what about the cardiac?
So history of chest pain, palpitation.
Chest pain, previous history of angina.
Yes, sir.
What about the abdominal, visceral?
Abdomen pain, melena, mesenteric ischemia, we have to rule out. Sir.
Really pain.
What is that called?
Sir, soon after meal, patient may have
postprandial abdominal pain. The same thing like stroke, you have to ask for anything. There is some ulcerative block in the carotid, internal carotid, throwing emboli. Which side you will hit the lesion? Right side, the lesion. Which side you will have the lesion?
Left.
Opposite side only you will have.
Left side.
So contralateral motor deficit and ipsilateral
Facial paralysis.
eye side. Just throw emboli into retinal artery. What will happen? The
Sir,
blackouts. Amaurosis, fucox, the fleeting blindness. These are the things you have to ask in the history.
Okay, sir.
Past history, no history of similar episodes in the past.
Can you ask the history of importance? The male patient, no?
Yes, sir.
Yes, sir.
Sir, history of importance implies pyotolia occlusion, sir. Sir,
Iliac occlusion.
So what is Lerich syndrome?
Sir, occlusion at the level of
it is a triad. Triad. What are the three components of the triad?
Sir, important gluteal claudication and
Aortoiliac occlusion. Okay, right. So you have to ask the male patient. So you have told about some pain during walking.
Yes,
so what else you left there? Important thing.
Claudication distance.
Yes, sir.
Yes, sir. Claudication.
What is intermittent claudication?
Sir, that
you tell me the characteristic features. You can tell it is intermittent claudication.
Sir, crampy pain occurring in a group of muscle, mostly in calf region.
Not necessarily.
Okay, sir.
It may be gluteal or this is a crampy like pain.
Group of muscle involvement compels the patient to take rest, and then patient will resume to walk.
Any other points? Important.
Not relieved by analgesics.
Constantly reproducible with the same amount of exercise or distance of walking. Okay. So that you can ask the patient, he will get the pain in the cough claudication when he is walking for 150 feet. Then he take rest. Then again he walk. Only at that 150 feet, then he will get again the pain.
Okay.
Why it is coming?
Sir, due to accumulation of substance P, sir.
Why it is accumulating there?
Reduced blood flow. There
say any exercise, there should be any increased blood flow. If the particular affected muscle proximal to the particular group of muscles, the artery will be blocked, which cannot dilate and compensate for exercise-induced vasodilatation. Then these substances will be accumulated, produce pain and compel the patient to stop. How will you differentiate from any other pain you will differentiate? Claudication?
Neurogenic pain.
Claudication pain.
Different types of claudication.
Vasogenic and neurogenic claudication, sir.
So venous claudication, vascular side, neurogenic claudication, and musculoskeletal pain. These are the things you have to differentiate. How will you differentiate between the vascular arterial and the venous claudication?
One point to differentiate between arterial, venous and neurogenic.
You have already told that the pain will be brought about particular amount of exercise, relieved by the pain. So how, what about the venous claudication? When will you get the venous claudication?
Deep vein thrombosis. Venous deep vein thrombosis.
So venous outflow obstruction. When exercise, there is increased blood flow from the arterial side, the venous return will not compensate because of the occlusion in maybe iliac or the IBC.
Okay.
So how, what type of the pain, what is the relieving factor?
Say, how will you find out whether it's a venous claudication or arterial claudication? In a venous claudication, there will be arterial pulse, peripheral pulses will be normal.
Okay.
In neurogenic claudication, peripheral pulses will be normal. Only in arterial claudication, you will not feel the peripheral pulses. Okay. That's the main important point.
So very simple, the pain will be relieved by the change of position, neurogenic. Venous is already accumulation of stasis of the blood in the limb will brought about the bursting like pain. If it is a secondary varicose vein, the patient will feel the bursting pain in the engorged and bursting pain in the secondary varicose vein. So how will you get the relief?
Changing posture.
Changing the posture, sir.
Limb elevation, man.
Usually in arterial claudication, patient will drop his foot down.
Hang by the side.
In venous claudication, the patient lift his limb up. In neurogenic claudication, patient knows how to get relief of his pain. Either with the internal rotation or external rotation, they will relieve the compression over the nerve.
Okay,
The patient only knows how to get rid of the pain.
So any other thing important to assess whether the disease is progressive or not? Claudication distance.
Okay, sir.
You are not mentioned that claudication distance. 100 meters. Okay. So another thing is the particular muscle will be involved. So patient may not be able to walk for the particular distance, but he can cycle. He can go by the cycle for more than a kilometer. So different muscle groups. That means that muscle group is not involved. So any other important points you have to think about the claudication clinically? A lot of things. Just you should not tell the intermittent claudications. You can assess the level of occlusion.
Segmental level of occlusion.
But the patient has a foot claudication, you think it is infrapoplity lesion. With a calf claudication, the lesion may be above the knee. Calf claudication,
thigh claudication and buttocks claudication.
Accordingly, you have to have some idea in the history itself. The patient may have the
level of occlusion.
Okay. Anything else? Carry on. So that the patient having only 2 months claudication history.
Yes, sir.
The 1 month they developed the
Black discoloration, sir.
Is it a spontaneous following a trauma?
Spontaneous, sir.
Very important that you have to spontaneous discoloration of the toe is more important. It's denoting there is more severe disease. The patient has developed the ulcer or the gangrene of the toe after trivial injury, then there is a better way to can revascularize. So you should always mention any ischemic ulcer and toe, spontaneous, the patient witnessed, see a spontaneous discoloration of the toe or it is following a trivial injury. Okay?
Past history, no history of similar episodes in the past, no history of comorbidities, no history of previous hospital.
Anything else, there is a gangrene, you told there is a numbness and a loss of, anything else he is experiencing? What about the wrist pain?
Sorry, history of wrist pain for the past 1 month, sir. It's having, sir.
So the rest pain, what is the characteristic? I am just teaching you.
Sir, burning type of pain, sir. Not really.
Constant
Constant.
burning type dysesthesia. What is unpleasant feeling, pain? Even you touch, the patient will, even the flow of air, you will produce pain. Nocturnal in type, more come in the night.
Night time.
The patient
Awakens from
will,
sleep. Can't sleep.
pass a lot of sleepless nights and hang the foot in the bedside
side of
so
the
that
bed.
the gravity aided. Actually, it will screw the already existing collateral because of the lymphedema, the ischemia will be worsened. So the rest pain will be in the toes or adjacent forefoot. Burning type of pain come in waves. In between the patient, you see the patient will be very calm. Suddenly he become shouting with pain. If you ask for the mechanism, still not understood. Why it is coming more on the night, we don't know. You go in the morning, in the rounds, you are sleeping. Throughout night, you will not sleep. So that is the rest pain. So what type of gangrene?
Sir, it
Dry gang.
Sorry, okay, you can carry on. You will
past history, no history of similar episodes in the past, no history of comorbidities, no history of previous hospitalization, and no history of previous surgeries. Personal history, he consumes mixed diet, history of smoking for past 8 years, 20 cigarettes per day, smoking index was 60 and pack years were 8, history of drinking alcohol, brandy 90 ml per day for 5 years, family history, no history of similar complaints in the family members, no history of atherosclerotic disease in the family, and no history of connective disease disorders.
Is the alcohol is anything related to vascular?
Sir, it can cause atherosclerosis, sir. Sir, it can cause atherosclerosis, sir.
Atherosclerosis.
Smoking is factor, sir.
Alcohol will not have any problem. Actually, it will promote vasodilatation. Small amount of alcohol accepted. You will get took large amount, consume a large amount, then it will affect the liver, not the vascular.
What type of previous surgery you asked for?
The previous amputation,
Amputation you can very well see on inspection. All 10 toes are there.
Any previous bypass surgeries or vascular surgeries?
What type of surgery you expect?
Sympathectomy, sir. Sympathectomy, sir.
The most common thing is lumbar sympathectomy.
Sir.
Okay.
You said 160 is smoking index.
Yes, sir.
How smoking is connected to this PAOD?
Sir, if the smoking index is more than 300, is a risk factor.
How it causes this PAOD?
Sir, nicotine content.
TAO.
Nicotine content damages the collagen, sir, in the vessel. Endothelial injury in the vessel, sir.
One is nicotine. It sensitizes the sympathetic nerve endings to the circulating catecholamines, thereby causing vasospasm. Second thing is tobacco glycoprotein. That causes endothelial injury and thrombotic tendency. These are the two causes for this TAO in smoking.
Summary.
Previous what you will personalist anything else? What are the risk factors for atherosclerosis?
Smoking.
You have delineated smoking. Anything else you asked?
Sir, cholesterol. Obesity, sir. Obesity.
Obesity, the inspection, I mean general examination. So what else you can ask in the history?
Sir, any
Risk factor for atherosclerosis? Anybody else? Risk factors for atherosclerosis?
cardiac problem? Cardiovascular problems.
Simple. It's like smoking, anything else. Said there is certain things are modifiable. Certain things are not modifiable. Not modifiable is age. You become older and older, you will get the degenerative changes, atherosclerosis. Number 2 is the sex. Somehow the female counterpart will have the protective hormones till the menopause. And the race. I think now the race is immaterial because we Asians are having the atherosclerosis more frequent, more earlier than the Western counterparts. These are the non-preventable.
Okay.
What are the preventable risk factors?
Obesity, sir. Smoking.
Hypercholesteremia and hyperlipidemia, sir.
Smoking, hypertension, diabetes, hypercholesterolemia, homocystinemia, these are all risk factors. Then come the sedentary life, stress, obesity. You are telling what you are going to put in the last, you are asking in the first. You tell me again, what are the risk factors now?
Sir, modifiable and non-modifiable, sir. Modifiable, hypertension, diabetic, obesity,
smoking first.
Smoking, cholesterol, triglycerides, homocystinuria, sir. Non-modifiable, age.
Even the sedentary life stress we can reduce, obesity can reduce. These are all modifiable. Okay.
Non-modifiable, age.
So only these are you have to ask in the history. This is the important part in the management also. When you are thinking of conservative management, you have to modify the risk factors.
Okay.
Okay. So these things you have to ask in the history, personal history, whatever they may be.
Summary: 50 years old male who is a chronic smoker and alcoholic presents complaints of wrist pain in left foot with Boyd's grade 3 and black discoloration of left fifth toe. Suggests your peripheral artery.
What is Boyd grade 3? Wrist pain.
Sir,
what is Boyd's classification?
Sir, grade 1 patient have after walking for some time develops pain, sir. And
Boyd's classified only claudication, not the wrist pain.
pain.
I don't think so. Anything maybe I missed. As far as my knowledge is concerned, Boyd's classification of claudication for Boyd's classification is for only for claudication.
Claudication pain.
Grade 1, 2, 3 the Boyd's original classification. Grade 1 is the patient experience some discomfort or pain,
and then the pain
they are able to walk,
and then
the vasodilatation, fluid substances washed out, he is able to walk continuously. Grade 2 is
patient develops pain,
have pain, experience pain, but with effort he will walk continuously. Grade 3 is compel the patient to stop. That's all.
Yes, sir.
I don't know.
Sir, general examination. Patient is conscious, oriented, and well cooperative, moderately built and moderately nourished. No pallor.
How will you classify the chronic limb ischemia? How will you grading or staging? What is Fontaine?
So Fontaine
and
classification.
Rutherford.
Fontaine classification.
Fontaine stage.
Stage 1.
Rutherford is grading. How many stages in Fontaine? Original Fontaine.
6 stages, sir.
Fontaine, put it very simple. 0 to
0.
0 is
asymptomatic, sir.
1 is?
Sir, 1 asymptomatic, sir. 2A, 2B. 2A, patient develops pain after walking for distance of
2 is claudication. 3 is rest pain. 4 is
gangrene.
tissue loss or gangrene. We later classified 2 into 2A and 2B. 2A is mild, 2B is moderate or severe, because mild always the conservative management. Moderate or severe, there is a place for intervention. Maybe a surgery, bypass, or some intervention we can do in the second. So that we subdivided in stage 2 into 2. What about grading, Rutherford?
Sir, 0 asymptomatic, sir. 1 mild claudication, sir. 2 moderate classification. 3 severe classification. 4 rest pain, sir. 5 on the minor tissue loss. 6 major tissue loss or gangrene.
Very good, very good. Okay. Sir, carry on.
Sir, no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema, no signs of atherosclerosis like arcus inhalis, transverse ear crease and xanthomas. Patient vitals, pulse rate 86 per minute, regular rhythm, normal in volume and character, no vessel wall thickening, no radial and radiofemoral delay, respiratory rate 16 per minute, abdominothoracic type, blood pressure systolic 120, diastolic 80 mmHg measured in right upper limb in sitting posture, and in other limb systolic 120, diastolic 80 mmHg in sitting posture, temperature afebrile, sir. Local examination, after getting proper consent by the patient is exposed from abdomen up to toes and was examined in a well lighted room. On inspection of the left lower limb in supine position, attitude of the limb is normal, blackish discoloration of the left toe noted, no active discharge or ulcer noted, line of demarcation is present, brittleness of nail present over the fifth toe, signs of ischemia like thinning of skin present, loss of hair, loss of shininess of skin present, no loss of subcutaneous fat, no deformity of leg, toes or muscle wasting noted. Test for circulatory insufficiency, Bugus postural test and capillary refilling and refilling time was not able to appreciate during inspection. Guttering of veins noted present over the elevation of the limbs and palpation.
So what type of gangrene there in the fifth toe?
Sir, here dry gangrene type, sir.
What is meant by dry and wet gangrene? How will you differentiate clinically?
Sir, dry gangrene is due to gradual occlusion of the vessel, sir. There is no infection in dry gangrene. In wet gangrene, there will be sudden occlusion.
Clinically, how it looks like? How will you differentiate it is wet? When will you tell it is wet gangrene? It is the dry gangrene.
So it will be dried, mummified, and shriveled and
mummified, shriveled, blockish discoloration.
Yes,
So the hemoglobin is disintegrate.
Iron sulfate deposition.
Deposit, so discoloration. Then anything else in the dry gangrene? So this is a chronic insidious occlusion of the arterial supply. So it will take lot of time.
Okay, sir.
So it will be collateral will be there. So you are told the gangrene will be blocked and shriveled, mummified. Anything else?
Line of demarcation will be present, sir, in dry gangrene.
Then anything else? Separation by
aseptic ulceration, sir.
And anything else? Very important. There is no surrounding inflammation. These are things you differentiate between wet gangrene and the dry gangrene. Wet gangrene, you know, if at all any diagram demarcation, it will separate by suppuration. There is a intense inflammatory changes surrounding the
local capitis also.
In a wet gangrene, not in a dry gangrene.
So these are the things you have to mention here. So what is type of gangrene? Where the line of demarcation are there? What is the surroundings? What are adjacent things will be pale, mottled, no sign of inflammation. These are the things you would look for in the chronic occlusive arterial disease.
Okay, sir. And palpation?
So once you tell the gangrene and the sensation will be absent. Nothing to do with it. Really dead tissue. What is
Palpation, warm, no tenderness. All inspection findings are confirmed in palpation. Blackish discoloration noted over the left fifth toe. Skin is dry.
Anything else in the inspection? Inspection, you go back. So why the nail become brittle, skin become thin?
Sir, signs of ischemia, skin become loss of shininess.
So as a whole, the leg will be 3S. Shiny, scaly and skeletonized. Why it is shiny, scaly?
Shunting of blood from skin to muscle, sir. Shunting
so all
of
other things you are given in the written. Copy paste, correct? You will not understand and done that. You have to present, not read. So why you are asking for brittleness of nail, thinning of the skin, loss of hair? These are the signs of
ischemia.
What is acute ischemia?
Chronic ischemia.
epigastric region, suprapubic region, or in the umbilical region?
Umbilical region, sir. Umbilical region, sir.
Why? Here you can easily insinuate your finger in the epigastric region. Anybody else? Where will you look for the abdominal aortic pulsation?
You people are once that these are the cap codes, you are keeping silent. You people also have to answerable. Whatever the question passed.
It's not to the left or right, it will be in the midline. Usually we used to think that in the epigastric region it is very easy to palpate, but it is deep inside the epigastrium. So due to the lumbar lordosis, it is very easy to palpate the abdominal aortic pulsation in the umbilical region. It doesn't curvature is there. Due to the lumbar lordosis, abdominal aortic pulsation can be best felt in the umbilical region, not in the epigastric region.
What are the methods of feeling popliteal pulse? Go back.
Sir, in prone position, after asking the patient to flex the knee for 40 degree, we have to palpate in the lower border of the popliteal fossa, sir.
Prone.
Prone.
Which one is very easier?
Prone.
Prone. Or are you only prone? Karthik, how you will feel for the popliteal pulse? Mike. What? That day you are demonstrating house agents. The next year you will answer. This year, second year. Tell me, yeah.
So another method in supine position, by keeping the two thumbs over the tibial tuberosity, we have to palpate the popliteal artery by the other four fingers of the other hand, sir.
Audible, not clear.
Sir.
Point 1. What is the supine position? Point 2, what?
Prone.
Eh?
Supine prone.
If you want to discuss, you can go on outside and discuss.
Sir, in supine position, by keeping the thumb over the tibial tuberosity and using the other four fingers, we have to palpate in the popliteal fossa between the two heads of the gastrocnemius muscle, sir.
Popliteal fossa?
Between the two heads
Which
of
part
the,
of the fossa?
lower part of the popliteal fossa between the
Why
two.
are not in the upper half? What are the boundaries of popliteal fossa? What is the shape of the popliteal fossa? Anybody? What is the shape?
The upper part
Diamond
is
shaped.
In the upper part is deep inside the
There's
condyles.
4 borders.
Okay.
What is the upper and lower? Lower very simple. What is the medial and lateral border? Medial and lateral head of gastrocnemius. Upper lateral border is formed by you have to feel, you cannot feel in the upper of Y. You see that the femur, what is femur? Condyle looks like that. There is a two condyle, medial and lateral condyle. There is a deep sulcus, intercondylar sulcus. You cannot feel the pulse in the intercondylar pulse. So you have to go to the lower half. So you have to, between the two heads of the gastrocnemius, put your 4 fingers and thumb in the tibial tuberosity and press against the posterior surface of the tibial
So just lateral to the extensor hallucis longus muscle.
Line. Draw a line from the midpoint or intermalleolar line to the first web space. Then you can feel the pulse in the proximal 1/3 of that imaginary line.
Okay, sir.
You can go distally, it will tip into the intraosseous. You cannot feel.
Palpable murmur, sir. Palpation finding, sir. That is.
If say you are putting your stethoscope in the femoral groin, you are hearing a you can keep, you can tell no problem. Part of the arterial tree signifies what? Stenosis at the that part of the vessel you are auscultating or the proximal tree. See, the systolic bruit will originate at the stenotic lesion, then transmitted distally. So even in a iliac aortic stenosis, you can hear a bruit in the groin. If you are hearing in the groin the bruit, that doesn't mean there is a lesion in the femoral. It may be in the proximal.
விசில் அடிக்கிறீங்களப்பா, விசில் அடித்தா நேரம் பண்ணாதானே விசில் ஆகுது, அதுதான் புரியுது.
Some physics is when there is a vessel become stenotic, what will happen with the stenotic step? Before, in the stenotic segment, after the stenotic segment. Before, through the stenotic segment, after the stenotic segment, what will happen?
With the dye gangrene of the fifth toe,
you will get 3 over then. Yeah.
Less than 50 years, sir.
He is 52, 50. Then
Less than 50 years, atherosclerosis in old age, sir. Smoking history will be present in Buerger's disease.
you told that is the atherosclerotic etiology. So what are the findings make you conclude it is atherosclerotic pathologically?
Sir, old age, smoking history is positive.
When you call old?
Yeah, first and foremost point, TAO is a disease of the medium and small size vessel.
Small size, peripheries affect.
Here you are not able to palpate the post.
Exclusion criteria. You didn't read?
Sinova criteria. Less than 50 years, smoking history and infrapopliteal arteries are involved. Other risk factors for hypertension other than smoking.
What is thromboangiitis obliterans? What is the difference between atherosclerosis and thromboangiitis obliterans, otherwise called Buerger's?
Do any surgery in the arteries. That is the main reason. It's inflammation of the small, medium-sized arteries, veins, and accompanying nerves. That's why there is severe pain.
Okay, sir.
It's a very simple. The onset of first symptom after 50 years. Onset of symptom before 50 years. He is telling 52 years. We don't know. 1 month old, 2 months old claudication and 1 month old critical ischemia, not acceptable. Patient should have 2-3 years claudications. You are not elicited very well. Okay? So maybe the claudication, mild claudication for 4 years.
Sir, investigation, sir. We have to proceed with investigation, sir.
Sir, API index, no?
Yes, sir.
I didn't ask anything about API index. Now only the investigation, API, what is the things, what are the particular specific investigation, blood investigation you want to do?
Sir,
laboratory, lab test.
Lipid profile, especially we have to see, sir. Lipid profile, sir. Okay, sir, lipid profile. Okay.
I will not do anything, man.
Okay, sir.
Next year only I will come. By the time you may be passed.
Sir, complete blood count, random blood sugar, sir. Diabetic, we have to roll out, sir. Random blood sugar, RFT, renal function test, and lipid profiles, and homocysteine levels. And we have to do, sir.
So, routine investigations, CBC, urine analysis. Then you check about the diabetic status, hemoglobin fasting postprandial, renal function test, at least urea and creatinine, and the liver function test fully, then lipid profile, then you assess the cardiac status.
ECG, echocardiogram.
At least 3. If any abnormality, you go for CABG. Or the patient having the clinical symptoms are angina, you have to go for it. So when you are thinking about management of peripheral vascular disease, you rule out cardiac cerebral.
Yes, sir.
Cerebral first, then comes coronary, then come limbs.
Okay, sir.
Vital organs first, then come the limbs.
Okay, sir.
Without correcting the coronary or cerebral lesions, you are going for any bypass or anything else, you lose the patient.
Okay, sir.
This priority will be there. So these are things you would ask. Then what is ABI index?
Sir, ankle brachial pressure index. If it is normal value 0.9.
How will you do ABI? So only 10 more minutes. Minutes. How much the flow through the renal, any the spectral widening, everything, and also you can follow up the patients after the bypass, whether your pattern, your stent is patterned or everything, you can follow. That is advantage. Bedside you can do it. So that is non. There's a lot of things, conventional, DSA, MRA and CT angio. You read about other things, I tell about the CT angio. Now everybody is doing CT angio. The conventional is the gold standard. This is better than conventional angio here. Okay? Now we are doing only CT angio. CT angio, you will give the level of occlusion. When you are going to manage, what are the things you see in the CT angio?
Sir,
Site of occlusion,
level of occlusion and the collaterals whether formed or not, distal flow is present or not.
Length of occlusion.
Length of occlusion.
Level, length of occlusion, any inflow disease. There is a lesion in SFA whether proximal arterial tree is good or not. Otherwise, without correcting the inflow disease, you should not bypass. Okay. Then good runoff.
Runoff, distal runoff.
Distal runoff.
Proximal run-in and distal runoff. Both proximal and distal is very much needed, because if you are going to bypass, the proximal vessel should be healthy to have a bypass.
There will be iliac lesion. There will be a SFA lesion. We are doing hybrid. You put a stent in the iliac, then do a femoropopliteal bypass. Now, that is hybrid procedure. Technology is more and more improved now. So two things, endovascular as well as open surgery. Endovascular now first. Most of the time you are doing endovascular, but it's not a gold standard. I am telling you that if you are keeping some balloon, mechanically dilating, you are placing a metal stent there, it always harm. Anytime it will go for occlusion. Compared to the open surgery. Bypass, you are doing venous, you can see the 15 years, 20 years pattern grafts we are seeing. So anyhow, now it became more glamorous. The technology is improved, so we are doing a lot of angioplasty and stenting. Patient also wants that, not the open surgery. Okay? So my opinion is, if the patient is young enough, without any risk factor, but go for open surgery rather than interventional. The old people with comorbid conditions, no other go, we have to do stent some endovascular procedure. So if all the measures fail, then you think about
amputation, lumbar sympathectomy.
Where it heal, you cut. That's all. Simple policy.
In general, you can divide this treatment of TAO or PAOD into two. One is direct arterial surgery, another one is indirect arterial surgery. Indirect arterial surgery means your lumbar sympathectomy or your omontopexy, and the third one is an Ilizarov technique. Have you heard of Ilizarov? Limb lengthening. They use in orthopedics.
Okay, sir.
They put an external fixator and lengthen the limb. That improves the vascularity. But direct arterial surgery, as I said, it is endarterectomy or an angioplasty by putting a stent. Latest is drug-eluting stents. What are the drugs used in
Drug-eluting stent, drug-coated balloons, lot of things are available.
And
even stent, covered stents are there because it's a metal. One of the cause for is the metal irritating the intimal hyperplasia. It will go for occlusion. So it will covered stent. So the metal will not go in contact with the intima. So only the cost is the factor.
Third type of direct arterial surgery will be your bypass surgery, Dacron or PTFE grafts.
Yes, sir.
Any doubt? Again, any doubt about that? You can ask now. 2 minutes.
What is VEGF?
Vascular endothelial growth factor, sir.
So you should not tell why, if you are clear cut, no TAO and atherosclerosis, how to differentiate? Any doubt in that? Number 2, another things I want to tell, particularly our Karthi is there, you should not, without feeling the pulse, don't do the amputation of the toes. If the absent, you ask vascular surgery opinion, or at least you do the Doppler, then you think about removing the toes. So by the time you come to the vascular surgeon, you screwed all the things, all the toes, how you will salvage the limb, I don't know. Unless without increasing, improving the vascular, touch the gangrenous or ulcerative part. Otherwise, it will go ascend. By the time we intervene, we lose the limb, functional limb. Yes, unless there is a sign of infection, don't remove the toes.
Yes, sir. We usually get a vascular surgery opinion only if they advise an amputation, we used to amputate, sir.
And I am asking about my institute. I am telling. You take over that patient. We have done angioplasty, a good pulse, dorsal inspedes, but a big second to also go to the
So we can divide the two groups. This is Hunter's group. This is Theodore Cocker's group. So first we must start with the line, madam. Line. But யாராவது கேளு டாஸ்க் எக்ஸாம் First question. Okay, we can go to first question. So this is see the video. So this is name the technique how he is removing the substernal thyroid. Without sternotomy. Hunter. 1, 2, 3, 4, 5, 6. Theodore Cocker. Okay. கம்பெனிக்கு தான் போகுது. அதுக்கு முன்னால் நீங்கள் சொல்லியிருந்தா இதை செலிப்ரேட் பண்ணியிருக்கலாம். So this is a toboggan technique. Toboggan is like a sled-like transport used in snow. So we can introduce our finger like a toboggan, I mean it's a sled, and we can slide over the trachea and remove. This is a toboggan technique. Okay, we can go to the next. So, question to the Cockers, Theodore Cocker. What's the name of the incision? What's the name of the procedure? First preference is to the Cocker team. 5, okay. Raise your hand. Come. Okay, this is an incision. What is the name of the procedure? Okay, come. What is the name of the procedure? Batwing?
Mammopexy.
Mammopexy. For?
Central cord. Retroareolar tumors.
Periareolar tumors. Okay, very good. So, this is congratulating you. Okay, this is the bad wing incision. So identify this legend. This is a clue. He is from that country and he is fond of this area. And these pictures and the male and female denote something. And this is a very good instrument. It is introduced by him. This is a clue. 5, 4, 3, 2, 1. Hunter. I am giving 3 clues, 4 clues. கம்பெனிக்கு தான் போதா சார்? இன்னொரு இவங்களுக்கு தான் மதுரை மெடிக்கலுக்கு. ஒய் யூ ஆர் கிரையிங்? எஸ், யூ ஆர் ரைட் சார். கிரைல். ஸோ ஜார்ஜ் வாஷிங்டன் கிரைல் இஸ் a name. He contributed many procedure in neck dissection. So that's a Kreil's neck dissection is the A is a Kreil's neck dissection. And not only the Kreil's mosquito clamp is very famous, and he only is the first surgeon to introduce direct blood transfusion from the patient to patient, direct, without. Is an American surgeon. So 60-year-old woman notices lump on both sides of her neck. FNEC shows non-diagnostic, underwent total thyroidectomy. Pathology reveals Hurthle cell carcinoma. And which of the following options is the most appropriate post-surgical management of the patient? You say either the treatment. Theodore Cocker. 5, 4, 3, 2, 1. Hunter. டிவியில் கேட்கலாம், எதில் கேட்கலாம்? Raise your hand. Raise your hand. So here you can so radioiodine ablation, because the other cell cancer type is a follicular cancer but differs from follicular neoplasm, so more often multifocal and bilateral. So radioiodine ablation can be given. So this is even though it's a medical question, but surgeon has to come across this type of thing. So 32-year-old woman with the multiple hematomas in the GAT and the physical examination showing this image. Raise your hand and tell. First, come. Another. This patient is at risk of which of the following cancer apart from GAT? Breast cancer. Okay. Come. So, in the PHC carcinoma caused by mutation in the STK11 gene, increased risk of developing breast, colon, and rectum cancers. So you look at this surgeon. He's a great surgeon of 20th century. He's the author of the great selling book that is Puzzle People, and he's first successfully done one surgery that changed the history in 1967. And his famous quote, "I had an immense fear of failing the patient who had placed their health or life in my hands. Even for simple operation, I would review books. Then I sick with the apprehension. I would go to the operating room almost unable to function until the case began." This is a famous saying of this surgeon. He recently died in 2017 at the age of 90 years. So anybody raise your hand and tell. Full name. I heard some half answers. அந்த பக்கம் இருந்து ஒன்றுமே வரலையே பண்ணோம். ஓப்பனிங் பண்ணுங்க, அக்கௌண்ட் ஓப்பன் பண்ணுங்க, நெகட்டிவ் பேலன்ஸில் போயிட்டு. எஸ் ப்ளீஸ். தாமஸ், வெரி குட், எக்ஸலன்ட். Sargel, this is a full name, and he performed the liver transplant, and he is a father of modern transplantation. Question goes to the Cockers. Identify the lesion. What's the endoscopic procedure being done? What is the classification? Yes? Gave. What is the classification used for this upper GI bleed? That's a trick. அவங்க சொல்லணும், ரெண்டு பேருக்கு வேணா ஷேர் பண்ணிக்கலாம். கம் 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 கம். 4 ரெண்டு பேரும் ஒரே இது. So this gave, and the procedure being done is organ plasmagogue, upper GI bleed, type 1, type 2 and type 3. So what is the equipment being used and what is the procedure? Raise. Yes, very good. Come, come. Sorry, sorry. Okay. கொடுத்துருங்க. இதை சொல்லுங்கப்பா. Angiogram of the neck region. What is the sign? What is the pathology? Come. Liar sign. What is the pathology? இப்படின்னா மொத்தம் யாராவது ரைஸ் பண்ணி சொல்லு. Liar sign. Okay. What is the pathology? You are right. You are right. You are right. You know, he is Elon Musk, you know. Okay. So, lyre sign is a carotid body tumor. Lyre was the string, it's a musical instrument. So, what will happen? The tumor in between the thing, it will separate the internal and external carotid by the tumor. So, it is described in the CT angiography. Theodore Cocker team. What's no. Don't see. Don't you raise, stand, and then tell. Wait. Your turn has to come. What's the procedure? What's the indication of this procedure? You completely see fully. Just see the video fully. Once again, so the initial 3 seconds is very important. This is very important. I think you must have seen only in conferences. Theodore Cocker? Yes. Pass. Submucosal? Where? No. Anybody? Raise and tell. Raise your hand and tell. Yes. Full name. What is the short form? Then. It's a poem. So you are having some. இது வர மாட்டேங்குது. So பழுவ விட்டியாப்பா. So this is a type 4, type 6 choledochal cyst. It's a classification, Stodani classification. Latestly only they added 6. Okay, come. ஒரு சிம்டம் இங்கே இருக்குது. ஆல்ரெடி நீ வடிவில் பார்த்தாலே கண்டுபிடிச்சிருப்பீங்க. ஒரு சிம்டம் இருக்குது. ஸோ வாமிட்டிங், பெயின் அண்ட் சப்குட்டேனியஸ் எம்ஃபைசீமா seen in Borov syndrome. இதை சொல்லியிருந்தீங்கன்னா நீங்கள் இந்த அப்ரிசியேஷன் வந்திருக்கும். யாரும் சொல்லல. Okay, this goes to Theodore Kakkar team. You are doing laparotomy, ileal segment showing this type of finding. What's the diagnosis? Crohn's disease. Very good. Come. Come. So name these important surgical steps A and B. So first step you know very well. That is used for major surgery. What about the B? That is very important. What is A? What is the name of the procedure? Matax. Very good. Excellent. Come. So cattle blast maneuver is right mobilization. Matax maneuver is left malleolar region. That is essential for retroperitoneal injuries, particularly to expose the aorta and left iliac vessels. This is for your Whipple's procedure. We are doing cattle blast maneuver. Come. That side. Clarity for Kakkar side. Anybody? Radiology. Radiology sign for A, B. 5, 4, 3, 2, 1. Okay, last. Anybody? Raise. Stand. Apple core. Okay, very good. That is A is okay. கிடைக்கும். இல்லாட்டி பாதியை பிச்சு தான் கொடுப்பேன். Anybody? Napkin rice. Anybody? இல்லாட்டி கம்பெனிக்கு தான் போயிடும். Look at the tooth. Some I am giving clue. Disease, diverticulosis. Come. Identify the syndrome involved. That back side. Gardner syndrome. Identify the syndrome and chromosome number. Gardner syndrome. By hiatus hernias and particularly rolling type of hiatus hernias. It's a Cameron ulcer. This company போயிடுச்சு. Identify this procedure in a patient with varicose vein and the energy transmitted at the wavelength of. யாரா ஒரு ஆள் சொல்லணும். யார் ஃபர்ஸ்ட் சொன்னீங்க? நீங்களே டிசைட் பண்ணிங்க. சரி, ரெண்டு பேருக்கு ஷேர் பண்ணிங்க வாங்க. வா வீடியோ போடு. வா. So, identify lab view. Three points you have to mention. A, B, C. 5, 4, 2. Anybody? Very good. Okay. Medial? Median or medial? L. Umbilical ligament. Come. Excellent. So, C is also celebrating your
Struma ovary.
Struma ovary.
Struma ovary.
Tropoplastic tumor. Then
secondary is producing excessive thyroxine.
Ectopic thyroid tissue. All are constitute the thyrotoxicosis. But hyperthyroidism only the toxic goitres. Here toxic goitres plus these conditions, right?
Ipa Puruncha, thyrotoxicosis, hyperthyroidism. Hyperthyroidism means there is the thyroid gland alone is active. You have got to have increased level of thyroxine. Hyperthyroidism. Thyrotoxicosis, you have activity in the thyroid, or it may not be the thyroid itself, it may be somewhere else. Plus you have symptoms like your exophthalmos, peritoneal myxedema, all it is not due to your, that is not seen in your hyperthyroidism. So it is a complex phenomena where you have these features plus hyperthyroidism. That is thyrotoxicosis. Is it clear? Yes. So adula unaku vandu primary thyrotoxicosis, then thyrotoxic ectasia, then your say your stroma ovary,
tropoplastic tumor,
tropoplastic thyrotoxicosis. Tropoplastic thyrotoxicosis enna?
Gestus.
Tropoplastic thyrotoxin enna?
Gestational tropoplastic tumor which secretes the
illappa hydatidiform mole adala they secrete your thyroxine. So thyroxine எங்க இருந்தோ இருக்கும், gland மட்டுமே இருக்காது அதுல.
Ectopic thyroid.
Was getting attached to the tracheal rings.
What are the two muscles?
Muscles.
First two muscles will be contract.
During declusion, mylohyoid gets contracts. Mylohyoid. The inferior constrictor muscle, thyropharyngeus and cricopharyngeus.
Right. Two constrictor muscles contract to pull the cricoid cartilage and thyroid cartilage. So along with that, the thyroid swelling also moves with declusion.
இப்போ புரிஞ்சா புரியலன்னு நான் சொல்கிறேன். ஃப்ளோரில் புரிஞ்சாடா அவன் சொன்னது? இப்போ தைராய்டு கிளாண்ட் என்க்ளோஸ் வித் ஃபேஷியா கால்ட் பெரிட்ரிக்கியல் ஃபேஷியா. The peritral fascia has got anterior and posterior layer. Anterior layer about certain oblique of the thyroid and the hyoid bone. Below it goes to the mediastinum. Posterior contains to form the ligament of Berry. It is attached to the cricoid cartilage. அவன் மற்றெல்லாம் சொல்லலை. cricoid cartilage attached thyroid cartilage by cricothyroid membrane. Thyroid cartilage attached the hyoid bone by thyroid membrane. Attachments. Now the inferior constrictor divides into cricoid thyropharyngeus. Cricoid attached to the cricoid cartilage, thyroid cartilage. சரியா attachment. During declusion, mylohyoid muscle contracts, it pulls the hyoid up. இப்போ rail engine பெட்டி மாதிரி, when the hyoid is pulled up, hyoid போக அந்த கூட என்ன ஆகும்? Thyroid cartilage also move, when the thyroid goes, cricoid also moves up. So when these cartilages move up, automatically thyroid gland moves up during declusion. Because of the your peritral fascia attachment to the oblique thyroid cartilage and hyoid bone anteriorly,
posterior ligament of Berry to the cricoid cartilage. And the inferior constant pushes the gland above. Myelin pulls up. So இப்போ ஊட்டிக்கு போகக்கூடிய ட்ரெயின் வந்து மேலே ஒரு ட்ரெயின் இன்ஜின் கிலோ இன்ஜின் தள்ளும்ல அந்த மாதிரி. ஸோ தட் இஸ் இட் மூவ்ஸ் அப்படின்னா பீஜன்லாம் தெரிஞ்சுக்கிடணும். வாட் ஆர் அதர் ஸ்ட்ரக்சர்ஸ் மூவ்ஸ் வித் டெக்லூட்டேஷன்?
Midline structures like cervical dermoid, subhyoid
cervical dermoid.
Dermoid cyst in the midline. Sir,
என்னடா கொல்லம்பட்டில் ஊசி வைக்கிற மாதிரி சிங்கத்து கோக்குற மாதிரி பிரசன் பண்ற, ஒழுங்கா பிரசன் பண்ற.
thyroclastic cyst, subhyoid bursitis.
ஏன்டா தைரோசிஸ் ஏன்டா மூவ் ஆகுது? ஏன்டா மூவ் ஆகுது?
சரி டாடா
படிச்சுக்கோ, தெளிவாக இருக்கணும், தோதுப்படாது. ஸோ தைரோக்ளாசல் டக்ட். ஸோ above it has a foramen cecum, below it is to the pyramidal lobe of the thyroid gland. So when it develops, it descends down. So it passes, when the tract it passes, sometimes it goes through the hyoid bone, or it may anterior, or it may wind around the hyoid bone. 3 அனாமலி இருக்குது, பீச்சிக்கெல்லாம் தெரியணும். So because of this descent, when any cyst develops in the thyroclassal tract, you call it as a cyst, thyroclassal cyst. Is what type of dermoid? ஏய் சும்மாடா டே, ஃப்ளோலுக்கு வாயை புத்துறா, அவன் தான்டா பேசுவான், மாய அமைதியாடுறா. இதுதான் தெரியணும்டா, அது இதான் சொல்கிறேன், பிஜிக்கெல்லாம் கேட்டுருவான். வாட் டைப் ஆஃப் டெர்மாய்ட், கிளாசிஃபைட் டெர்மாய்ட். ஸோ பிஜி எக்ஸாமினேஷன் வந்து அவன் என்ன கேட்டாலும் ரைட்டு லெஃப்ட்டு கேட்டால் யூ ஷுட் பி ப்ரிப்பேர்ட் டு ஆன்சர் ஃபார் தட். நீ படித்தா தான் தெரியும். ஸோ தைரோக்ளாஸ் இஸ் எ டியூபுலர் டெர்மாய்ட். ஸோ யூ காட் ஏ செக்விஸ்ட்ரேஷன் டெர்மாய்ட், டியூபுலர் டெர்மாய்ட், implantation dermoid, teratomatous dermoid. So teratomatous dermoid got the ovary and the testis. Sequestration dermoid on the line of fusion, extraangular dermoid. Implantation dermoid, so injury. So a tailor, so epidermis pushed by the needle prick, keta solla theriyano. So because of this attachment to the foramen cecum, it moves up with the deglutition and also protrusion of the tongue. So lower attachment is through the hyoid bone to the isthmus of the thyroid gland. That is, it moves up plus moves with the protrusion of the tongue. குழப்பமே இருக்கக்கூடாது. Yes.
What are the other thyroid swellings will not move with deglutition?
Malignant tumor, real thyroiditis.
Malignant tumor with the
infiltration to the surrounding structure. Renal thyroiditis. Recurrent swelling which alter the plane.
What is the recurrent swelling?
Retrosternal goiter.
Radial thyroiditis, okay. Then
சத்தமா சொல்றா, இல்ல அவன் சொல்றா retrosternal goiter, agreed.
Retrosternal goiter with the intrathoracic
extension, with locked or impacted.
Right.
Right, where?
And huge thyroid. எவ்வளவு பெரிய thyroid இருக்கும். தொங்கும் அப்படியே. So huge thyroid. These are the thyroids, even though they are thyroid swelling, they will not move during deglutition.
So thyroid swelling does not move to deglutition. புரிஞ்சதில்ல, a huge thyroid swelling will not move. A retrosternal goiter, intrathoracic extension will not move. Then radial thyroiditis will not move. Malignancy will infect your muscles. So the anaplastic asthma, commonly your anaplastic asthma, even though they arrest the thyroid, they does not move to the deglutition. இதெல்லாம் உனக்கு கேட்கக்கூடிய கேள்வி பரீட்சையில். Clear? Yes.
Right. Okay.
Lower border of the swelling seen, well-defined border, no scar, sinus, dilated veins, no visible pulsation over the swelling, no movement of swelling. Trachea appears to be in midline, no other swelling noted in the neck region. Palpation.
Name of the method using for inspection.
Classical method.
Inspection. Examination of thyroid. What is Bizelow's method?
For short neck people, to clearly visualize the anterior surface of the neck, using clasping the both hands against the nape of the neck with the extension of neck, you will able to see the thyroid properly.
When you will get engorged veins over the thyroid region?
Retrosternal goiter compressing the thoracic inlet. There will be dilatation of veins over the anterior surface of chest wall.
How will you confirm the retrosternal extension? By clinical test.
Pemberton sign.
What is Pemberton sign?
Asking the patient to raise the both hand by the arms touching the both ears, keeping it for 3 minutes. We will see dilatation and congestion of veins over the
and the patient will be dyspneic. Patient will be
dyspneic.
Proceed.
Palpation, no local rise of temperature, it is non-tender. Inspectory findings are confirmed by standing behind the patient, slightly flexing the neck. On palpation, a butterfly-shaped swelling of size 8 into 4 cm, extending 2 cm from thyroid cartilage, 1 cm above suprasternal notch, up to anterior border of both sternomastoid muscle. Multiple nodules are palpated. It is a bosselated in surface, firm in consistency, well-defined borders, intrinsic mobility present.
Intrinsic mobility எப்படி பாப்ப இதுல பிரேக் போட்டுருவாங்க எக்ஸாமினர் intrinsic mobility thyroid எப்படி பாப்ப
What is mean by intrinsic mobility?
சொல்லு.
Fixing the thyroid in fixing the trachea in one hand and palpating the swelling in vertical direction. If it mobile, it is
சரி கை தட்டுறா டேய் கை தட்டுறா ஒழுங்கா சொல்றேன்ல. ஸோ நீ வந்து ட்ரக்கியா ஃபிக்ஸ் பண்ணி தாண்டா பார்க்கணும், மறக்காத. ட்ரக்கியா should be fixed. ட்ரக்கியா ஆட்டி காமிடா அவங்களுக்கு. ஆட்டுறா ட்ரக்கியா இல்லை சும்மா ஆட்டுறா இல்லை ட்ரக்கியா இது ஆட்டி காமி அப்படி பார்க்கக்கூடாது. பரிச்சை இப்படி தான் பார்ப்பேன், ஃபெயில் ஆகிக்கிறேன். பிஜி அண்டர் கிராஜுவேட் விட்டுருவாங்க. யூ மஸ்ட் ஃபிக்ஸ் த ட்ரக்கியா and then see both vertical and horizontal. Number 1, வாயை திறடா ஆன்றா திறடா சொன்னதை செய்யடா ஆன்றா ஃபிக்ஸ் பண்ணுற மேண்டபில் வாயை திறடா ஃபிக்ஸ் பண்ணு. See, when you want to see the thyroclastal cyst, you fix the mandible, ask the patient to protrude the tongue. நீ வாட்டு சும்மா நீட்ட சொல்லக்கூடாது. Then breast, fix the breast and see a breast, you see with the movement. So moves along with the breast tissue, the pathognomonic feature for you were see a breast. Moves within the breast tissues you were fibroadenoma. இந்த மூணுமே நீ வந்து கிளினிக்கல் சைடு வந்து ஃபிக்ஸ் பண்ணி தான் பார்க்கணும். Yes.
Lower border palpable, corrected pulsation felt equal on both sides.
What about the tracheal position?
Trachea appears to be in midline.
Appears to be midline.
Palpation வந்துட்டீங்கடா.
Clinical test.
3 finger test
to know the position of the trachea. How will you examine?
3 finger test.
3 finger test. Only one. That's all.
3 finger test. Trial sign.
Trial sign.
Looking for a straight line symphysis.
Then auscultation over the trachea. Right? So 3 tests we can do it.
என்னடா லைன் எங்கிருந்தா எப்படா லைன் போடுவேன்?
Symphysis venti.
ஏடா இப்படி யோசிக்கிற? ஏண்டா ஒரு பிஜி கடன்னு சொல்ல வேண்டாமடா?
Adam's apple, suprasternal notch.
சொல்லு சென்டர் ஆஃப் தி மிடில் ஆஃப் தி suprasternal notch. You draw a line. அதில் தான் வந்து ட்ரக்கியா இருக்கணும். Deviation you can see. Then when you do palpate, you will see a tracheal ring you can palpate. Then auscultate, you will have a bronchial breath sound.
And trial sign. 3 tests. Trial sign, 3 finger test and auscultation. 3 method we can confirm whether the trachea is in the midline or not.
Coccus test negative, Berry negative, no palpable thrill, no cervical node.
எந்த பல்ஸ் எங்கடா பாப்பா? கரோடிட் பல்ஸ் எந்த பல்ஸை பார்க்குற எங்கே பாப்பா? Thyroid cartilage. So it divides into internal and external. Internal medial, external medial. Thyroid assist பண்ணிருக்கீல? அப்போ ஆப்ரேட் பண்ணிருக்கியா? இது external carotid medial, internal carotid medial.
External carotid.
External carotid is
medial.
Medial. So what are the branches of the external carotid?
Sir, superior thyroid artery, lingual artery, posterior pharyngeal artery. Posterior axis.
சொல்றா நோக்கத்துக்கு சொல்றா.
posterior auricular.
இல்ல ஒரு தெளிவாரா பிஜி.
posterior auricular artery.
போதையில கஞ்சா குடிச்ச மாதிரி பிரசன்ட் பண்ற. தெளிவா பிரசன்ட் குழப்பம் வர கூடாது. எல்லாம் கிளியரா இருக்கணும் சொல்லு.
facial artery, accessory palatine artery,
ascending
pharyngeal artery.
இஷ்டத்துக்கு நீடா உனக்கு தெரியுமாடா பொடி உனக்கு தெரியுமாடா?
superior thyroid artery.
Yes.
Lingual artery, facial artery, ascending pharyngeal artery,
maxillary artery, occipital artery, superficial temporal artery.
அசெண்டிங் ஃபெரிஞ்சியல் ஆர்டரி சொல்லல நீ சொன்னானா? ஸோ எல்லா பிரான்ச் சொல்லிட்டானாப்பா? 8 பிரான்ச் சொல்லலையா? திரும்ப சொல்லு, நான் என்றேன் சொல்றா.
superior thyroid artery, lingual artery, facial artery, ascending pharyngeal artery, maxillary artery, occipital artery, superior temporal artery, and posterior auricular artery, temporal artery.
சூப்பர்ஃபிஷியல் டெம்பரல் ஆர்டரியா? இஷ்டத்துக்கு டெர்மாலஜி வைக்காத, வெள்ளக்காரருக்கு பேர் வச்சுட்டு போயிருக்கேன், பேரை மாத்தாத. அடுத்து
superficial temporal artery and posterior auricular artery.
posterior auricular artery. So these are the branches. So நீ எங்களுக்கு வாத்தியா சொல்லி கொடுத்த சொல்லி நீ எழுதிக்கோ. சிஸ்டர் லக்ஷ்மி பவுடர் ஃபேஸ் ஆஃப் அண்ட் அட்ராக்ட் மெடிக்கல் ஸ்டூடெண்ட்ஸ் எழுதிக்க, ஈஸியாக போயிடும். அவன் லூசினா நம்ம லட்சுமின்னு வச்சுக்கிட்டோம், எழுதுடா எழுதிக்கடா. சிஸ்டர் லக்ஷ்மி பவுடர் ஃபேஸ் ஆஃப் அண்ட் அட்ராக்ட் மெடிக்கல் ஸ்டூடெண்ட்ஸ் ஈஸியாக. சிஸ்டர் வந்து சுப்பீரியர் தைராய்டு, சிஸ்டர் லக்ஷ்மி லிங்குவல் ஆர்டரி, சிஸ்டர் லக்ஷ்மி பவுடர் ஃபேஸ் போஸ்டியர் ஆரிக்குலர், எஃப் ஃபேஷியல் ஆர்டரி, ஆஃப் அண்ட் ஆக்சிபிட்டல், அட்ராக்ட்ஸ் அசெண்டிங் ஃபெரிஞ்சியல், மெடிக்கல் ஸ்டூடெண்ட்ஸ் வேர் maxillary artery and superficial temporal artery. கேட்டால் கேட்பாங்க, why it is called external carotid and internal carotids? அதுக்கு ஏன் அப்படி பேர் வச்சுருக்காங்க தெரியுமா தெரியாதா? தெரியாட்டு விட ஒரு பெரிய குற்றம்லாம் இல்லை, தெரிஞ்சாச்சும் இல்லாட்டி தெரியாது. எங்கள் ஃப்ளோரில் என்னடா டே இப்போ பேசுகிறா, கேட்குறப்ப பேசுது, இப்போ என்னடா இப்படி உட்காந்துருக்கீங்க, என்னடா இது என்னடா சொல்கிற நீ வரல, என்ன சொல்ல வர சொல்லு. அப்புறம் என்னடா என்ன இது பதிலா? இப்போ உள்ளதே போக போகிற வெளியே இருக்கு, எங்கே கடலை பார்த்தா போகும், எடா போய் சொல்ல உட்கார்றா. ஸோ தெர் இஸ் இப்போ எக்ஸ்டர்னல் கரோட்டிட் ஆர்டரி, இந்த பிரான்ச்சஸ் ஆர் கிவன் அவுட் சைட் த கிரேனியல் கேவிட்டி. இன்டர்னல் கரோட்டிட் ஆர்டரி பிரான்ச் ஆர் கிவன் இன்சைட், நோ பிரான்ச் அவுட் சைட். இதுதான் மெசேஜ் தான். எக்ஸப்ஷன் பிஜியில் கேள்வி கேட்பான், வாட் இஸ் எக்ஸப்ஷன்? இப்போ ஃப்ளோரில் சொல்லு எக்ஸப்ஷனுக்கு என்னடா. ஆழமாக படித்தா தெரியாது. பிஜி வந்து நல்லா படி. எப்போப்பா படித்தா செய்யுது? இந்த 2 மாதம் இருக்குது, நல்லா உட்காந்து படித்தா தான் இதான் நாலேஜ். எடுத்து நோட்ஸ் வச்சுக்கோ, லைஃப் லாங் யூஸ்ஃபுல்லாக இருக்கும். ப்ராக்டிஸ் பண்ணப்போ அடிச்சா வந்து சேர்த்துக்கிட்டே இருக்கலாம். எனிபடி இதை அறிவிச்சு இருக்கானா? எக்ஸப்ஷன். அவன் படிக்கலை, படித்தா தான். என்னடா சொல்கிறா, எந்திரி உட்காந்தே பேசாத. கதை தெரியுமா? 3ல் இறங்க ஒருத்தனுக்கு தான் பேர் என்னப்பா அவன் தெரியுமாப்பா? 3ல் இறங்க ஒருத்தன் தான் சொல்லியிருந்தாங்க. அவன் உன்னை மாதிரி யோசிச்சுக்கிட்டே இருந்தேன். கடைசி ஆம்ஸ்டாங் கரெக்டாக ஆம்ஸ்டாங் பேர் ஊர் முழுக்க வந்துருச்சு. ஆம்ஸ்டாங் இஸ் நாட் அலவுட் டு லேண்ட் இன் த மூன். இறங்க சொன்னால் ஒருத்தனுக்கு தான். அவன் யோசிச்சுக்கிட்டே குழம்பிட்டே இருக்க போய் தான் கடைசியாக அவன் போயிட்டான். என்னப்பா எனக்கு பேர் ஞாபகம் இல்லை தம்பி, வயசானலாம் கொஞ்சம் சின்ன சின்ன ஞாபகம் வருது இருக்குது. முதல்ல ஒருத்தனை தான் அவன் தான் இவா சாஸ் டு லேண்ட் இந்த மூன். அந்த போய் உன்னை மாதிரி யோசிச்சுக்கிட்டு இப்படி யோசிச்சுட்டு போய் இறங்கலை, டக்குன்னு ஆம்ஸ்டாங் இறங்கினா அவன் பேர் போயிடுச்சு. எக்ஸப்ஷன் மிடில் மெனிஞ்சல் ஆர்டரி, it is a branch of the maxillary artery. It enters the cranial cavity which supplies your meninges. One of the cause for your extradural hematoma common. புரியுதா? ஸோ எக்ஸல் கரோட்டிட் ஆர்டரி வந்து பிரான்ச் பிரெயினுக்குள்ளே போகாது, கிரேனியல் போகாதான்னு போகும். இது இதெல்லாம் கேள்வி உனக்கு நீட்டு பிஜிக்கு நீ எம்சிஹெச் போனால் கேள்வி கேட்பான். ஸோ மிடில் மெனிஞ்சல் ஆர்டரி பிரான்ச் ஆஃப் தி maxillary artery enters into the cranial cavity. That is the name nomenclature. Internal carotid, external carotid. Yes. சொன்ன ஆன்சர் கரெக்ட். எக்ஸல் கரோட்டிட் தான் மீடியல்னு சொன்னேன். எக்ஸல் கரோட்டிட் இஸ் மீடியல், இன்டர்னல் கரோட்டிட் இஸ் லேட்டரல். So will you palpate both carotid in the same time?
Yes sir. No sir.
ஆமா
sir. இல்ல sir.
அதெல்லாம் சொல்ல புரியுதா? ஏப்பா இதுக்கு டீல வந்து கஞ்சா போட்டு கொடுக்குறீங்கப்பா, டீ ஒரு போதையில் இருக்காடப்பா. ஏடா ஒரு தெளிவாக இருக்கா பரிசு இதே மாதிரி. ஆமாம் வந்து என்னடா இருக்க வாழ்க்கையில். ஒருத்தவங்க வாத்தியார் கிளாஸ் எடுத்து முடிச்சிருக்காரு, சார் வந்து தெளிவாகிறான்னு சொல்லியிருக்காரு. சார் வந்து ப்ரிசைஸாக இரு, கிளியராக இரு, குழப்பமே இருக்கக்கூடாதுடா. சார் வந்து உண்டு இல்லை, ஆப்ரேஷன் பண்ணுறேன் பண்ணலை முடிஞ்சு, பி கிளியர், ஷார்ப்பாக டிசைட் பண்ணால் இல்லாட்டி சேர்ந்துக்கு வரவே கூடாது. போய் மருந்தை மாற்றி போட அதை போட்டு ஃபிசிஷியனாக போயிடணும், குழப்பம் இருக்கக்கூடாது, தெளிவார். என்னடா சொன்னேன், ரெண்டும் சேர்த்து பார்ப்பேன். ஏன்டா பார்க்கக்கூடாது
சார்? செக் இண்டிவிஜுவலி சார். தனித்தனியாக பார்க்கணும்
ஏன்
சார்? பேஷண்ட் மே கோ ஃபார் சின்கோப்.
ஒய்
சார் ரெடியூஸ்டு பிளட் சப்ளை டு த பிரெயின் and carotid sinus stimulation sir.
Carotid sinus you are palpating, patient you are stimulated, vagal tone will be increased, bradycardia, even patient may die. அதனால அட்டேட்ட ஒன்று மட்டும் 2 பக்கம் பார்க்கக்கூடாதுடா. எஸ்.
Percussion, resonant note over the manubrium sternum, auscultation.
ஏன்டா சும்மா ஏன்டா கை பாத்திரத்தை தட்டிக்கிட்டே இருப்பியா? ஏன்னா லோவர் பார்டர் பார்த்த பிறகு எதுக்கு போய் பர்கஸ் பண்ணுற முட்டாளே, அதெல்லாம் பண்ணக்கூடாது. இப்படி தான் பரீட்சையில் மாற்றுறது கமிட் சூசைட், எக்ஸாம் பிடிச்சிக்குவான். யூ சார் லோவர் பார்டர் பேல்பிள் அமைதியாக இரு, புரியுதா? எக்ஸாமில் வந்து சிம்பிளாக ப்ரெசென்ட் பண்ணி தப்பிச்சு போகக்கூடிய வழியை பாரு. இப்போ இந்த லோவர் பார்டர் எதுக்கு நீ பர்கஸ் பண்ண போகிற, தேவையில்லையில, எதுக்கு நான் பர்கஸ் பண்ணுறேன், தேவையில்லைடா. ஸோ நான் பவுட்ரு போட்டு குளிப்பேன்னு சொன்னால் அப்போ நம்ம மாதிரி நினைப்பாங்க, தேவையில்லாத வேலை, புரியுதா? எஸ்.
Auscultation, no bruit here. Other system examination, CVS S1, S2 here, no murmur.
குரு எங்கே கேட்பேன், சாதாரண எங்கே கேட்கும், ஒய்
சார் ஒரு superior pole of thyroid.
எந்த கண்டிஷனில் காமன்?
சார் primary toxicosis.
Why you get the superior pole?
It is the site where superior thyroid artery enters.
எதுக்கு அந்த சைடை சூஸ் பண்ணுறேன்னு கேட்குறேன்.
Superior thyroid, which is a direct branch from external carotid artery.
Yeah? Direct branch of?
External carotid artery.
First and direct branch of external carotid blood supply அதிகமாக வரும். That is why you got a primary toxic item. Because in this vascularity you will be able to see a bruit. Reason of that. Yes?
RS, normal vesicular blood sound here, no added sound.
RSல வேறு என்ன பார்ப்பீங்க
சார்?
RSல என்ன பார்ப்பேன்? Any abnormality?
ஸ்லைடு கீழே இருக்கு, பால்பேஷன் கொஞ்சம் எடுத்துக்காமி. Palpation.
See here RS is okay. Is there any finding? What other finding you can expect? Respiratory systemல என்ன பார்ப்பீங்க? Pleural effusion. Because the carcinoma thyroid will produce infiltration and effusion. Right? Right. Abdomen என்ன பார்ப்பீங்க?
Abdomen. Organomegaly.
என்ன இருக்கு அப்டமன்ல? நார்மல்.
நார்மல் சார்.
என்ன ஆர்கனோமெகாலி பார்ப்பீங்க?
ஹெப்படோஸ்பிளினோமெகாலி.
ஹெப்படோஸ்பிளினோமெகாலி. லிவர் ஹெப்படோமெகாலி which condition?
An autoimmune condition like Hashimoto's.
ஹெப்படோஸ்பிளினோமெகாலி in Hashimoto's வேற
medullary carcinoma.
medullary carcinoma. Only hepatomegaly. Any other condition? Secondary infiltration. Papillary carcinoma will produce secondary infiltration in the liver. புரியுதா?
ஏப்பா நோ cervical node போடுங்க, எந்த cervical node பார்ப்பேன்?
Level 2, 3, 4.
நீடா?
upper jugular, middle jugular, lower jugular.
அதான் இது தைராய்டு, அதாவது நான் சொல்லலை, ஒரு சிலர்லாம் வந்து யூ ஷுட் பி வெரி கிளியர். The lymph node which you are supposed to examine thyroid is where level 6, not 2. எந்த நோடு தைராய்டு ட்ரெயினர் நோடு, ஃபர்ஸ்ட் நோடு?
P-laryngeal. Delphian node, P-laryngeal lymph node.
பிற லெவல் 2ன்ற அது எதுலடா வருது? அது லெவல் 2ல வருது?
level 6.
level 6 சார்.
level 6 எக்ஸ்டென்ட் என்னடா? எங்கிருந்து எங்கடா எக்ஸ்டென்ட்? What is the extent of level 6?
Superiorly hyoid bone, superiorly hyoid bone, inferiorly sternal notch or innominate artery.
Innominate vein.
ஏன் ஒருத்தன் சொல்லி சொல்றா, சத்தம் மைக்கிட்ட வந்து பேசுறா.
Use the mic man.
Superiorly hyoid bone.
Superiorly
hyoid bone.
என்ன போன? hyoid, right? Agreed.
Inferiorly innominate artery.
Innominate artery.
On both sides by carotid.
Carotid. அதானே ஃபஸ்ட்டு ட்ரெயின் நோடு அதுதானடா. அதை விட்டு லெவல் 2ங்கிற 3ன்ற இதை சொல்லவே மாட்டேன்ற. த ஃபஸ்ட்டு இது லெவல் ஆஃப் நோட் ஃபார் தைராய்டு இஸ் level 6. ஸோ அவன் என்ன சொன்னா தம்பி? டெல்ஃபியன் நோடு சொன்னீங்களா? அது எந்த நோடு?
ப்ரீலரிஞ்சியல் lymph node.
ப்ரீலரிஞ்சியல் நோடு. ஸோ ப்ரீலரிஞ்சியல், ப்ரீட்ரக்கியல், பேராட்ரிக்கல் குரூப் ஆஃப் லிம்ஃப் நோட்ஸ். அதான் ஃபஸ்ட்டு நீ வந்து பார்க்கறாங்க, அதை சர்ச் பண்ணி பார்க்கணும். அதுக்கு பிறகு நீ போய் 2, 3, 4 போய் சொல்லு, புரியுதா? ஸோ தைராய்டு போகிறப்ப 2 சொல்லாதடா, லெவல் 6 மறக்காத. ரைட்.
CNS என்ன பார்ப்பீங்க? You are not mentioning about the CNS. Is it necessary to examine the CNS? பார்க்கலாம். What finding you can expect?
Pulsatile
பார்க்கணும்.
Pulsatile.
புரியுதா?
Hyperexia, hyperexia,
exaggerated-ஆ, diminished-ஆ, புரியுதா? ஹைப்போதைராய்டிசம் ஹைப்பரான்னு பார்த்துடலாம். ரைட்.
எனக்கு ஃபார் கம்ப்ளீஷன் லெவல்ஸ் ஆஃப் நோட் இந்த நெக்ஸ்ட் சொல்லு.
சார்
லெவல்
1 submental nodes, submental and submandibular, level 2 upper jugular, level 2 middle jugular, level 3 lower jugular, level 2 upper jugular, level 3 middle jugular,
level 2 upper jugular என்னடா போதையாடா, ஒரு குழப்பத்தின் உச்சமா இருக்கேடா, ஒழுங்கா சொல்றா. அப்பர் ஜுகுலார் இந்த ஜுகுலார் ஐயோ அப்பா சொல்லு.
upper jugular, 3 middle jugular, 4 lower jugular, 5 posterior triangle nodes, 6 pretracheal, prelaryngeal, 7 anteromediastinal nodes.
Mediastinal, right. So thyroidல வந்து லெவல் 1 இருக்காது, very rare. You have level 2, 3, 4, 5, 6, 7 வராது, லெவல் 6 ஓட முடிச்சுக்கோ. ஃபர்ஸ்ட் எங்க பாப்பனா தைராய்டு வந்து you must say level 6 ஃபர்ஸ்ட் நீ அதான் சொல்லணும், சரியா? ரைட்.
Spine and cranium normal, no eye sign seen. Summary: a 16-year-old female came with swelling at anterior surface of neck for 15 years with no malignant.
பட் இது வந்து plane of the swelling சொல்லவே இல்லையா? plane of the swelling நீ சொல்லவே இல்லைல.
It is
when swelling moves with the deglutition, it is when swelling moves with deglutition, it is confined to deep fascia.
Deep to
strap muscles தானப்பா. deep fascia எதுக்கு சொல்ற? it is deep to strap muscles. அத வச்சு நீ சொல்ற. is there any test?
strap muscle எப்படி போகுது?
இப்ப strap muscle எதுவும் டெஸ்ட் இருக்கா? இல்ல என்ன டெஸ்ட் இருக்கு?
fold the tongue against
என்னப்பா?
fold the tongue against
the hard palate, which makes the strap muscle taut.
hard palate வந்து எதை வச்சு என்ன பண்ணுவ?
folded tongue, folded tongue
வச்சு
please press against the hard palate.
அது பண்ணா போதுமா? lift the hard palate with the tongue, then ask the patient to deglute. The muscle will contract. lift பண்ணிக்கிட்டே deglute பண்ணணும், then only the strap muscle will contract.
it is very difficult to perform பா. எழுதி வச்சிருக்கேன், அதெல்லாம் should be erased from the text book. நீ எல்லாம் யூத், அதெல்லாம் வந்து it should be erased.
But you must know
அவன் சொன்னது மாதிரி when it moves to the deglutition, it is deep to strap muscles. முடிஞ்சு நோ. இந்த அனாட்டமி ப்ரோஸை கூட தெரியாண்டாரு டெஸ்ட்டு. அவன் சும்மா எழுதி வச்சிருக்கேன். ஆனால் பட் இது சும்மா படிச்சுட்டா சொல்ல தெரிஞ்சுக்கோ. பட் இட்ஸ் வெரி டிஃபிகல்ட் டு டூ தட்.
What tendency is cystic swelling? It is hard in consistency, and malignancy usually hard because of the cellular multiplication. It is softer in the center. This is thyroid paradox.
So in this case, 60 years female, multiple goiter. What is your aim here? As a surgeon, you are seeing the patient. Patient came to you. What's your aim?
To rule out malignancy.
Yes.
Rule out
Because,
malignancy.
yes. How do you rule out malignancy? What are the essential steps you have to do?
First, I will do thyroid function test.
Pardon?
First, I will do thyroid function test. First, I will do
thyroid function test.
By malignancy, okay. Thyroid function test. Malignancy. Okay.
Ultrasound neck and FNAC.
ஏன்னா அல்ட்ரா சொன்னால் என்ன இருக்கும்? தைராய்டு என்னடா இருக்குது? சும்மா என்னடா ஏதோ சும்மா ஏதோ தெம்மாங்கு பாடின மாதிரி பாடுற. தைராய்டு ஃபங்க்ஷன் டெஸ்ட், ஊர் உறங்கியது, உலகம் சுற்றியது, மனிதர்கள் சிரித்தால் இதடா பதில், ஒரு பிஜி மாதிரி சொல்கிறா. இப்போ தைராய்டு ஃபங்க்ஷன் என்னடா இருக்குது மலிக்னன்சிக்கு?
Mostly it will be euthyroid, sir.
என்னப்பா?
Mostly it will be euthyroid.
Euthyroid or hypo?
Hypo.
ரைட்டு. அல்ட்ராசவுண்ட் என்னடா இருக்கும்?
Ultrasound, it will be, there will be microcalcifications, loss of peripheral halo, taller than white lesions, hypoechogenic foci, margins should be irregular, and there will be notes will be there.
ஸோ அல்ட்ராசவுண்ட் எல்லாமே சொல்லிட்டேன். இப்போ மைக்கு உனக்கு தெரியுது, மைக்கு பயன்படுத்துகிறா, மைக்கிட்ட வா, மைக்கை கிளியராக பேசு, தெரியுது உனக்கு சொல்ல தெரியல, ஒழுங்காக சொல்ல நான் சொல்கிறேன்.
In ultrasound there will be microcalcifications, loss of peripheral halo, hypoechogenic foci, irregular margins, taller than white lesions.
ஸோ இப்போ நீ சொன்ன அல்ட்ராசவுண்ட் அவன் சொன்னதெல்லாம் சரிதான், அவன் கரெக்டாக சொல்ல தெரியல. இப்போ தைரியமாக பேசுகிறா. Nodules are taller, margins are irregular, calcification, increased vascularity, hypoechoic. Normally you got a halo, there's a nodule, there's a nodule, you got a halo, but yes, the halo will be absent. Okay, malignant infiltration, the halo will be absent. So these are the features to say ultrasound wise is malignant. So the nodule is taller, irregular margin, calcification, increased vascularity, hypoechoic, and then absence of halo. This is ultrasound finding to say it is a malignant. So ultrasound we say it's a solid or cystic. Malignant or benign. Benign is a margin will be regular, normoechoic, normal vascularity, there is no calcification, you will have a halo but even the nodule and the normal tissue. That is why we say benign, ultrasound wise. இப்போ சார் கேட்ட மாதிரி cyst வந்து soft, solid cyst வந்து firm, but in thyroid, because of the tense cyst, it may look like a very hard, which is a pathognomonic feature for your papillary carcinoma of the thyroid. What is complex cyst? What is simple cyst? What is complex cyst?
Simple cyst contain clear fluid. Complex cyst contain both solid and.
What is significance of complex cyst?
Sir?
Clinical significance.
Malignant transformation will be more.
Yes, malignant transformation. Complex cyst is a clinical suspicion that patient may have a malignant changes. Yes, right. So you got ultrasound then.
You said FNAC.
Yes, sir.
Size of the needle.
For FNAC, we should use a 23 gauge needle.
Syringe.
10 ml syringe.
How many pass-throughs?
How many? Minimum 6 passes with minimum 6 cluster of cells. Each cluster contain 20 cells.
So in FNAC, which malignancy you will be able to diagnose, which malignancy you may not?
In FNAC, papillary carcinoma thyroid can be diagnosed, medullary carcinoma thyroid, and follicular carcinoma cannot be diagnosed by FNAC.
Why?
Because it is diagnosed by vascular and capsular invasion by biopsy only. Sir.
Good. So that's the answer. FNAC வந்து papillary பார்த்துடலாம், medullary பார்த்துடலாம், follicular பார்க்க முடியாது. To say follicular carcinoma, you need vascular invasion and capsular invasion, otherwise pathology will not say. So FNAC you cannot do, right? Yes.
In medullary carcinoma, one more thing you can add to find out. Apart from FNAC, ultrasound, one more marker.
Calcitonin.
What scan you will do for medullary carcinoma?
Indium
scan.
Indium triple one.
Huh?
Indium triple one.
Right. So indium
triple one
labeled. That will make out your medullary carcinoma. Agreed. Yes. வேற என்னப்பா இன்வெஸ்டிகேஷன் பண்ணுவேன்? இல்லப்பா எல்லாம்.
When you will do CT?
Sir, suspect malignancy.
There is retrocenal extension.
Retrocenal extension.
Yes.
Neck nodes. To see the neck nodes.
There is a neck nodes or
there is extension. There is.
Right, you
follicular carcinoma. Follicular carcinoma.
Follicular carcinoma. So multinodular goiter, you will have follicular carcinoma. Correct answer. பதில் அதுதான். So the report comes as benign. What is your treatment? If the report comes as malignancy, what is your treatment? So when சொன்னதோட you add your ideal indirect laryngoscopy. X-ray of the neck. So lateral and anteroposterior view to know the lumen of the your trachea, so that anesthetist will choose a correct tube. Ideal is a must. Ideal மறந்துடாத. இதெல்லாம் போக எக்ஸ்ட்ரா வந்து இன்டாக்ட் லாரிங்கோஸ்கோப்பியும் எக்ஸ்ரே நெக்கும் நீ வந்து நீ எடுத்துக்கணும். Now report has comes, FNAC comes as a benign, what is your management?
Total thyroidectomy for benign, sir.
Benign total பண்ணுறேன்.
சரி இருப்பா. malignancy?
Sir,
central
lymph node dissection.
என்னடா முதல்ல
total thyroidectomy and அப்புறம் சொல்லு central nodeன்ற
சொல்ற தைரியமா பேசு.
Sir, total thyroidectomy if plus central neck node dissection.
Later total thyroidectomy பண்ற malignancy-க்கு. Why do you want to do total thyroidectomy?
If post-oply, if you are going to do radioactive iodine, it will be taken up by the remaining thyroid cell. So we do total thyroidectomy.
And post follow-up, there will be thyroglobulin assay should be monitored. So it should be there will be total thyroidectomy should be done.
Rather than பண்ற. Right. Benign-க்கும் total, malignancy-க்கும் total ஆ? சரி ரைட் குழப்பம் வேண்டாம். ஸோ நீ தைராய்டு வந்து பரீட்சையில் நீ சொல்ல வேண்டிய பிஜி சொல்ல வேண்டிய வந்து benign disorders, FNAC, hemi-thyroidectomy. When it's confined to the one lobe, a solid nodule. So multilateral guide is a near total thyroidectomy, near total. Malignancy total. இவ்வளோதான் 3 சர்ஜரி தான்ப்பா. ஸோ benign hemi, ஸோ benign multilateral guide near total, malignancy total. Toxic guide total. ஏன்னா recurrent thyroiditis is very difficult to treat and operate. So total thyroidectomy. இந்த 3 சர்ஜரி தான் நீ பரிச்சை சொல்ல வேண்டியது. நீ வந்து you must use the word near total. Near total என்னடா?
Sir, leaving behind 1 to 2 gram of tissue at the tracheoesophageal groove. To
save your recurrential nerve and the parathyroid, you leave behind a bit of tissue. That is minimum 2 gram. That is near total. Then you சொல்ல வேண்டிய answer. How will you identify recurrential nerve? What is Riddle's triangle?
Sir, superiorly inferior thyroid artery, laterally carotid sheath.
என்னடா superior inferior thyroid artery? என்னடா புதுசா சொல்ற? நீடா
bounded by inferior thyroid artery. Bounded by inferior thyroid artery inferiorly and by recurrential nerve and carotid artery on sides.
என்னடா சொல்ற? என்னப்பா?
எனக்கு நல்ல சொல்லு.
இரு அதாவது நான் என்ன சொல்றேன்?
It is bounded by inferior thyroid artery.
Inferior thyroid artery எங்கடா?
On the inferior
base. தெளிவாடா வாழ்க்கையில ஒரு தெளிவா
base will be found.
base எங்கடா இருக்கு? இங்க பாரு வெயிட்ஸ். இங்க பாருப்பா சர்ஜனுக்கு வந்து எப்பயுமே நல்ல நாலேஜ் இருக்கணும். சொல்றது எழுதுறா அப்புறம் எழுதுறா. What is surgery? Surgery is the ideal procedure for the patient. எழுது. It removes a diseased organ from the patient, put it in a bottle for biopsy, bring back the patient to the normal stage. எழுது. Provided the surgeon is competent. So the competency includes to examine clinical diagnosis. Number 3, operative skill. அறிவு இருக்கு எல்லாம் பண்ணுற ஆப்ரேட் பண்ண தெரியாட்டி வேஸ்ட்டு. இப்போ அப்படி தான் பேஷண்ட் போஸ்ட் ஆப்ரேட் சைடு வந்துச்சு நீ பண்ணால் ட்ரக்கேஷன் பண்ணிகிட்டே இருக்க முடியாது. அட்டர் வேஸ்ட். ஸ்கில் இருக்கணும். ஆப்ரேட்டிவ் ஸ்கில், போஸ்ட் ஆப்ரேட்டிவ் கேர். ஆப்ரேட் பண்ணி போட்டு போயிட முடியாது. யூ ஷுட் கிவ் எ குட் கேர் ஃபார் த பேஷண்ட். தென் ரீஹாபிலிட்டேஷன். இப்போ நீ பிலோனி ஆப்ரேஷன் எபோனி ஆப்ரேஷன் பண்ணியிருப்பா, ப்ராசஸ் போட்டு செஞ்சு சமூகத்தை நடக்க விடணும். இவன் தான் சர்ஜன். இதான் சர்ஜரி. Surgery is ideal procedure for the patient. It remove the diseased organ from the patient. Put in a bottle for biopsy. குப்பையில் போட்டுறக்கூடாது. Bring back the patient to the normal stage. இப்போ கண்ணு தெரியலாம்பா, உள்ள ஐஓஎல் கண்ணை உலகத்தை பார்ப்பான், கைகாலாம் ஒடிஞ்சிருக்கும். இப்போ பிளேட்டிங் டன், திரும்ப எழுச்சி ஓட ஆரம்பிச்சிருவான். ஐயான்னு அழுதுட்டு வருவான், அப்பெண்டிக்ஸ் பண்ணுவேன், அடுத்த நாள் போயிட்டு வரேன் டாக்டரும்பான். அதான் சர்ஜரி. அதுக்கு உனக்கு வந்து அறிவு வேணும், கிளினிக்கல் டயக்னோசிஸ் வேணும், ஆப்ரேட்டிவ் ஸ்கில் வேணும். படிக்காமல் வரக்கூடாதுரா தம்பி, பிளைண்டாக இருக்கக்கூடாதுரா. நீ எனிபடி இந்த ஃப்ளோர் வாட் இஸ் ரிலீஸ் ஆகி வாட் ஆர் த பவுண்டரிஸ் தெரியலை. ரைட். ஸோ மீடியலி ட்ரக்கியா, medial trachea, then laterally your common carotid. Apex is found by the junction of your trachea and your common carotid. Base is above. Apex வந்து கீழடா, base வந்து மேலே. Base is formed by the inferior thyroid artery. There you have the recurrent laryngeal nerve. That is Riddle's triangle. Then Behr's triangle. So there, recurrent laryngeal form be a boundary recurrent laryngeal nerve. Common carotid medially by the recurrent laryngeal, medially by your lateral by the common carotid, above by the inferior thyroid artery. Behr's triangle, BEHRS, Behr's triangle. தெரியும் உனக்கு பச்சை கட்டாயம் கேட்டுவாங்க பிஜிக்கு. Riddle's triangle தெரியும். Riddle's triangle சொல்லு, நான் சொன்னது சொல்லு. Medially trachea, laterally
common carotid,
apex is below, base is above. The base is formed by the inferior there is a branch of
thyrocervical trunk.
Which is a branch of
subclavian.
இதே ஃப்ளோர்ல சும்மா இருடா, அவன் தான்டா சும்மா இருடா.
Subclavian.
First part of the subclavian. Subclavian சொல்லாத, first part of the subclavian. இதெல்லாம் தெரியணும். Recurrent, that is how you search. What is thyroid surgery? Dissection of the recurrent laryngeal. எழுதுடா, dissection of recurrent பரிச்சை தான் பொறுச்சுக்கணும். Thyroid is nothing but dissection of the recurrent laryngeal. Recurrent laryngeal ஒழுங்கா dissect பண்ணாலே thyroid surgery பெரிய ஆளு. A surgeon, a general surgeon competency is being assessed by your recurrent laryngeal nerve and facial nerve. இது ரெண்டையும் ஒழுங்கா பண்ணாலே நீ எந்த பிரான்ச்சுக்கு நீ போகலாம், நீ பெரிய ஆளாக வந்துடலாம். இது ஒழுங்காக ஆப்ரேட் பண்ணி போனால் இது பெரிய காரியம். recurrent laryngeal. How will you identify parathyroid? What is the relation of the parathyroid and inferior thyroid artery recurrent laryngeal nerve?
Sir, superior parathyroid lies posterior to the recurrent laryngeal nerve.
என்னடா எதா superior எதா அர்த்தம் இருக்கான்னு பாரு.
Superior parathyroid.
அதாவது கிளியரா பேசுறா.
Superior parathyroid lies
பண்றோம். அப்படி எங்க என்ன பண்ணுவேன்? 4 பேர் என்ன பண்ணுவாங்க?
Peritoneal implant.
removed means we make into multiple pieces and inject into the sternomastoid or brachioradialis.
ஸோ ஸ்டெர்னோமாஸ்டாய்டுக்குள்ள போடணும், இல்லாட்டி நான் டாமினன்ட் லிம்பில் வந்து ஃபோராமஸ் வந்து நீ பண்ண கரெக்ட்.
வாட் இஸ் நோட் ஆஃப் பாயிரர்? பாயிரர், POIRER. நோட்
Pretracheal, which compress the recurrent laryngeal nerve.
The node along the course of the recurrent laryngeal nerve are called node of Poirer. Suppose in this ordinary inflammatory condition, it will produce hoarseness of the voice. That is why you must know about the node of Poirer. Right. Suppose in your case, only one lobe is involved, and the FNH is papillary carcinoma. What is the treatment?
Total thyroidectomy.
Total.
இதெல்லாம் பிஜி
கேள்வி also can be
பாஸ். ஒரு நிமிஷம் பாஸ், இல்லை பிஜி கேள்விடா, அதெல்லாம் யோசிச்சு பதில் சொல்கிறேன். உனக்கு கேள்வி கிளியராக கேட்குறாரு. ஒரு லோபு அங்கே மட்டும் பாப்புலர் கஷ்டமாக இருக்குது, என்ன பண்ணுவேன்? யோசிச்சு பதில் சொல்லு. இவரை போஸ்ட் நான் அண்டர்
Hemithyroidectomy, send the specimen to biopsy. If it is a microcarcinoma, we can follow the patient.
இல்லை ஆல்ரெடி பாப்புலர் கார்சினோமா வந்துருச்சு இல்லை?
We look for the size of the lesion, sir.
See, what is NCCN criteria for lobectomy? Version 2, 2018. என்ன NCCN criteria? What are the criteria for lobectomy in carcinoma thyroid?
Size less than 4 cm.
Low risk patient. The patient must be low risk. Age will be less than 45 years. No history of previous irradiation. Size of the tumor will be less than 4 centimeter. No extrathyroidal extension. No lymph node metastasis. So with this condition we can do lobectomy and observe the case. Follow the patient. When will you do the total thyroidectomy in this case? What is the surgery?
Completion thyroidectomy.
When will you do completion thyroidectomy in these patients? What are the criteria for completion thyroidectomy after lobectomy?
If The
There's aggressive variant, tall cell variant. If there is aggressive tall cell, aggressive variants, tall cell columnar diffuse fluorescing variants, and if there is extracellular invasion,
the margin will be not clear margin. So you are operated. It is not a clear margin. After surgery, it may be large size tumor, more than 4 centimeter. Then multifocus origin. Macroscopically, on cut section, it is multifocus in origin. Extrathyroidal extension and or after 3 weeks. Because why after 3 weeks? 12 weeks. Why? Not 3 weeks. Within 3 days you can do completion thyroidectomy or wait for 12 weeks. After that only you do completion thyroidectomy. Right?
ஸோ இப்போ papillary carcinoma அப்படி சொல்லி வந்துச்சுன்னா criteria for your lobectomy alone. So less than age 40, less than 1 centimeter, no node, right? So no, these there is no previous history of neck irradiation. The criteria is you do a hemithectomy, you follow up the patient. Follicular carcinoma more than 4 centimeter, right? When you have extra capsule, that is your capsule invasion, and then vascular invasion is there, then you go for total. No vascular invasion, no capsule invasion, less than 4 centimeter, then you can go for those type of patients also low risk group, they say you can observe. So this is 1 centimeter for papillary, follicular is 4 centimeter, age is 40 criteria.
Yes, the NCCN criteria, right?
You tell me the pathogens of goiter, multinuclear goiter.
Decrease the T3 and T4 with increase rise in TSH, which stimulate the diffuse hyperplasia of the thyroid follicle. Due to increased thyroid follicle, there will be increased colloid deposition, which will get changed into necrosis or hemorrhage into the nodule. Some nodule become active, some nodule become inactive. The internodular tissue will become active in a multinodular goiter.
Right now it goes for secondary toxicity. Whether nodule is active or internal tissue is active.
Internal toxin.
Internal tissue is active. That's the message. So if with the malignancy in multinuclear goiter, follicular carcinoma, so what is the difference with the primary toxic thyroid toxicosis and the secondary toxic goiter? So primary toxic goiter, secondary toxic goiter.
Primary, the most common system involved is CNS. It is autoimmune origin. It occurs affect a young age group. The symptoms occur first, followed by the goiter. In secondary, CVS is commonly affected. It occurs in MNG goiter. It common in old age. Treatment will be only surgery. But for primary, you can antithyroid, radioactive iodine and surgery.
Right,
last question, what is metastatic carcinoma thyroid?
Metastasis from the kidney,
right,
colon,
breast,
kidney, colon and bronchogenic carcinoma. Right, bronchogenic carcinoma and renal tumors will produce metastatic infiltration in the thyroid. 2%, about 2% of the cases you can get. Right.
Right, good.
Thank you.
Thank you.
Very good presentation.
Thank you, sir.
Thank you, sir.
The next presenter is Dr. Sujita.
Good evening, sir.
எப்போ இன்னொரு கேள்வி பரீட்சையில் கேட்குறது, எத்தனை ட்ரக்கியல் ரிங் வரைக்கும் நீங்கள் வந்து எடுக்கலாம் அப்படின்னு எக்ஸாம், இன்னும் பிஜி எக்ஸாம் எத்தனை ட்ரக்கியல் ரிங் எடுக்கலாம்? இப்போ நான் ஆப்ரேட் பண்ணுறேன், ட்ரக்கியல் ரிங் வந்து ஒரு அட்ரண்டாக இருக்குது, எத்தனை ரிங் வரைக்கும் எடுக்கலாம்? பரீட்சையில் எக்ஸாம் கேட்குறது ரெண்டு எடுக்கலாம். 2 எடுத்துகிட்டு யூ கேன் டூ a primary closure. Switch metal proline. So 3-0 or 4-0 proline. You injure the rectal angina, what will you do? So on the table you can do a suturing, or you can put a nerve graft. Nerve graft எங்கேருந்து எடுப்பேன்னு கேட்பான். எங்கேருந்து எடுப்பேன்? ப்ரெசென்டார் எங்கேருந்து எடுக்கிறது?
Posterior.
என்னடா? Ansa cervicalis. Ansa cervicalis. இன்னொரு கேள்வி பிஜியில் எக்ஸாம் கேட்குறது, வேர் வில் கெட் த ஸ்டாப் மசில்ஸ்? கீழே கட் பண்ண மேலே கட் பண்ண, இப்போ ஹியூஜ் தைராய்டு ஸ்டாப் மசில்ஸ் எங்கடா கட் பண்ணுவேன்? என்னடா சொல்கிறேன்? என்ன சுப்பி ஓய் அன்சா cervicalis எப்படா ஃபார்ம் ஆகுது? cervical plexus hypoclasse. So the rest of the strap muscle is only in the lower end. So if you want to cut, when the difficult thyroid, to cut the strap muscle in the upper end. இதெல்லாம் பரிச்சை கேட்குற கேள்வி.
Now it is disproved, now it is disproved. You can cut it anywhere. It is a segmental nerve supply. It will supply.
Another newer thing, now you got a segmental supply. You can cut anywhere. Newer developments. That also you must know. So nerve எடுக்கிறது வந்து ansa cervicalis. பக்கத்துல எடுக்கக்கூடிய nerve வந்து ansa cervicalis. Yes.
Good evening, sir. My case presentation is on a 21-year-old gentleman who is a college student presented to the OPD with the chief complaints of growth in the left leg for 6 months. Patient was apparently normal before 10 years. Then he developed hyperpigmented patches in the left leg, following which he developed itching and the lesion became hyperpigmented 6 years back, and then he noticed a growth over the lesion 6 months back, which progressed to attain the present size. Not associated with pain, associated with discharge from the growth for the 3 months, which is scanty, serous and not foul smelling. History of bleeding associated with trivial trauma from the growth. No history of long-standing exposure to sunlight, no history of long-standing mole, no history of burns, no history of trauma, no history of fever, no history of any other swelling, no history of chest pain, hemoptysis, jaundice, no history of loss of weight or appetite. Past history, not a known case of diabetic mellitus, systemic hypertension, bronchial asthma, addiction, sleep and appetite normal. No other family members have similar complaints. On general examination, patient condition is fair, no pallor, not icteric, no cyanosis, no pedal edema, no generalized lymphadenopathy except for the inguinal nodes. Vitals, temperature normal, pulse rate 90 per minute, regular, normal in volume, no specific character, felt equally in all peripheral pulses. BP 110/70 millimeter of mercury, SpO2 98%. Local examination of the left leg. On inspection, irregular proliferative growth which looks like cauliflower growth of size 5 cross 4 centimeter seen on the anterolateral aspect of the distal 1/3 of the left leg just above the lateral malleolus. The surface appears irregular, margins are ill-defined, scanty serous discharge present. The surrounding skin is hypopigmented. There is presence of hypopigmented patch on the superior aspect of the growth. There is no restriction of ankle movements. There is no deformity. No other swelling or ulcer visible elsewhere. No sinuses. On palpation, there is no rise of temperature, not tender. The inspectory findings of size, shape, surface and extent confirmed. Margins are ill-defined, hard in consistency. It does not bleed on touch. Mobile in both horizontal and vertical directions. The surrounding skin sensation is normal and surrounding skin induration present. There is no distal neurovascular deficit. On examination of regional lymph nodes, a single non-tender, mobile, firm, vertical group of inguinal nodes of size 1 cross 1 centimeter palpable on the left side. Other system, CVS S1, S2 here, no murmur, RS bilateral air entry present, no added sounds, per abdomen soft, bowel sounds present, no organomegaly. On summarizing, a 21-year-old gentleman with chief complaints of growth in the left leg for 6 months, irregular proliferative growth of size 5x4 cm on the anterolateral aspect of the distal 1/3 of the left leg, just above the lateral malleolus, serous discharge present, surroundings in hypopigmented, margins are ill-defined, the swelling, the growth is hard, mobile in both directions.
You are telling mobile,
Sir.
whether it is a benign or malignant, your diagnosis.
Benign swell,
Your diagnosis benign or
malignant, sir.
how it is mobile?
Sir, it does not infiltrate the underlying structures.
Whether
Surrounding skin is indurated, a single non-tender mobile firm vertical group of inguinal node of size 1x1 cm palpable on left side. The diagnosis is a case of squamous cell carcinoma of the left leg.
Do you have any pathological microscopic eyes?
Sir?
Say squamous cell
what
carcinoma.
is the clinical name for this squamous cell carcinoma?
Marjolins ulcer.
Marjolins, sir.
Sir, clinical.
So what is your diagnosis?
என்னம்மா மாஜுலன்ஸ் நீ என்னம்மா
What is Marjolins ulcer?
யோசிச்சு பார்த்து சொல்லுங்க.
Ulcer develop in chronic scars, burns, sinuses.
In your case, is it present from the scar?
Sir, the hypopigmented lesions present for xanthoma.
Leukoplakia, one of the
Leukoplakia,
cause. That is why it is coming from the white patch, right? Leukoplakia. What are the causes?
Sir?
What are the causes of precancerous lesion? Bowen's disease.
Bowen's disease.
Keratoconus.
Keratoconus, actinic keratosis.
Senile keratosis, like that. There are so many conditions, right?
Okay, what's your final diagnosis, clinical diagnosis?
Proliferative growth on the left side of the leg.
Epithelioma or epidermal carcinoma is the clinical diagnosis. Squamous cell carcinoma, according to him, squamous cell carcinoma is a microscopic diagnosis.
Epithelium.
Some examiner will accept, some examiner will not accept squamous cell carcinoma. You must say epithelioma of the leg.
What are the points which made you to think of it's a malignant growth?
6 months duration. Base 6 months duration. Pre-malignant lesions present.
Yes.
Sun exposed area.
Hard in consistency, you told. Hard in consistency.
Hard in the consistency. Base indurated. Node.
Usually this tumor will touch and bleed. Here it is, according to you, it is not present. Then what about the edge?
Edge will be averted.
It is a pathognomonic for epithelioma. Edge will be. Edge சொல்லவே இல்லை. You are not mentioned about the edge. Very important.
Sir.
Right?
இல்லைம்மா நீ எட்ஜ் மென்ஷன் பண்ணவே இல்லையா அதான் கேட்குறேன்.
Sir, proliferative growth.
What is edge? What is edge?
Edge is the between margin and floor.
What is margin?
Margin is the junction between the normal epithelium and the abnormal tissue.
What is the floor?
Floor is the ulcer is.
Yeah.
Floor.
ஏம்மா அல்சர் பார்ட்ஸ் இது ஏம்மா குழப்பத்தில் இருக்க? The exposed part of the ulcer is called the floor.
On
The
which
structure on which the ulcer rests is called the base. மாற்றி சொல்கிறேன்.
Which one you can see? That's what you tell.
So floor, sir. Floor.
உன்னுடைய கேஸ் வந்து எட்ஜ் வந்து எவர்டடா இல்லையாம்மா?
இல்லை
அந்தாங்க
சார்
For epithelioma, right?
ஏம்மா வாட் ஆர் தி கிளினிக்கெலாம் என்னென்ன எட்ஜுமா இருக்கு? ஸ்லோப்பிங் எட்ஜ்.
ஸ்லோப்பிங் எட்ஜஸ் இஸ் seen in healing ulcer and venous ulcers.
அண்டர்மெண்ட் எட்ஜ் எங்கம்மா இருக்கும்?
Undermined in tuberculosis.
சரி.
Neuropathic and ischemic ulcers. Arterial ulcers.
முக்கியமான இது syphilis. Syphilis punched out appearance. Right?
அவன் சொன்னலாம் சரிதான். Trophic ulcer கரெக்ட், ischemic ulcer கரெக்ட், ப்ளஸ் சிபிட்டிக் ulcer கரெக்ட். சொன்னதான் கரெக்ட்.
rodent ulcer எப்படி இருக்கும்?
Sir, raised and beaded
Bearded
edges.
appearance. That's all. Right? So how will you proceed? It is a case of epithelioma. Right? First of all, what is epithelioma or squamous cell carcinoma?
It is the proliferation of the keratinocytes present in the prickle cell layer of the
Prickle cell. There is a tumor arising from the prickle cell layer.
of the skin, epidermis.
Otherwise called, what is the name of the
Spinosum,
stratum
spinosum.
very important. Few weeks will
நீ லேயர்லாம் சொல்லு, ஸ்கின் லேயர் சொல்லு, டாப்ல இருந்து பாட்டம் வரை ஸ்கின் லேயர் சொல்லு.
Corneum, lucidum, granulosum, spinosum, basal.
Basal. This is the epidermis. 5 layer. Dermis.
Papillary dermis, reticular dermis,
Epidermis.
subcutaneous.
So 7 layer. From with the 7 layer epidermis, prickle cell layer, it is arising. Prickle cell layer is otherwise called stratum spinosum. Right?
பேசல் காசம் எங்க இருந்து வருது?
Stratum basal.
மெலனோகார்சினோமா?
Sir?
மெலனோகார்சினோமா எதுல இருந்து வருது? எங்க?
Basal, sir. Neural crystals.
எங்கமா இருக்கு அது?
Sir?
எந்த லேயர்?
Melanocytes from basal, sir.
சரி எழுதிக்கப்பா. ஸ்குவாமஸ் S for S ஈஸியா ஞாபகத்துல வச்சுக்க. ஸ்ட்ராட்டம் ஸ்பைனோசம், ஸ்குவாமஸ் செல் கார்சினோமா. Then basal carcinoma, B for B. So basal layer. Basal layer இடையில வந்து நமக்கு வந்து melanocytes இருக்கு. So from the basal only you got melanocarcinoma. Melanocytes, where do they come?
Neural crystals.
Neural crystals. Migrate and settled in the skin. Right.
Okay, what are the investigation you do for this?
So melanin, what is the amino acid essential for melanin secretion? ஏலே சும்மா இருடா. இது பேர் தான் மேயற மாடு நக்கர் மாடு கெடுக்கிறவள, அமைதியா இரு. வாயை பொத்திட்டு அவள் நாளைக்கு பரீட்சை போய் பதில் சொல்லணும்ல. அவள் ப்ரெசென்ட் பண்ணுற அவளுக்கு சி மஸ்ட் கோ வித் சம் நாலேஜ். தெரியல. ஸோ டைரசின் டு டோப்பா டு மெலனின். எஸ்.
What are the investigation you do for this case?
I will do a edge-wedge biopsy of the lesion. More proliferative on the edges, representative of the growth. Edge will be the representative of the growth. Look for the grading.
Yeah, central layer இருக்கிறது.
Necrosis.
Yeah, necrosis. ஆமா தெரியணும்லம்மா.
Ischem.
என்னம்மா? ஏமா எதுக்கும் ஒரு 4 ஜோன் நீ போகணும்ல. ஸோ எட்ஜில் வந்து யூ காட் a good blood supply, சென்டர் வந்து blood supply இருக்காது, அவ்வளோதான்.
So you don't do edge biopsy, only wedge biopsy. It will contain normal tissue and malignant tissue. Right.
Other investigations.
What are the investigation?
X-ray local part.
X-ray of the local part.
X-ray chest.
Why local part X-ray?
Any bony involvement will alter the treatment.
Right, okay.
I will, the node is palpable, sir. So I look for ultrasound of the nodal basin, inguinal region, ultrasound of the inguinal region.
ஏமா அல்ட்ராசவுண்ட் பார்க்குற நோடு வந்து செகண்டரி நோடாக இல்லைன்னு பார்க்கணும்னா ஸ்ட்ரெயிட்டாகவே கோன் டு அன் FNAC.
Whether it is infective or
இல்லை வெயிட், ஐ வில் கிவ் ஆன்டிபயோட்டிக் ஃபார் 2 weeks. ஐ வில் ரிவ்யூ. ஏதாவது ஒரு பதில் சொல். அல்ட்ராசவுண்ட்னு சொல்கிறேன், அல்ட்ராசவுண்ட் பிரயோஜனப்படாது. Say, I see by clinically, do you think that is a second node infection? What is your suspicion?
Sir, node is mobile and firm, sir. It might be secondary node, infective node, sir.
அப்போ சொல்லு node, I suspect infection, I'll give antibiotic for 2 weeks, then I will review. If the persistent node is there, then you go for FNAC.
So primary, you have done biopsy. What could be the biopsy report?
We can, the grading of presence of epithelial pearls can be seen in well differentiated squamous cell carcinomas.
Squamous cell carcinoma not well differentiated.
Well,
number of cell list will be more.
What is well differentiated? What is poor differentiated?
Cell list will be
more than
it is
70.
well differentiated, right?
அதுக்கு என்னமா கிளாசிஃபிகேஷன்?
Borders classification.
படிச்சிருக்கா ஒழுங்கா சொல்லுமா. What is borders classification?
Grade 1 well differentiated, more than 75% keratin pearls present.
Well differentiated.
Grade 2 moderately differentiated, 50 to 75%. Poorly differentiated, 25 to 50%. Undifferentiated, less than 25%.
சரி ஒரு கை தட்டுப்பா, படிச்சிருக்கா, கை தட்டு. அவன் அதுக்கு தான் அந்த கேள்வி கேட்கும் நிற்கிறான். Right, okay.
Your epithelial pearls or cell nest will be present. You are convinced it is a squamous cell carcinoma. What are the conditions where the cell nest is absent in squamous cell carcinoma?
Mucosa.
In some of the squamous cell carcinoma, the cell nest
Lower
is
esophageal.
absent.
Lower esophageal carcinomas, squamous cell carcinomas.
Lower end of esophagus and arsenum of the bladder.
Yes, sir.
Here there is no peritoneal cell layer. That is why there is no cell nest formation in this area.
Okay.
Tell me the conditions where the cell nest is positive, even though they are not squamous cell carcinoma.
Cutaneous horn, keratoxanthomas.
Mixed parotid tumor and teratoma of the testis, where cell nest is positive, but they are not squamous cell carcinoma. Right? Sir, what is the treatment you are going to do? Biopsy report.
இருங்க, அதெல்லாம் இப்போ ஸ்பீச் லெவலில் கேட்குற இந்த கேள்விலாம் வேறு எங்கே வரும்? ஸ்கின்ல வருது, வேறு எங்கெங்கே ஸ்குவாமஸ் செல் கார்சினோமா வரும்லாம் கேட்பாங்க.
Lips, oral cavity, mucous membranes like anal canal, esophagus.
எங்கம்மா எனக்குன்னா கரெக்டாக சொல்லுவார். போஸ்ட் கிராஜுவேட் அதான் நான் கேட்குறேன். பட்ஜெட் ஃபெயில் ஆகிடுவாங்கப்பா, இல்லை நீங்கள் கட்டாயம் ஏழுக்கள் எங்கம்மா?
Below the pectinate line.
டென்டேட் லைன் மேலே புதுசாக நீ சொல்கிறம்மா. டென்டேட் லைன் ஏம்மா? டென்டேட் லைன் மேலே எங்கே, கீழே எங்கம்மா?
Below is keratinized squamous epithelium, sir.
Above?
Columnar.
So above இப்போ டென்டேட் லைன் கீழே வந்து ஸ்குவாமஸ் செல் கார்சினோமா, ஏனல் கனால். எக்டோடம், அது வந்து எண்டோடம். ரைட், வேற எங்கே வரும்? இல்லைம்மா, இதெல்லாம் ஸ்குவாமஸ் செல் கார்சினோமா.
Esophagus.
எங்கம்மா ஈசோஃபேகஸ்? இப்படி பொதுவாக கிளியராக போய் ஒரு போஸ்ட் கிராஜுவேட்டுமா. ஸோ ஸ்குவாமஸ் செல் கார்சினோமா வேறு எங்கே வரும்? மதர் பார்ட்ஸ் ஆஃப் த பாடி. ஸோ வேற ஸ்குவாமஸ் எப்படி? எங்கே? ஸ்கின்னு, ஓரல் கேவிட்டி, அப்பர் தேர்ட், மிடில் தேர்ட் ஆஃப் த ஈசோஃபேகஸ். தென் இந்த lower third may go for a metaplasia that you got a Barrett esophagus, so you may have a squamous cell carcinoma. அப்பதான் உனக்கு வந்து இந்த keratin pearls வந்து absent. புரியுதா? then வேற எங்க வரும்? below the anal canal, below the dentate line, you have squamous cell carcinoma. மறந்துட கூடாது. then you got there is your metaplasia where it may change in the renal pelvis,
respiratory epithelium. Respiratory epithelium.
then you have bronchus. So where it may get a metaplasia into a squamous epithelium, so patient will have a squamous cell carcinoma. PG எல்லாம் கேட்பாங்கப்பா, ஜாக்கிரதை. gallbladder, so gallbladder, urinary bladder, renal pelvis, and the lower of the esophagus. So where it may go for a squamous metaplasia will have a squamous cell carcinoma. Right, you said the inguinal node. You tell me the arrangement of inguinal node and the area which it drains. Inguinal node, you said vertical group. What is arrangement of inguinal node in the inguinal region?
There is superficial and deep inguinal nodes, sir. Superficial, there is suprolateral and supromedial and inferior. That is vertical group. Vertical groups drains the lower extremities and anal canal below the dentate line, and horizontal group is from peri.
See, strong. Era floor la era solla mudiyuma. Irma, you are wrong. Floor la. Ilma, you are wrong. Pesada. Vera solla mudiyuma pa. Ina inguinal node theriyanumda. Common வந்து நீ block decision பண்ண settle node biopsy பண்ற. What is arrangement of the inguinal group of lymph nodes? Floor la era பல் சொல்ல முடியுமா? முடியாது. Right. சரி எழுது. Vertical horizontal group and vertical group. Vertical drains the long saphenous territory of the lower limb. PG, undergraduate மாதிரி பல் சொல்லக்கூடாது. Long saphenous territory of the lower limb is drained by the vertical group of lymph nodes. Short saphenous territory is drained by the saphenopopliteal node. எங்கேயும் கிடையாது. saphenopopliteal. இப்போ நீ lateral malleus அல்சர் இருக்குன்னா PG வந்து பச்சை எங்கே சொல்லணும்? I am sensitive by lymph node the saphenopopliteal junctions தான் சொல்லணும். நீ வந்து இங்கேயும் சொல்லக்கூடாது. Then horizontal, medial, lateral. Medial, it drains your genitalia, anal canal below the dentate line. Anal canal below the dentate line. So genitalia, perineum, anal canal below the dentate line. Lateral half, It drains the area of the anteabdominal below the umbilicus plus gluteal region. So abdominal wall உடைய umbilicus க்கு abdominal wall drain பண்ணி எங்க lateral half of the inguinal group of members and gluteal region. இதான் arrangement. inguinal adenopathy இருக்கா எங்கங்க நீ சர்ச் பண்ணி பார்க்கணும். So the anal canal you have a melanoma. Melanoma வரலாம், squamous cell carcinoma ரெண்டுமே வரலாம். Yes.
What is Ferguson-Smith syndrome?
Sir, it is multiple squamous cell epitheliomas. It is an autosomal dominant disorder.
What is the importance of this?
It regress
that is very important.
regress spontaneously.
Squamous cell carcinoma will regress spontaneously. It is usually found in the New Scotland. Excellent.
What are the variants of the squamous cell carcinoma?
Verrucous.
ஏமா பிஜி தரமா படிச்சு வரணுமா எழுதிக்கிறா. So papillary type, then you got a spindle cell type, and then verrucous. These are the variants of your squamous cell carcinoma. பரீட்சையில் கட்டாயம் கேட்பாங்க, நீ சும்மா அண்டர் கிராஜுவேட் வேறு உனக்கு இதெல்லாம் கேட்பாங்க. So what is thing about your verrucous? You said verrucous.
Aggressive, it is a less aggressive tumor. It does not spread to the lymphatics.
Right, anybody in the floor? Verrucous carcinoma பத்தி என்னடா? Right, verrucous carcinoma no radiotherapy. எழுதிக்கோ. Squamous cell carcinoma will melt like a snow for radiotherapy. When you make it, it's a warty like growth. When you make a diagnosis of verrucous carcinoma, no radiotherapy. The treatment is only surgery. If you give radiotherapy, it become anaplastic. கொடுக்கவே கொடுக்கக்கூடாது. Then what is Majolin ulcer? Another type of Majolin ulcer. What is Majolin ulcer?
Develops in chronic scars, burns, chronic sinuses following osteomyelitis.
சொல்லக்கூடாது. Majolin ulcer. A chronic venous ulcer turning to malignancy is called Majolin ulcer. அதான் பதிலாக இருக்கணும். நீட்டில் அதான் நீட்டுக்கு எம்சிஎஸ் போனால் அதெல்லாம் கேள்வி. நீ ஸ்கார்லாம் மார்க் போட மாட்டான். A chronic venous ulcer turning to malignancy is called Majolin ulcer. மற்ற உள்ளுக்குள்ளே சேர்த்துக்கிட்டேன். இவன் சொல்கிற மாதிரி ஸ்காரில் வர்றது எல்லாம் அடிஷன். பட் வாட் இஸ் Majolin ulcer? A chronic venous ulcer turning to malignancy is called Majolin ulcer. What type of malignancy? Squamous cell carcinoma. Then இப்போ அடிஷனாக வந்து நீ ஸ்காரில் வர்றது பேட்ச் நீ கூட சேர்த்துக்கிற. So what is significant? What is the difference between the Majolin ulcer and squamous cell carcinoma?
Sir, no lymphatic spread,
Why?
sir.
Why?
Because scar.
TNM classification of squamous cell carcinoma.
Sir, current NCCN guidelines does not involve staging for squamous cell carcinoma other than head and neck, sir.
You are latest Bailey telling the TNM classification. You are telling not necessary. Latest Bailey they are given.
T1 less than 2 centimeter. T2 2 to 4 centimeter. T3 more than 4 centimeter with perineural invasion. T4 adjacent deep structures.
Node
N1 ipsilateral node less than 3 centimeter. N2A B C. N2A ipsilateral node more than 3 centimeter but less than 6 centimeter. N2B multiple ipsilateral node less than 6 centimeter. N2C contralateral node less than 6 centimeter. N3, any node more than 6 centimeter with extra
It is given in the
capsular.
latest Bailey. They have changed it. Previously only N1, N0 and N1. Now up to N1, N2, N3. 3 stages it is given.
What you are going to do for this case?
Do wide local excision of the lesion with 1 centimeter margin, circumferential and peripheral and deep margin of 1 centimeter. And assess the specimen. If margins are negative with frozen section, I will go for a split skin grafting of the area.
See
And
here,
nodal-
here what is the important structures present in this area?
Lateral malleolus.
In this area, it is in the anterior aspect, anterolateral aspect of the leg, right? Angle joint.
Extensor digitorum.
You must know the extensor retinaculum. What are the structures under cover of extensor retinaculum? You must know the structures, otherwise it is very difficult to do wide excision. Tell me the structures under cover of extensor retinaculum.
Tibialis anterior. Extensor digitorum longus. Anterior tibial artery.
There is extensor collis longus, doctor. Extensor collis longus tendon. Peroneus tertius, peroneus tertius, right? Tibialis anterior. Extensor collis longus tendon. Artery. Nerve. Then extensor digitorum tendon. And peroneus tertius. This is from medial to lateral. You must know the anatomy. Then only you can cut the structures with the 1 centimeter clearance. Usually, high risk patients 1 centimeter. If the low risk,
4 mm.
you can give 4 mm. 4 mm clearance is enough. According to the latest theory, 4 mm is enough for low risk individual. For high risk individual, 1 centimeter clearance to be done. Right? Here 1 centimeter clearance, because it is a leukoplakia there. You have to give 1 centimeter clearance. Okay. After that, what will you do for eye area?
Split screen grafting. If the paratenon is present, we can go for SSG, sir. Split skin grafting.
Split skin grafting, okay, right. For node?
For node, I will do inguinal block dissection.
The same sitting or you have to wait?
Not possible.
Sir,
you can
actually,
do blood
according-
dissection. Otherwise, you go to give antibiotic.
Pause.
See for the nature of the node. If it is subsided, leave it and observe the case. If it is not subsided, then do FNAC. If the FNAC is positive, go for block dissection. Right? What block dissection?
Modified superficial inguinal lymphadenectomy of catalones.
Modified?
Superficial inguinal lymphadenectomy.
இதம்மா அப்படின்னா என்னம்மா?
So the boundaries of dissection will be laterally femoral artery and inferiorly till the fossa ovalis and superiorly till the inguinal ligaments.
What are the structures you have to remove?
Superficial group of nodes. Usually all the fibrofatty tissue along with the usually the GSV should be
Great saphenous vein.
ligated
Don't.
and-
Okay. GSV. Great saphenous vein. Okay.
Great saphenous vein.
Saphenous vein. Okay.
great saphenous vein will be ligated.
What are the complications of inguinal node block dissection?
Flap necrosis of the lymphedema, femoral artery blowout.
Femoral artery? Blowout. Blowout.
ஃபஸ்ட்டு சரியாக இருக்கும்.
If your raw area showing tendons or periosteum, what will you do?
Perichondrium or if paratenon is preserved, we can put SSG, sir.
Okay, if it is it's not covered.
Oh, for flap.
Flap. What is flap? What is graft?
Flap is a piece of tissue, amount of tissue which retains its blood supply from the donor side, sir.
Here, what flap you can do is?
RS, reverse sural artery flap.
Cross-leg flap, simple.
Cross-leg
flap is enough.
What is random flap? What is axial flap?
Random flap does not have a long arterial supply base, sir. The axial flap has an long named artery for as its arterial supply, sir.
What is free tissue transfer?
It is the microanastomosis.
Yeah, that is called free flap.
The flap should be detached from the donor side and the microanastomosis of the vessels to be done with the recipient bed, sir.
Okay. What is the graft you know? You said what is the name of the graft?
Thiersch graft, split skin graft is called Thiersch graft, sir.
What is full thickness graft?
Ulfi's graft.
What is the name of the knife using for
Humphrey's knife. Watson's modification.
Where will you take the graft?
Thigh, over the ipsilateral thigh.
சரி, ஒரு லாஸ்ட் கொஸ்டின். வாட் ஆர் த கிளினிக்கல் டைப் ஆஃப் அல்சர்ஸ்? ஒரு வெளியே ப்ராக்டிஸ் பண்ண போகிறேன். கிளினிக்கல் டைப் ஆஃப் அல்சர்ஸ் என்ன உனக்கு தெரியும்?
ஸ்ப்ரெட்டிங் அல்சர், ஹீலிங் அல்சர், கேலஸ் அல்சர்.
ஸ்ப்ரெட்டிங் அல்சர் எப்படி இருக்கும்? ஹீலிங் அல்சர் எப்படி இருக்கும்?
Edges will be spreading ulcer, edges will be inflamed and edematous, and with the slough will be present with the purulent discharge. And healing ulcer, there will be granulation tissue will be present and edge will be sloping. Callus ulcer does not show any signs of healing.
இது என்னமா chronic ulcer?
Chronic
ulcer you will have a long duration, you will have a varicose vein or DVT. இதெல்லாம் உங்களுக்கு தெரியணும். Then another thing, you add malignant ulcer. Clinical, but even though it's not given the DAS, but the clinical type of ulcers are spreading ulcer, healing ulcer, chronic ulcer. That is சொல்ல வேண்டியது. You add a malignant ulcer. Malignant ulcer, you add a squamous cell carcinoma, basal carcinoma, and malignant melanoma. So clinical type of ulcer also you must know. Right.
DD for squamous cell carcinoma. Amelanotic melanoma is important. DD, amelanotic melanoma. Then keratoacanthoma, seborrheic dermatitis. These are the DD. How will you differentiate between amelanotic melanoma? Amelanotic melanoma, how will you differentiate?
Clinically, melanos.
DOPA positive. DOPA reaction is positive. Right. Okay.
DOPA reaction is சொன்னா போதும். ரைட். வேற ஏதாவது சந்தேகம் இருக்காப்பா? இருப்பா. சந்தேகம் இருக்கா ஏதாவது? தைராய்டெல்லாம் காமன் வைக்கிறது இதுவும் ஸ்கின்னு வந்து காமனாக வச்சுருவாங்க. தரவா ஏன்னா எக்ஸாமில் வந்து கட்டாயம் தைராய்டு இருக்கும், ஹேர்னியா இருக்கும், சிஎஸ் ஸ்டமக் இருக்கும்ல, பிரெஸ்ட் இருக்கும். அதெல்லாம் கொஞ்சம் தரவா படிச்சுக்கோங்க. பிரெஸ்ட்டு, வேரிகோஸ் வெயின், ஹேர்னியா, தைராய்டு, அப்சூட்டி ஜாண்டிஸ், சிஎஸ் ஸ்டமக்கு, ரைட்லி ஆஃப் மாஸ். ஏதாவது குழப்பம் இருக்கா, சந்தேகமாக இருக்கா, இதாக இருந்தால் கேட்டுக்கோ. ஸோ இப்போ வந்து சிஎஸ் ஸ்டமக் வந்து பார்த்தீங்கன்னா, even though it is advanced, you can do palliative gastrectomy, agree, accepted in the examination. CA colon, even though got a secondary, is palliative colectomy if it's operable. Primary அப்புறம் palliative colectomy பர்ச்சேஸ் சொல்லிக்கலாம். ஏதாவது சந்தேகம் இருக்கா கேட்டுக்கோ. ஒரு 5 minutes செய்யது ஒரு 5 நிமிஷம் எடுத்துக்கிறோம்ப்பா. சந்தேகம் இருக்கா? பிஜிஸ்க்கு சந்தேகம் இருந்தால் கேட்டுக்கோ, குழப்பம் வரக்கூடாது. தென் இப்போ வந்து எல்இபிசியில் வந்து லோக்கல் அட்வான்ஸ் பேசிக்கஸ் என்ன இன்வெஸ்டிகேஷன் பண்ணணும்னு கேட்பாங்க. என்ன இன்வெஸ்டிகேஷன் பண்ணுவீங்க? எல்இபிசி. யூ டெல் மீ தி இன்வெஸ்டிகேஷன்.
Down stage the disease.
இல்லைடா, எல்இபிசியில் வந்து என்ன இன்வெஸ்டிகேஷன் பண்ணுவான்னு கேட்பான் எக்ஸாமில். ஒய் சும்மா சொல்கிறா, அது ஒன்றும் கிளாஸ் ரூம் மாதிரி இல்லை, ஏன்டா சாதாரணமாக பேசு, அதெல்லாம் வேண்டாம்டா. என்ன கோர் நீடில் பயாப்சி, கோர் நீடில் பயாப்சி எல்ஏபிசி வந்து நீ சொல்ல வேண்டிய பட்சம் வந்து கோர் நீடில் பயாப்சி. ஏன்டா கோர் நீடில் பயாப்சி?
Neoadjuvant chemotherapy. Post-op chemotherapy, if it is, shows response in the preoperative.
என்னடா எதுக்குடா கோர் நீடில் பயாப்சி பண்ணுற?
ERBR
பயாப்சிங்க பாரு, எஃப்என்ஏசி பண்ணுற அப்படின்னா எஃப்என்ஏசி நீ பண்ணால் உனக்கு வந்து ஒன்லி இதுக்கு டிஷ்யூ டயக்னோசிஸ் கிடைக்காது, ஹார்மோனி பார்க்க முடியாது. ஏன் அப்படின்னா நீ வந்து கோரனில் இதுக்கு எல்ஏபிஸ்க்கு வந்து நியோஜன் கீமோதெரபி கொடுத்துருவேன், கொடுத்தா டீமெல்லாம் காணாமல் போயிடும். காணாம போன அப்புறம் ஸ்பெசிமே இருக்காதா தம்பி, இதெல்லாம் பிஜி கேள்வி. வேற நீ எர்லி பஸ் கேன்சர் எஃப்என்ஏசி எடுத்துகிட்டு இந்த டியூமர் வந்து ஒய்டெக்ஸிமன் இப்போ அங்கே டியூமர் இருக்கும், ஸ்டடி பண்ணலாம், ஹிஸ்டாலஜி பார்க்கலாம், இதுக்கு ஆபீஸ் இங்கே இருக்காது. இதான் கேள்வி. கோர்னியல் பயாப்சி வந்து என்ன விஷயம் போனால் நீ பதில் சொல்ல வேண்டிய கேள்வி வந்து கோர்னியல் பயாப்சி, இதான் பதில். ஏதாவது சந்தேகம் இருந்தால் கேட்டுக்கோ. செஷன் இஸ் கோயிங் டு பி க்ளோஸ். சையது வந்து காலேருந்து உட்காந்து ரொம்ப களைப்பாக இருக்கா, ஆளை பார்த்தா ரொம்ப டயர்டாக இருக்கா. சைதுக்கெலாம் கைதட்டுங்கிறாட்டே, ஒரு கைதட்டு, ரொம்ப களைப்பாக இருக்கா. ரைட், ஏதாவது சந்தேகம் இருக்காடா தம்பி? ரைட், ஓகே, தேங்க்யூ, விஷ் யூ ஆல் தி பெஸ்ட். பரிச்சை எப்பப்பா? மார்ச்சா? ஸோ ஆன் பிஹாவ் ஆஃப் தி சார், சாரி மேல தானே பரிச்சை. On behalf of your